where are they situated exactly. So foregut is from esophagus to duodenum at the level of pancreatic duct and common bile duct insertion, that is ampulla of Vater in the second part of duodenum. Midgut is from the lower duodenum to proximal two-third of the transverse colon. So if this is the transverse colon, here is the proximal two-third. Till here it is midgut, and from here it is hindgut. So hindgut is distal one-third of transverse colon to anal canal above the pectinate line. Okay, and the midgut, sixth week of development, physiological herniation of midgut through umbilical ring. If this is the umbilical ring, the midgut has to herniate. Midgut herniates out of the umbilical ring, and at 10th week of development, it returns back to the umbilical cavity, and then it rotates around the superior mesenteric artery, which is total of 270-degree counterclockwise rotation. So if it herniates out of the umbilical ring at 6th week of development, at 10th week it returns back to the abdominal cavity, and then it rotates around the superior mesenteric artery 270-degree. Okay, so this is 270-degree rotation. And if this does not rotate completely or does not rotate at all, we will have malrotation. Okay, and initially the cecum is at the left lower quadrant. If this is the abdomen, this is left side, this is right side. In adults the cecum is at right side, okay, right lower quadrant, right? So but initially the cecum is present at the left lower quadrant. Then, and the duodenojejunal junction is at the right side of the midline. If this is the midline, initially the duodenojejunal, the DJ junction, is on the right side of the midline. So now what happens is the cecum rotates to the right side of the abdomen, that is to the right lower quadrant, and duodenojejunal junction crosses the midline and moves to the left side of the to the left side of the abdomen. So now in adults it is like this, right? Duodenum, and this is jejunum. So here is the duodenojejunum junction. Okay. Now the ventral wall defects. These are the developmental defects due to failure of rostral fold closure. That is sternal defects, which will cause ectopia cordis. If it is lateral fold closure, it will cause omphalocele or gastroschisis, or if it is caudal fold closure, it will cause bladder extrophy. Okay, this is the rostral fold. These are the lateral folds, and these are the caudal folds. If the rostral fold closure is incomplete, it will cause ectopia. What is that? Yeah, ectopia cordis. So the heart will be outside the body, will be outside the thoracic cavity, and that fetus is not viable. Laterals are omphalocele and gastroschisis, and caudal folds are bladder extrophy. Now we'll see the differences between gastroschisis and omphalocele. So the gastroschisis is extrusion of abdominal contents through abdominal wall defect, which is at the right of the umbilicus. The extrusion of umbilical contents is not through the abdominal contents is not through the umbilicus, but it is from the right side of the umbilicus. It is a defect in abdominal wall. It is not a defect in umbilicus. See, this will be confusing when you are solving questions that what is gastroschisis and what is congenital umbilical hernia. So umbilical hernia will herniate from the umbilicus, right? And the gastroschisis is going to herniate on the right side of the umbilicus, that is from abdominal wall. Okay, and the coverage of gastroschisis is, it is not covered by anything. It is not covered by peritoneum or amnion. You can see here the abdominal contents is just outside the body without any covering, and the guts come out of the gap in the letter G. Okay. Association, it is not associated with chromosomal abnormalities unlike omphalocele, so it has good prognosis. Gastroschisis G, good prognosis G. And omphalocele is herniation of abdominal contents through umbilicus. Okay, and it is covered by peritoneum and amnion. So now the omphalocele will be confusing. You will be confusing omphalocele with congenital umbilical hernia, because in omphalocele it is covered by peritoneum and amnion, but a congenital umbilical hernia is covered by skin. Right, and they both will be arising from the umbilicus. So you have to differentiate all these three conditions. Like gastroschisis, there will be no covering, there will be no peritoneum or no amnion. That will be gastroschisis, and it will be in the right side of the umbilicus. And omphalocele, it will have covering of both peritoneum and amnion, and it will herniate through the umbilicus. But the umbilical hernia will have covering of skin. Okay, that is how you differentiate all three of them. And omphalocele, abdominal contents are sealed in the letter O. Okay, and it is a shiny gray sac. Here you can see it is a shiny gray sac, and it is associated with congenital anomalies like trisomies 13, 18, Beckwith-Wiedemann syndrome, and other structural abnormalities, cardiac, GU, and neural tube defects. And this is another point of differentiation between omphalocele and umbilical hernia. Omphalocele is associated with trisomies 13 and 18, whereas the umbilical hernia is associated with trisomy 21, that is Down syndrome. Down syndrome does not cause omphalocele, but it causes umbilical hernia. So now we'll see umbilical hernia. It is failure of umbilical ring to close after physiologic herniation of midgut. Right. So after the we discussed that at 10th week of development, the herniated abdominal contents goes back into the abdomen, and then the umbilical ring is closed. So now if there is failure of umbilical ring closure, there will be umbilical hernia. So there will be herniation of midgut whenever it wants to, right? Because normally the umbilical ring has to close to keep the abdominal contents inside the abdomen. Okay, and it protrudes with increased intra-abdominal pressure like crying, and it may be associated with congenital disorders like Down syndrome, congenital hypothyroidism, and small defects usually close spontaneously. Okay, and these two conditions, the above two conditions, omphalocele and gastroschisis, they can be diagnosed intranatally. Okay, and but the congenital umbilical hernia can only be diagnosed postnatal clinically. Okay, and one more thing is that alpha fetoprotein will be elevated in both gastroschisis and omphalocele, maternal alpha fetoprotein, because the viscera is in communication with the amniotic fluid. It causes elevated alpha fetoprotein, right? Now one more thing, you have to remember all the pathologies. Not just remember, but you should be able to differentiate all the pathologies. Look, the GI system's most important questions are based on the differentiation of pathologies between the diseases, right? So what is the pathology behind the ventral wall defects? It is due to the failure of rostral fold closure, and the gastroschisis is due to extrusion of abdominal contents through abdominal wall defect, and it is the omphalocele is herniation of abdominal contents through umbilicus. Right. And umbilical hernia is failure of umbilical ring to close after physiologic herniation of midgut. That you have to keep in mind. Now, tracheoesophageal anomalies. So, esophageal atresia with distal tracheoesophageal fistula is the most common and often presents as polyhydramnios in utero due to inability of fetus to swallow amniotic fluid, because the esophageal atresia is there, so the amniotic fluid cannot enter stomach from esophagus, so it reverts back from mouth into the amniotic fluid cavity. Okay, so there will be polyhydramnios in utero. And neonates drool, choke, and vomit with first feeding. This is the point to remember, that the neonates drool, choke, and vomit with the first feeding. It's not like this disease develops after 1 week or 2 weeks, or like other conditions do. Uh, you can see tracheoesophageal anomalies with the first feeding itself. And TEFs allow air to enter stomach if there is a fistula between the trachea and esophagus distally, which is visible on chest X-ray. Cyanosis is secondary to laryngospasm to avoid reflux-related aspiration. And clinical test is failure to pass nasogastric tube into the stomach. So in pediatric in labor rooms, the pediatrician at birth passes nasogastric tube to check for tracheoesophageal anomalies. If the nasogastric tube can reach stomach, the child is normal, and if the nasogastric tube is not able to reach stomach, it is obstructed midways. It is tracheoesophageal fistula. Okay. And yeah, in H type, the fistula resembles the letter H, and in pure esophageal atresia, chest X-ray shows gasless abdomen. Okay, let's see. So if this is the normal, the gastric bubble is small, if you can see. And in pure esophageal atresia, there is no fistula between trachea and esophagus. See, there is no fistula here, and there is just esophageal atresia, and so there will be gasless stomach, okay, because there is no fistula. And in H type, there is fistula between both of them, and then there is so there will be prominent gastric bubble, because the air from trachea enters esophagus and then stomach. And this is the most common type, the proximal esophageal atresia and distal tracheoesophageal fistula. So here you can't pass nasogastric tube through this point, and the air from trachea enters esophagus, causing a giant prominent gastric bubble. And also, what is the pathology of this tracheoesophageal anomalies? It is the failure of primitive foregut to separate from airway. Right, the primitive foregut forms esophagus, and it is the inability of primitive foregut to separate from airway. Okay, let me just write that down so that I remember it too. Is failure of primitive foregut to separate from airway. And the neonate drools, choke, and vomit. It goes without saying that the vomit is not coming from the stomach itself. It is just coming from the first feeding that we just gave. So it goes without saying that the vomit is non-bilious. Okay. If the vomit is bilious, we have to consider other conditions like duodenal atresia, jejunal atresia, all those conditions. And they will not present with the first feeding itself. It will present like 1 or 2 days later after birth. Okay. And what is the reason of the esophageal atresia, the esophagus not being formed properly? It is the failure of dorsal and ventral foregut to separate. So these are all UWorld annotations, okay, that I've just annotated into my first aid, and then I'm just writing it here for you guys. Now intestinal atresia. It presents with bilious vomiting, as I just said. The TEF does not present with bilious vomiting, but the intestinal atresia does, and there is abdominal distension within the first 1 to 2 days of life. Duodenal atresia, it is failure to recanalize. Is the failure to recanalize. And the X-ray shows double bubble sign. The first bubble is due to the dilated stomach, and the second bubble is due to the proximal duodenum. And it is associated with Down syndrome. Sorry. And why is the failure of recanalized forms duodenal atresia, causes duodenal atresia? Because let's see, the duodenum is like is a closed lumen. It has a closed lumen. It does not have lumen at all, I mean. And then it recanalizes, forming a tube that has lumen, that is duodenum. So it is failure to recanalize which causes duodenal atresia. But that is not the reason jejunal or ileal atresia occurs. The jejunal and ileal atresia occurs because of the disruption of mesenteric vessels due to ischemia, that is typically superior mesenteric artery, ischemic necrosis of fetal intestine. There is segmental resorption and bowel becomes discontinuous. X-ray may show triple bubble sign. The third bubble is for the proximal jejunum and a gasless colon. It is associated with cystic fibrosis. It may be caused by maternal cigarette smoking or use of vasoconstrictive drugs, cocaine. So cocaine is vasoconstrictive. It will constrict smooth superior mesenteric artery, which will cause ischemic necrosis of the fetal intestine, which will cause segmental resorption. And it is also associated, jejunal and ileal atresia is also associated with gastroschisis. And there is another term called apple peel atresia. So it is jejunal atresia plus ileum looping around superior mesenteric artery. So UL has a really great diagram of apple peel atresia. It is also called Christmas tree atresia. And these both conditions will present at 1 to 2 days of life. Now, hypertrophic pyloric stenosis. It is the most common cause of gastric outlet obstruction in infants. And I guess the most common cause of gastric outlet obstruction in adults is gastric cancer, which is in antrum or pylorus area. I'm not sure about it, but just look it up. And it has palpable olive-shaped mass in epigastric region, visible peristaltic waves, which has good strength. These peristaltic waves, which are visible in hypertrophic pyloric stenosis, are very strong. And non-bilious projectile vomiting, because it is coming from stomach, right? So it will be non-bilious, and it occurs at 2 to 6 weeks old. So it is more common in firstborn males, associated with exposure to macrolides, mostly erythromycin. And it results in hypokalemic, hypochloremic metabolic alkalosis. And it is secondary to vomiting of gastric acid. So gastric acid is vomited out, H plus is lost, so it will cause increased concentration of bicarbonate, which will cause metabolic alkalosis and subsequent volume contraction. Because of vomiting, there is loss of blood volume, there is loss of body volume. To compensate that, RAS system will get activated, renin-angiotensin-aldosterone system will get activated, and the aldosterone will cause increased sodium absorption and increased potassium excretion, which will cause hypokalemia. So all of them together causes hypokalemic, hypochloremic metabolic alkalosis. And the ultrasound shows thickened and lengthened pylorus. The treatment is surgical incision of pyloric muscle, which is called pyloromyotomy. Now, pancreas and spleen embryology. Pancreas is derived from foregut, and ventral pancreatic bud contributes to the uncinate process, which is this one. And both ventral and dorsal buds contribute to pancreatic head and main pancreatic duct. So you can see this is the pancreatic head. Ventral and dorsal, both the buds are contributing to the pancreatic head and the main pancreatic duct. This one is the main pancreatic duct. Yeah. And annular pancreas is the condition where there is abnormal rotation of ventral pancreatic bud with forming a ring of pancreatic tissue, and it encircles the second part of duodenum, and it may cause duodenal narrowing and vomiting, and it is associated with Down syndrome. So what happens is ventral pancreatic bud is initially here, and it is supposed to go behind the duodenum and then fuse with the dorsal pancreatic bud. But now in annular pancreas, the ventral pancreatic bud encircles the duodenum like this, and so there is duodenal obstruction, which is causing vomiting, and it is associated with Down syndrome. And pancreatic divisum is ventral and dorsal parts fail to fuse at 7 weeks of development. So the ventral bud appears at around 5th week, and then it fuses with the dorsal part at around 7 weeks. So they fail to fuse, causing pancreatic divisum, and it is a common anomaly, mostly asymptomatic, but it may cause chronic abdominal pain or recurrent pancreatitis. There are recurrent cases of pancreatitis in the patient of pancreatic divisum. And the spleen arises in mesentery of stomach, hence it is mesodermal, but it has a foregut supply. So this is a very important detail about which you will loves to ask questions, that spleen is a mesodermal organ, mesodermal origin, but it has a foregut supply through celiac trunk and splenic artery. And here you can see the annular pancreas. Okay. The annular pancreas is somewhat encircling the second part of duodenum, so you can see the narrowing of the lumen of the duodenum. And there's also accessory pancreatic duct within the pancreas, which opens into the minor papilla, and the main pancreatic duct opens into the major papilla in the second part of duodenum. Now the retroperitoneal structures. Retroperitoneal structures are posterior to and outside of the peritoneal cavity, and injuries to the retroperitoneal structures can cause blood or gas accumulation in the retroperitoneal space. So this is a good mnemonic to remember the retroperitoneal organs like sad pucker, suprarenal glands, which is adrenal glands, then aorta and IVC, and duodenum, second through fourth part. The first part of the duodenum is intraperitoneal, second, third and fourth parts are retroperitoneal. Pancreas, except the tail is intraperitoneal. Ureters, colon, descending and ascending, the transverse colon is intraperitoneal. Kidneys, esophagus, only the thoracic portion. The abdominal portion is again intraperitoneal, and rectum, which is partially retroperitoneal. And these the organs which have exceptions, like the duodenum, the second through fourth part, pancreas, descending and ascending colon, and the rectum partially, they all are secondary retroperitoneal organs. So what is secondary retroperitoneal organs? They have lost their mesentery during development, and they are in front of primary retroperitoneal organs. So let me just tick mark which ones are secondary retroperitoneal. So first these duodenum and pancreas, then colon, and then rectum. These are secondary retroperitoneal organs, and others are primary retroperitoneal organs. So primary retroperitoneal organs, they never had a mesentery, so they were retroperitoneal from the beginning, but secondary retroperitoneal lost their mesentery during the development, during the embryological development, and hence are secondary retroperitoneal, and they are in front of primary retroperitoneal organ. Secondary retroperitoneal organs are in front of primary retroperitoneal organs. Okay, and this is a CT scan. You have to look at other abdominal CT images too, because there are many questions regarding the abdominal where there will be abdominal CT scan given, and you will have to figure out the pathological organ from the question stem. So this is descending colon, this is left side. Okay, whenever you are reading a CT scan, the sides are always reversed. If this is your right side, then this is the left side of the CT scan, they are inversed. This is ascending colon, this is aorta, this is IVC, and right kidney, left kidney. If we go further above, like further above in the upper quadrants of the abdomen, there will be liver here and spleen somewhere here. There will be, you can see portal vein, splenic vein, and everything like that. And the aorta is just above the vertebral body. That is how you differentiate aorta. And just right and little above to it is IVC. And if there is esophagus, there it will be in thoracic CT, it will be somewhere. No, not here. Here it will be trachea, and somewhere here will be esophagus. Yeah. And you can see trachea. You can differentiate trachea as there will be air inside the trachea, so it will be pitch dark like this. Now the important gastrointestinal ligaments. So these are pretty easy. You can differentiate them from their name itself. Like if it is falciform ligament, it is from liver to the anterior abdominal wall. If it is hepatoduodenal ligament, here is the hepatoduodenal ligament. It connects hepato, liver, and duodenum. Then there's hepatogastric, which connects liver to the lesser curvature of stomach. Then there's gastrosplenic, from greater curvature of stomach to the spleen. Then there's gastrocolic, it connects stomach to the transverse colon. And this is falciform ligament, it connects liver to the anterior abdominal wall. Okay, so falciform ligament, it connects liver to the anterior abdominal wall, and structures contained are ligamentum teres hepatis, which is derivative of fetal umbilical vein, and patent para-umbilical veins, and it is derivative of ventral mesentery. Anything that is related to the liver, like falciform ligament, hepatoduodenal ligament, hepatogastric ligament, they all are derivative of ventral mesentery. And anything that is related to stomach, like gastrocolic, gastrosplenic, they are derivative of dorsal mesentery. Then there's hepatoduodenal ligament, which connects liver to the duodenum, and it contains very important portal triad. Portal triad has proper hepatic artery, portal vein, and common bile duct. One of everything, one artery, that is hepatic artery, one vein, that is portal vein, and one duct, that is common bile duct. And the Pringle maneuver, where ligament is compressed manually or with a vascular clamp in omental foramen. So here is the omental foramen. There is foramen through which you can go from greater sac to lesser sac, I think. And It is compressed manually or with a vascular clamp in omental foramen to control the bleeding from hepatic inflow source, that is portal vein or hepatic artery, versus outflow, that is hepatic vein or IVC. So if you compress the portal triad and the bleeding stops, you can infer that the bleeding site was either portal vein or hepatic artery, and if the bleeding still continues, the bleeding was from hepatic veins or IVC. And hepatoduodenal ligament borders the omental foramen, which connects the greater and lesser sacs, and it is a part of lesser omentum. So anything above the stomach here, it is part of lesser omentum, and anything that is here on the which connects the greater curvature is part of greater omentum. Okay, now is hepatogastric ligament. It connects liver to the lesser curvature of stomach. It contains gastric vessels. You will see the gastric vessels, which is the left gastric artery and all that. It is left gastric artery is somewhat here, and right gastric artery is somewhere here. So it is contained by hepatogastric ligament, and it is derivative of ventral mesentery because it is derivative of from liver. So it is ventral mesentery. It separates greater and lesser sacs on the right. This is the right side. This is the right side, and this is the left side. It is separating the greater and lesser sacs on the right side. Okay, and it may be cut during surgery to access the lesser sac. Okay, and it is a part of lesser omentum. So lesser sac is beneath these whole ligaments. When you tear open these ligaments, you can get access to lesser sac, and then you can access retroperitoneum. And and so what does lesser sac have? Everything. What does lesser sac contain? Lesser sac contains portal triad and the gastric vessels. So here is the lesser sac. If you open it up, you will have access to portal triad, gastric vessels, and the retroperitoneum. And now the gastrocolic ligament. It connects greater curvature to transverse colon, and it contains gastroepiploic arteries. So somewhere over here there is a left gastroepiploic artery, there is right gastroepiploic artery, and there's anastomosis between them. And yes. Yeah. So that is contained by the gastrocolic ligament, and it is derivative of dorsal mesentery. Right, I told you guys anything that is related to the stomach, it arises from the dorsal mesentery, and it is a part of greater omentum because it is connecting the greater curvature of the stomach to the colon. Now there's gastrosplenic ligament. It connects greater curvature to spleen, and it has short gastric vessels and left gastroepiploic vessels. Short gastric arteries, that is the branch of splenic arteries. It is contained by gastrosplenic ligament, and it is also derivative of dorsal mesentery. It separates greater and lesser sacs on the left. So greater and lesser sacs are separated on the right by hepatogastric ligament, and it is separated on the left by gastrosplenic ligament. Okay. Here greater and lesser sac is separated by hepatogastric ligament, and here greater and lesser sac are separated by the gastrosplenic ligament. And last is splenorenal ligament. It connects spleen to the left pararenal space. It contains splenic artery and vein, and also tail of pancreas. So it is derivative of dorsal mesentery. So it contains tail of pancreas. So now if there is a pancreatic surgery, it poses a risk to the damage of splenic artery. Okay, so if there is pancreatic surgery happening, there is always a risk of rupture of splenic artery because it is in communication with the tail of pancreas. If you want to see the lesser and greater sac, the yellow part in this diagram, is lesser sac, and all the orange part, that is this, that is greater sac. Okay. Now the digestive tract anatomy. So we'll see the layers of the gut wall. Inside to outside, it is MS, mucosa, submucosa, muscularis. It is mucosa, submucosa, muscularis externa, and serosa. Muscularis externa, or just muscular layer. It is a layer of smooth muscle. And mucosa contains epithelium, lamina propria, and muscularis mucosa. So here it is. There is epithelium, there is lamina propria, and muscularis mucosa. Okay. Then there is submucosa, which contains submucosal nerve plexus, that is Meissner's nerve plexus. So there is 2S, so it secretes fluid. And in muscularis layer, there is mesenteric nerve plexus, so it is M. So it is responsible for the motility, because it is smooth. As I told you, the muscularis layer is a layer of smooth muscle, so it is responsible for the motility. And serosa when it is intraperitoneal, and adventitia when it is retroperitoneal. And ulcers can extend into submucosa, inner or outer muscular layer, and erosions are just in mucosal layer only. So mucosa, the erosions are just in the mucosal layers, but if there is ulcer, it can extend up to submucosa or even muscular layer. So if this is the muscularis layer, erosions can occur, ulcers can occur up to the muscularis layer. Also, muscularis has inner circular layer and outer longitudinal layer, and between both of those layers there is mesenteric nerve plexus, which is responsible for the motility. Then there's tunica muscularis and tunica serosa. It's just the muscularis externa and the serosal layer. And the adventitia is also present in the esophagus, thoracic esophagus. There is no serosa present, okay, in esophagus. And submucosa has very important Brunner's gland. And the frequency of basal electric rhythm, that is slow waves, it originates in the interstitial cells of Cajal, and the speed of the frequency of the electric rhythms is the highest in duodenum, then in ileum, and then in stomach. So that these interstitial cells of Cajal are responsible for the depolarization and repolarization of smooth muscle cells in the intestines. It is called the enteric nervous system. Now the esophagus has a non-keratinized stratified squamous epithelium. In the upper 1/3 is striated muscles, and middle and lower 2/3 are smooth muscles with some overlap at the transition. Okay. So upper 1/3 is striated muscle, and middle and lower 2/3 are smooth muscles. And stomach has gastric glands, parietal cells are eosinophilic. So this is the parietal cell. You can see it is very pink, eosinophilic. It is very eosinophilic. And the chief cells are basophilic. That is this. You can see the difference between both of this. It is eosinophilic, that is there are parietal cells, and the basophilic, that are chief cells. Okay. And duodenum has villi and microvilli, which increases the absorptive surface. It has Brunner glands, bicarbonate secreting cells of submucosa. So it neutralizes the acid secreted by the parietal cells. It has crypts of Lieberkühn and it contains stem cells that replace enterocyte, goblet cells, and Paneth cells that secrete defensive lysozyme and tumor necrosis factor, and plicae circularis that is in distal duodenum. Okay. So what all does it have? It has first of all Brunner's gland. There are bicarbonate secreting cells. Then there is crypts of Leberkuhn. It contains stem cells. Then there are Paneth cells that secrete defensive lysozyme and TNF. So it has immunological function. And then the last is plicae circularis, that is in the distal duodenum. Now jejunum has villi, crypts of Leberkuhn, and plicae circularis, but the plicae circularis are taller and more prominent and more numerous versus the ileum, and it has feathered appearance with oral contrast and increase the surface area of jejunum. Okay, so it has everything the duodenum has except the Brunner's gland. Brunner's gland are very unique to duodenum. It has villi, crypts of Leberkuhn, and plicae circularis. And ileum has villi and pair patches. They are unique to ileum. They are lymphoid aggregates in lamina propria, which is a part of mucosa and submucosa. And there are plicae circularis as in duodenum and jejunum, but they are not very prominent. And then there is crypts of Leberkuhn and largest number of goblet cells in small intestine. Okay. So there is Peyer's patches, which is lymphoid aggregate, and if there is lymphoid hypertrophy, there is Peyer patches hypertrophy. It can lead to it can cause a lead point, causing intussusception and everything. Okay, and then in colon there is crypts of Leberkuhn with abundant goblet cells, but there is no villi in colon. Let's look at the images. See, these are the gastric glands. Okay. We saw the parietal cells and the chief cells. Parietal cells are eosinophilic and chief cells are basophilic. Then these are villi of the duodenum. If there is villus atrophy, it will look like this. That we'll see in celiac disease, there is villus atrophy and the crypt hyperplasia of the crypts. So these are the crypts. Okay. So these are the crypts. Then there is ileum. There is lymphoid aggregates called Peyer patches. So this is the Peyer's patches. Okay, and this is the colon where you can see there is no villi. There is no villi. And yeah, one more thing. Peyer's patches also have M cells, which is used in the pathogenesis of Shigella. We'll see that later on. Okay, it's all right. Now the abdominal aorta and its branches. 1 second. Abdominal aorta and its branches. So arteries supplying the GI structures are single and they branch anteriorly, like the celiac artery, superior mesenteric artery, inferior mesenteric artery. You can see they are all branching anteriorly. In arteries supplying non-GI structures like phrenic arteries, suprarenal, renal arteries, they are all laterally and posteriorly, and they are paired. They arise from both the sides. And two areas of the colon have dual blood supply. From distal arterial branches that are watershed regions susceptible in colonic ischemia. It is splenic flexure, superior mesenteric artery and inferior mesenteric artery, and second is rectosigmoid junction, and the last sigmoid arterial branch from the IMA and superior rectal artery. Okay, so whenever there is colonic ischemia due to hypotension or any hypotension shock, any thrombotic event, any embolic event, okay, that will cause colonic ischemia, and both of these regions will be more susceptible to it. So now let's see the arteries emerging from the aorta. So first is celiac artery. It arises at T12. Then there is SMA L1, at IMA at L3, and at L4 there is bifurcation. The bifurcation of aorta is at L4. It gives rises to right common artery and left common artery, which will give rise to internal iliac and external iliac. Then there's inferior phrenic artery and superior suprarenal artery, that is superior adrenal artery. Both of them are rising at the T12 level together. And then there is middle suprarenal, which is also at the level of T12 and somewhat L1, between the junction of T12 and L1. And the renal and inferior suprarenal both are arising together from L1 L2 junction, and gonadal artery arises below it from L2 junction. Okay. So T12, L1, L2. Superior suprarenal, middle suprarenal, and inferior suprarenal. Okay. Now, nutcracker syndrome. There is compression of left renal vein between the superior mesenteric. In nutcracker syndrome, there is compression of left renal vein between the superior mesenteric artery and the aorta. It may cause abdominal pain, gross hematuria from rupture of thin wall renal varicosities and left-sided varicocele. So if here is the renal vein going into the inferior vena cava, it is compressed by the superior mesenteric artery and the aorta itself. That will lead to increased pressure in the left renal vein, causing left-sided varicocele and abdominal pain and hematuria. And in superior mesenteric artery syndrome, it is characterized by intermittent intestinal obstruction symptoms like primary postprandial pain and increased nausea in prone position. When superior mesenteric artery and aorta compresses the transverse third portion of the duodenum, and it typically occurs in conditions associated with diminished mesenteric fat like low body weight, malnutrition, and generally when there is sudden loss of weight, like in cancer or after bariatric surgery, or in hypermetabolic states like in burns, shock, everything like that. Where there is quick weight loss, there will be superior mesenteric artery syndrome. Okay, so generally the superior mesenteric artery forms an angle of 45 degree with the aorta, and here there is duodenum. So and here is the fat pad. So if there is reduced fat, the superior mesenteric artery will now compress the duodenum, the third part of duodenum. And also I want to discuss the structures passing through the diaphragm. Like at the T8 level, there is IVC and right phrenic artery. At T10, there is esophagus and vagus nerve. At T12, there is aorta, thoracic duct, and azygous vein. So I ate 10 eggs at 12. So I is inferior vena cava at T8. At T10, eggs, which is short for esophagus and vagus. And at T12, A is for aorta and T is for thoracic duct. At 12, at T12. Okay. Now we'll look at the gastrointestinal blood supply and innervation. So foregut is supplied by celiac artery. Midgut is supplied by superior mesenteric artery, and hindgut is supplied by inferior mesenteric artery. And parasympathetic innervation for foregut and midgut is vagus, and for hindgut it is pelvic splanchnic nerves. Okay, pelvic splanchnic nerves. This is parasympathetic innervation. So what will be the sympathetic innervation? So sympathetic innervation for foregut is greater splanchnic nerve, and for midgut it is lesser splanchnic nerve, and for hindgut it is lumbar splanchnic nerve. Okay, let me just write it. Greater splanchnic, lesser splanchnic, and lumbar splanchnic. So these are preganglionics. Okay, so postganglionic has celiac in foregut, superior mesenteric artery ganglion in midgut, and inferior mesenteric ganglion in hindgut. But I am not writing that down because you can remember the postganglions by remembering the artery. If the foregut is supplied by celiac artery, so the postganglion will be celiac ganglion. SMA, so postganglionic will be superior mesenteric ganglion. Here the hindgut is supplied by inferior mesenteric artery, so the postganglion will be inferior mesenteric ganglion. And the vertebral level is T12 to L1 in foregut, L1 in midgut, and L3 in hindgut. Which are the structures supplied by the foregut supply? Pharynx is only supplied by vagus nerve in lower esophagus. Celiac artery only to proximal duodenum, liver, gallbladder, pancreas, and spleen. So we talked that spleen is a mesodermal organ, but it is supplied by the foregut arteries. And midgut includes distal duodenum to proximal 2/3 of the transverse colon, and hindgut includes distal 1/3 of transverse colon to the upper portion of the anal canal. And sympathetic innervation arises from the abdominal prevertebral ganglia, celiac, superior mesenteric, and inferior mesenteric, as we discussed. Now the celiac trunk. So which are the three major branches of celiac trunk? It is common hepatic, splenic, and left gastric. They constitute the main blood supply of the gut, and there is strong anastomosis existing between the left and right gastroepiploics and left and right gastric. So even if one of them is occluded, for example, if the left gastric artery is occluded, the right gastric artery can make up for the blood supply of the area supplied by the left gastric, because there is anastomosis between them. It goes similarly for the left and right gastroepiploics. So here is the celiac trunk. There is three arteries coming from it. There is common hepatic, this is left gastric, and splenic. Common hepatic gives proper hepatic and gastroduodenal artery. From proper hepatic, there is right gastric artery, which is supplying the right side of the lesser curvature of stomach, and there is left hepatic, right hepatic, and cystic arteries from proper hepatic artery. And from the gastroduodenal artery, there are anterior superior pancreaticoduodenal, which supplies pancreas and duodenum. Pancreas comes in the foregut supply. It supplies pancreas and duodenum's anterior part and posterior part as well. And the gastroduodenal artery also gives off right gastroepiploic artery, right gastric and right gastroepiploic. So where does the left gastric and left gastroepiploic artery comes from? So the left gastric artery is a branch of celiac artery. Here it is. So left gastric is coming from celiac artery itself, and it also gives esophageal branches, which are important in the esophageal varices in portal hypertension. And left gastric artery forms anastomosis with the right gastric artery coming from the gastroduodenal artery, coming from the proper hepatic artery, and it forms the anastomosis at lesser curvature of the stomach. And the right gastroepiploic artery anastomosis with the left gastroepiploic artery, which is a branch of splenic artery, and it makes anastomosis at the greater curvature of the stomach. And splenic artery has two branches, short gastric and left gastroepiploic. So the short gastric artery supplies the body and the fundus and little bit of cardia as well. So this is the fundus, this is cardia, and this is the body. Okay. So it supplies the greater curvature of the stomach. And if there are varices, if in the question stem they say there is varices present at the lower esophagus, so which of the arteries is involved? It is left gastric artery. But if you have to focus on the questions, if it is it says that the varices are present on the greater curvature of the stomach, in the body area or the fundus area of the stomach, then which of the arteries is involved? It is splenic artery, not left gastric artery. I will see the portosystemic anastomosis. So there are mainly three anastomoses, and the fourth anastomosis is man-made, as I call it. So the first anastomosis is at the esophagus layer, and the clinical sign is esophageal varices. So the portosystemic shunt has two factors, like portal factor and systemic factor. So the portal side is given by left gastric artery, and systemic is by esophageal artery. So here you can see this is the portal part, which is left gastric artery, and this is the systemic part, which is esophageal veins, which is a branch of which will give rise to azygous vein. Okay. And the second is at the umbilical area, and the caput medusae is the clinical sign. So the portal part is the paraumbilical veins. So this is the paraumbilical veins, this is the portal part, and the systemic part is the epigastric veins, which will join with the common iliac veins. So the epigastric veins are branches of inferior and superficial epigastric veins of the anterior abdominal wall. And the third is at the rectum, which will give rise to anorectal varices. It has superior rectal vein, which is portal, which is of portal circulation, and middle and inferior rectal, which is of systemic circulation. Okay. So here is the superior rectal vein, which will join with the inferior mesenteric vein, and which will join with the splenic vein, which will give rise to the portal vein. Okay. And the fourth is the man-made anastomosis in liver cirrhosis. So it is a treatment with a transjugular intrahepatic portosystemic shunt, tips between the portal vein and the hepatic vein, relieves the portal hypertension by shunting blood to the systemic circulation, that is hepatic vein. Hepatic vein is the systemic circulation, bypassing the liver, and tips can precipitate hepatic encephalopathy due to decreased clearance of ammonia from shunting. So usually ammonia from portal vein is metabolized by the liver, but now as we are shunting the blood from portal vein into the hepatic vein, bypassing the liver, the ammonia will enter the systemic circulation, and it can precipitate hepatic encephalopathy. Also, and there is anastomosis between, this is not relevant to the portosystemic shunt, but the superior mesenteric artery and inferior mesenteric artery, they both have anastomosis called the marginal artery of Drummond and arc of Riolan. So they both supply the colon. So if one of them is thrombosed or embolic, like if there is occlusion of inferior mesenteric artery, so superior mesenteric artery can make up for that loss of circulation through the marginal artery of Drummond. So there will be very less loss of circulation to the affected colon. Okay. And also if the IMA needs to be resected during the surgery, they are not re-anastomosed because there is always anastomosis of marginal artery of pneumon, so we may not need to re-anastomose the inferior mesenteric artery every time. The pectinate line, which is also called the dentate line, it is formed when the endoderm meets the ectoderm. So endoderm is the hindgut above the pectinate line, and below the pectinate line it is ectoderm, which is a part of the skin. And above the pectinate line there are internal hemorrhoids and adenocarcinoma, and below the pectinate line there is external hemorrhoid and anal fissures and squamous cell carcinoma, because it is generally the skin. Skin is ectoderm, and skin gives rise to the squamous cell carcinoma below the pectinate line. And above the pectinate line, if there are internal hemorrhoids are abnormal distension of the anal venous plexus, and risk factors include older age and chronic constipation, which it receives visceral innervation and are therefore not painful. On the other hand, the external hemorrhoids, they receive the somatic innervation from inferior rectal branch of pudendal nerve and are therefore painful if thrombosed. So external hemorrhoids are painful and internal hemorrhoids are not painful. There will just be fresh bleed in internal hemorrhoids, no pain. And anal fissures are tear in annoderm below the pectinate line and pain while pooping, blood on toilet paper, and located in the posterior midline because this area is poorly perfused. It is associated with low fiber diet and constipation. So now what is the nerve supply above the pectinate line? It is through the visceral innervation, that is inferior hypogastric plexus T12 to L3, and below the pectinate line it is from somatic innervation, that is pudendal nerve S2 S4. Below the pectinate line everything is from pudendal. If it is nerve supply, it is from pudendal nerve. If it is arterial supply, it is inferior rectal artery, which is branch of internal pudendal. If it is vein, it goes into the internal pudendal. Okay, so everything below the pectinate line is branch of pudendal. So artery above the pectinate line, it is a superior rectal artery, which is a branch of inferior mesenteric artery. And below the pectinate line is inferior rectal artery, which is branch of internal pudendal artery. Now veins above the pectinate line is superior rectal vein, superior rectal artery, and superior rectal vein. It is a branch of inferior mesenteric vein, which will join with the splenic vein to give rise to the portal vein. This is portal circulation. And below the pectinate line is inferior rectal vein, which is a branch of internal pudendal vein, branch of internal iliac vein, and which is a branch of common iliac vein and IVC. So if this is IVC, this is the common iliac, then there's internal iliac, external iliac, and from internal iliac there is internal pudendal vein. Okay, this is IVC, this is common iliac vein, this is internal iliac vein, external iliac vein, this is pudendal vein. And the lymph nodes above the pectinate line drain into the internal iliac lymph nodes, and below the pectinate line it drains into the superficial inguinal lymph nodes. So above the pectinate line is superior and middle rectal nodes, and below the pectinate line is inferior rectal nodes. Okay. Liver tissue architecture. So there are three things in the liver tissue architecture. There is portal vein, there is hepatic artery, and there is bile duct. So the functional unit of liver is made up of hexagonally arranged lobules surrounding the central vein with portal triad on the edges. And the portal triad consists of portal vein, hepatic artery, and bile ducts, as well as lymphatics. So this is the functional unit. So there is central vein and there is portal triad attached adjacent to it, which consists of hepatic artery, portal vein, and common bile duct. Only bile duct. And apical surfaces of hepatocytes faces bile canaliculi, and basolateral surface faces sinusoids. So this is the apical surface, okay, that faces the bile canaliculi. Here there are bile canaliculi. This is the apical surface. The basolateral surface faces the sinusoids. We'll see in detail when I see the diagram, when I will draw a diagram for you to simplify things. Let's just go over the theory once. So basolateral surface faces sinusoids. There are Kupffer cells that are specialized macrophages located in sinusoids, which clears bacteria and damaged or senescent RBCs. So Kupffer cells are specialized macrophages. Like there are specialized macrophages called histiocytes in skin. There are type 2 alveolar macrophages in the alveoli, which are specialized. Then there is hepatic stellate cytocells in species of Dece, which stores vitamin A when quiescent and produces extracellular matrix when activated, and it is responsible for hepatic fibrosis in cirrhosis. So the fibrosis is caused by the hepatic stellate or ito cells. So there are three zones of hepatocyte. Zone 1 is periportal zone. It is the outermost zone, and it is affected by the viral hepatitis first, because if it is the outermost zone, it is very accessible by the virus. And it is best oxygenated because it is the outer zone, and it is most resistant to circulatory compromise. And it is the region affected by the ingested toxins like cocaine. Zone 2 is intermediate zone, which is involved in yellow fever. And zone 3 is pericentral zone, which is a centrilobular zone. It is affected first by the ischemia because it is the pericentral zone. It is in the centermost region. So this is 1, 2, and 3. So it is difficult for the blood to reach the deepest layer, right? So the zone 3 is affected first by the ischemia, and it is least oxygenated, and there is high concentration of cytochrome P450. And therefore it is most sensitive to metabolic toxins like ethanol, carbon tetrachloride, halothane, rifampin, and acetaminophen. And it is the site of alcoholic hepatitis. So ischemia, cytochrome P450, toxins, and alcoholic hepatitis, they all involve the zone 3, that is the innermost zone. Okay, now let's draw a different clear diagram. Like so, this is our functional unit of the liver. Here is the central vein. This is the central vein. these are hepatic arteries. And this is portal vein. These both are hepatic inflow. So inflow is the blood goes from portal vein towards the central vein, and from hepatic artery towards the central vein too. Now I'll draw the bile canaliculi. And the bile is outflow. Bile canaliculi is outflow. Now let's draw the hepatocytes. So these are hepatocytes. This is portal vein, this is hepatic artery. So these are the stellate cells or ito cells, which are responsible for hepatic fibrosis and located in the space of Desai. So this is the space of Desai. And there are, we also talked about the Kupffer cells, which are located in the sinusoids. So if you didn't realize by now, these are the sinusoids. This whole area is sinusoid. Okay. So these are Kupffer cells. And this area is sinusoids. Okay. And this bile canaliculi, it collects bile from all the hepatocytes, right? So the hepatocyte secretes bile into the bile canaliculi, and from the bile canaliculi it goes into the bile duct. Okay. Yeah, that's it. This is the functional unit. This is the functional unit. So this is the zone. So this is the zone 1, this is zone 2, and this is the zone 3. This is zone 3. Okay. And also, as there is a hepatic artery and portal vein both supplying the hepatocytes, so there is dual blood supply, right? So there is rarely any infarcts occurring in the liver. And yeah, but there is one example, one exception, not example. There is one exception where there is thrombosis in the liver. That is after a transplant. That is after a hepatic transplant. So if there is a transplant reaction, there will be thrombosis in the hepatic arteries. And during the transplant surgeries, the collateral blood supply will also have damaged. So there will be infarcts in the liver because of the thrombosis of the hepatic arteries. Biliary structures. So cholangiography shows filling defects in the gallbladder. That is blue arrow in A. So this is the filling defect. and cystic duct red arrows in A. So this is not completely filling up the cystic ducts and the gallbladder. So there may be acute cholecystitis, or there may be gallstones in the cystic duct, which is causing impaired filling of the gallbladder. In gallstones that reach the confluence of the common bile duct and pancreatic duct at the ampulla of Vater can block both common bile duct and pancreatic duct. It is called double duct sign, causing both cholangitis and pancreatitis response respectively. So if it is obstructing the common bile duct, it is going to cause cholangitis, and if it is going to obstruct pancreatic duct, it is going to cause pancreatitis. In tumors that arise in the head of pancreas, usually ductal adenocarcinoma, it can cause obstruction of the common bile duct, which causes enlarged gallbladder with painless jaundice. This is Courvoisier's sign. So this enlarged gallbladder, which is palpable with painless jaundice. There is no pain like in gallstones or in cholecystitis. If it is gallstones or cholecystitis and you can palpate the gallbladder, it will be tender, it will be painful. So if it is painless and still there is jaundice and enlarged gallbladder, it is mostly due to the ductal adenocarcinoma of the pancreatic head, because it is obstructing the common bile duct. So this is the accessory. Let's talk a little about the accessory pancreatic duct. So it is the proximal part of the dorsal pancreatic duct, and it degenerates or it persists as accessory duct, and it opens into the minor papilla. So accessory pancreatic duct opens into the minor papilla. This is the minor papilla, and it is the proximal part of dorsal pancreatic duct, and therefore it degenerates or it can even persist in life as accessory pancreatic duct. Now the femoral region. So there is, if we go from lateral to medial side, there is nerve, artery and vein, and then there is lymphatics. So there is this mnemonic called you go from lateral to medial to find your navel. That is nerve, artery, vein and lymphatics. And in femoral triangle, it contains femoral nerve, artery and vein, just the nerve. Okay, it does not contain lymphatics in the femoral triangle. And in the femoral sheath, it is a fascial tube 3 to 4 centimeter below the inguinal ligament, below the central point of the inguinal ligament, and it contains femoral vein, artery and canal. Femoral canal, which contains inguinal lymph nodes, but it does not contain femoral nerve. So here it is nerve, artery and vein in the femoral triangle, but in the femoral sheath there is just vein, artery and femoral canal, which has deep inguinal lymph nodes. So there is no lymphatics in the femoral triangle, and there is no femoral vein in the femoral sheath. So this is the femoral triangle. It is bounded by the adductor longus muscle, sartorius muscle and the inguinal ligament superiorly. So there is this artery, vein, and then there's lymphatics, which is in the femoral region. So there is nerve, artery and vein in femoral triangle, and this is the femoral ring, which is covered by a femoral sheath, which has artery, vein and the inguinal lymph nodes. Okay, and the femoral hernia herniates through the femoral ring or the femoral sheath. the inguinal canal. So the inguinal canal starts at the deep inguinal ring. It is also called internal inguinal ring, and it ends at the superficial inguinal or external inguinal ring at the root of the penis. Okay. So the layers of the abdomen, that is parietal peritoneum, then there's extra peritoneal tissue, then there's transversalis fascia, then transverse abdominis and internal oblique, and going medially it will give rise to conjoint tendon. Together transverse abdominis and internal oblique will give rise to conjoint tendon, and between the conjoint tendon and the transversalis fascia there will be rectus abdominis muscle and pyramidalis muscle. And then there's aponeurosis of external oblique muscle. Okay. And then there will be inguinal ligament. So parietal peritoneum, extraperitoneal tissue, transversalis fascia, transverse abdominis and internal oblique, then external oblique and inguinal ligament. And transversalis fascia, internal oblique and external oblique give rise to the layers of the spermatic cord. So transversalis fascia gives rise to the internal spermatic fascia because it is the deepest layer, right? Transversalis fascia is deeper than the internal oblique and external oblique. So if it is stretched from the deeper side to form the spermatic cord, is going to form the innermost layer of the spermatic cord, right? So that will cause internal spermatic fascia. Then the internal oblique muscle, it is going to form the middle layer, that is cremasteric muscle and fascia layer. And the external oblique, it is the exterior most layer, right? So it is going to form the exterior most layer of the spermatic cord, that is external spermatic fascia. And this is the nice mnemonic, that is ICE type: internal spermatic fascia, cremasteric fascia, external spermatic fascia, formed by transversalis fascia, internal oblique and external oblique. And here are the inferior epigastric vessels. Inferior epigastric vessels are very helpful during the hernioplasty surgery to differentiate between the direct and indirect hernia, to locate the direct and indirect hernia. So if it is a direct hernia, it will be medial to the inferior epigastric vessels, somewhere over here. And if it is indirect hernia coming from internal inguinal ring and also superficial inguinal ring, from deep and superficial inguinal ring, it will be indirect hernia and it will be lateral to the inferior epigastric vessels. So inferior epigastric vessel serves as the anatomic landmark during the hernioplasty surgery. Anatomic surgical landmark. And there's a medial umbilical ligament and median umbilical ligament as well. So medial umbilical ligament is the remnant of umbilical artery, and median umbilical ligament is the remnant of allantois. So now the myopectineal orifice. So what is this diagram? Is the anterior abdominal wall viewed from the inside. So first we'll see the inguinal canal contents. In male it is ductus deferens, vas deferens. In female it is round ligament of uterus, ilioinguinal nerve, internal spermatic vessels, and internal spermatic vessels, ilioinguinal nerve, and also there are veins Which veins? Testicular veins. Arteries, one vein and 3 arteries. Arteries to vas deferens, artery to testicles, that is testicular arteries, and which was the third artery? Yeah, the third is the internal spermatic artery. There are also 3 nerves, I think. There is a branch of genitofemoral, there is ilioinguinal nerve, and there's autonomic nerves. Yeah, okay. And we'll now see the inguinal triangle. How is the inguinal triangle formed? So the medial border is formed by the lateral border of the rectus abdominis, and the lateral border is formed by the inferior epigastric vessels, and the inferior border is formed by the superior border of the inguinal ligament. Okay, rectus abdominis, inferior epigastric vessels, and inguinal ligament. So during the surgery, if we have to resect rectus abdominis muscle, there are chances that we will damage the inferior epigastric vessels as well, because as you can see, the inferior epigastric vessel is in close proximity to the rectus abdominis. So mostly during gynecological surgeries or during cesarean section, we have to divide the rectus abdominis either superiorly, or we have to cut sideways, like laterally. So if we are cutting the rectus abdominis transversely or laterally, there are chances that we are going to damage inferior epigastric vessels. And these inferior epigastric vessels are a branch of external iliac vessels. So if this is aorta, this is the common iliac artery, this is external iliac, this is internal iliac. Yeah, so the inferior epigastric arteries are the branches of external iliac. Here is the rectus abdominis, so this is the Hazelbeck triangle. Now we'll see the different hernias. So hernia is a protrusion of peritoneum through an opening, usually at a site of weakness, and the contents may be at risk for incarceration, that is, it is not reducible back into the abdomen or pelvis, and strangulation, there is ischemia and necrosis. So you have to learn the difference between incarceration and strangulation. There is no ischemia or necrosis in incarceration, it is just not reducible back into the abdomen. And in strangulation, there is ischemia and necrosis of the peritoneal contents. And the complicated hernias that can present with tenderness, erythema, and fever. So first is the diaphragmatic hernia. The abdominal structures enter the thorax. Most common causes in infants is congenital defect of the pleuroperitoneal membrane. And mostly it is the left-sided herniation. Right hemidiaphragm is relatively protected by liver, of course. And it is a left-sided herniation, mostly posterolateral side. Okay. And it is due to the congenital defect of pleuroperitoneal membrane, due to failure of pleuroperitoneal membrane to close properly. Failure to close properly. And in adults, it can be due to the laxity or defect of phrenoesophageal membrane, the membrane which joins esophagus to the diaphragm. That is phrenoesophageal membrane, and the laxity or defect of that membrane can lead to diaphragmatic hernia in adults, and it will cause hiatal hernia, which can be sliding hiatal hernia or paraesophageal hiatal hernia, which is herniation of stomach through the esophageal hiatus. So what is sliding hiatal hernia? So it is thus just gastroesophageal junction is displaced upwards as gastric cardia slides into the hiatus, and it will cause hourglass stomach, and it is the most common type, and it is associated with the GERD. So gastroesophageal reflux disease is characterized by the loss of intra-abdominal esophageal length, right? So in GERD, the esophagus moves upwards. So when the esophagus moves upwards, the gastric cardia is going to also to move upwards, right? So this is the gastric cardia that has moved upwards. This is supposed to be the gastroesophageal junction, but now here is the gastroesophageal junction. So that is sliding hiatal hernia. And the paraesophageal hernia, it is caused by gastroesophageal junction is usually normal, but gastric fundus protrudes into the thorax. So here is the gastroesophageal junction, it is at its normal place, but now the gastric fundus, this part has gone up, it has herniated into the thorax. This is the herniated gastric fundus. In sliding hiatal hernia, gastric cardia is being herniated, and in paraesophageal hiatal hernia, gastric fundus is being herniated. And also to remind you that sliding hiatal hernia is caused by GERD, and GERD can also be caused in kids. Okay, it's not like GERD is just a problem of adults. It can also be found in kids, causing sliding hiatal hernia in kids as well. Okay, and GERD related to sliding hiatal hernia are generally resistant to the antacids. If it is a normal GERD without any hernia, they are very responsive towards proton pump inhibitors. But if it has caused hernia and the gastric cardia is now at the level of in thorax, and it has herniated into the thorax, it will have resistance toward the antacids. Okay, so once again, sliding hiatal hernia and paraesophageal hiatal hernia is due to laxity of phrenoesophageal membrane, and in infants it is defect of pleuroperitoneal membrane. This is very important to differentiate both of them. Now, indirect inguinal hernia, it is indirect because it goes through both internal, that is deep inguinal ring, and superficial inguinal ring, and into the groin. It enters the internal inguinal ring lateral to the inferior epigastric vessels, as we talked about here. If it is indirect, it is going to enter laterally to the inferior gastric vessels through the deep inguinal ring, through the inguinal ligament, through the spermatic cord, into the external inguinal ring. It is caused by failure of processus vaginalis to close, and it can also form hydrocele, and it may be noticed in infants or discovered in adulthood, but not in very elderly people. Mostly the hernia found in elderly people is direct inguinal hernia, which is caused by the weakness of transversalis fascia. If there is indirect inguinal hernia, it is mostly found in the early adults or infants. It is very common in males. It follows the pathway of testicular descent. It is covered by all the 3 layers of spermatic fascia, obviously, right, because it is coming from deep inguinal ring to the superficial inguinal ring and then into the groin through the spermatic cord and into the testis. So it will be covered by all the three layers, which are internal spermatic fascia, cremasteric fascia, and external spermatic fascia. It will be covered by all the three layers. Whereas direct inguinal hernia, it protrudes through inguinal triangle, that is Hazelbeck triangle, and it bulges directly into the parietal peritoneum, medial to the inferior epigastric vessels but lateral to the rectus abdominis. So somewhere over here, as we saw, this is the site of direct inguinal hernia, that is lateral to inferior epigastric vessels but medial to rectus abdominis muscle. So this is the Hazelbeck triangle we talked about, right? So if this is coming, it is herniating directly from the Hazelbeck triangle. It is herniating directly from the Hazelbeck triangle towards the superficial ring. It will only pass through the superficial inguinal ring, not the deep inguinal ring. Medial to the inferior epigastric vessels but lateral to the rectus abdominis, goes through the external or superficial inguinal ring only. It is covered by external spermatic fascia. External spermatic fascia is formed by the external oblique muscle, and it usually occurs in older males due to acquired weakness of transversalis fascia. This is a mnemonic. You don't need mnemonic for this. You just have to understand what's happening here. Still, the MDs don't like medial to the inferior epigastric vessels is direct hernia and lateral to inferior epigastric vessels is indirect hernia. Okay. And as you can see, the hernia here, it is only coming from the superficial inguinal ring. It is not going through the deep inguinal ring. Okay. And if it is not coming from both the rings, it will only have one layer, that is parietal peritoneum. And also there's conjoint tendon, which we saw it is formed by, I think, transverse abdominis and internal oblique. Yes, the transverse abdominis and internal oblique muscle give rise to the conjoint tendon, and if the conjoint tendon is damaged, the hernia can also enter the scrotum. Okay. If conjoint tendon is damaged, direct hernia can enter the scrotum. And now the femoral hernia. It protrudes below the inguinal ligament. The inguinal hernia is above the inguinal ligament, whereas the femoral hernia, it protrudes below the inguinal ligament through the femoral canal below and lateral to pubic tubercle. The inguinal ligament are above and medial to the pubic tubercle. Femoral hernias are below and lateral to the pubic tubercle. It is more common in females, but overall inguinal hernias are the most common, more likely to present with incarceration, that is obstruction of the hernia which is not reducible back into the abdomen, or strangulation, which is ischemia or necrosis of the hernia. Okay, so where exactly is the femoral hernia herniating out? It is into the femoral canal, as we saw. Where is it? Into the femoral canal, which is bounded medially by the lacunal ligament and laterally by the femoral vein. Here it is femoral artery, here it is femoral vein, here this is lacunar ligament. So femoral hernia is herniating between them through the femoral canal. This is the femoral canal. This is femoral artery, this is femoral vein. And what was the content of this femoral canal? Right, it was inguinal lymph nodes. It was the content of femoral canal. We discussed about it somewhere over here, that there is femoral vein, femoral artery and canal in the femoral sheath, and the canal contains deep inguinal lymph nodes but no femoral nerve. And what is the reason of femoral hernia? Like in direct inguinal hernia, there was weakness of transversalis fascia. In femoral hernia, there is weakness of proximal femoral canal. Weakness of proximal femoral canal. And this is the point to remember, that it is below the inguinal ligament and it is below and lateral to the pubic tubercle. Okay, and it is situated medial to the femoral vein and lateral to the lacunar ligament. This is medial side, this is lateral side. So now the gastrointestinal regulatory substance. So first is gastrin. Gastrin is secreted from the G cells, which is situated in the antrum of stomach and duodenum. And the action of gastrin is, it increases the gastric H plus secretion. It helps in the growth of gastric mucosa, and it increases gastric motility. H plus secretion, growth of gastric mucosa, and gastric motility, not just acid secretion. Okay, and it is regulated by stomach distension, by food, by alkalinization, by amino acid peptides, vagal stimulation, via gastrin releasing peptide GRP, and it is decreased by pH less than 1.5. So it is self-regulatory. So if the pH decreases than 1.5, then it inhibits the gastrin release from G cells, and it is increased by chronic proton pump inhibitor used. Okay, so initially by PPI use it is decreased, but by chronic PPI used it is the receptors of G cells are upregulated. So then the gastrin secretion increases, and it increases in chronic atrophic gastritis as well, which is caused by H. pylori, and it and it is increased in Zollinger-Ellison syndrome as well, and it is very much increased in ZES. And also secretin normally inhibits the gastrin release, but in Zollinger-Ellison syndrome, secretin, if we administer secretin into the body, there is a paradoxical effect. So there will be increased gastrin with secretin administration. Now the second is somatostatin. Somatostatin is an inhibitory hormone. It is secreted by the D cells, which is situated in the pancreatic islets and GI mucosa. It decreases gastric acid secretion, pepsinogen secretion, pancreatic small intestinal secretion. It reduces gallbladder contraction, and it reduces insulin and glucagon release. In short, it decreases and inhibits everything. And it is increased by acid. So if there is increased acid production by G cells, then there will be increased somatostatin as well to inhibit overproduction of acids. And it decreases by vagal stimulation. So it inhibits secretion of various hormones, encourages somatostasis. Octreotide is an analog used to treat acromegaly, carcinoid syndrome, VIPoma, and varicose bleeding. Okay. Carcinoid syndrome and VIPoma is important for the gastrointestinal system. And emergency management of varicose bleeding is octreotide as well. The third is cholecystokinin, which is secreted by eye cells. Cholecystokinin has two eyes, so it is you can remember it that way. It is secreted by eye cells located in duodenum and jejunum. What cholecystokinin does is it increases pancreatic secretion. So cholecystokinin increases pancreatic secretion, it increases gallbladder contraction, it decreases gastric emptying, and increases sphincter of ODI relaxation. It increases pancreatic secretion and gallbladder contraction. So the bile from the gallbladder enters the intestine. It decreases gastric emptying, and it increases sphincter of ODI relaxation. So if the sphincter of ODI relaxes, the bile can easily enter common bile duct to from common bile duct to the intestine. And its secretion is it is stimulated by fatty acids and amino acids, and it acts on neural muscarinic pathways to cause pancreatic secretions. Okay, neural muscarinic pathways to cause pancreatic secretion. And cholecystokinin is the reason for the cause of pain in gallstones. It is the cause of pain in the gallstones. Okay, so when if there are gallstones, what happens is okay, let me just write it down. If there is gallstones, there is increased secretion of whenever there is a secretion of cholecystokinin, the gallbladder will contract, and it will cause increased pain, and it is usually after a fatty meal, because we saw fatty acids stimulate the release of cholecystokinin. And yeah, one other thing, I forgot to mention that how gastrin stimulates H plus secretion, acid secretion, how gastrin stimulates acid secretion. So it does that by two ways. So the major way is gastrin stimulates ECL cells. ECL cells secretes histamine, and histamine stimulates parietal cell, and parietal cell in return secretes H plus. Gastrin can also stimulate parietal cells directly, but that is not the major way. The major way is through ECL cells, histamine, parietal cells, and HCl. Okay, and if you have noticed, these are the opposite stimulation effects. Like vagal stimulation will increase the acid production. It will increase the gastrin production, and vagal stimulation will decrease the somatostatin production. Okay. They both are opposite effects. And if there is a somatostatinoma, and it is the tumor of the D cells arising from the D cells, which is called somatostatinoma, what will happen is there will be reduced pancreatic secretion, reduced small intestinal secretion, and reduced gallbladder contraction, everything, right? So if there is a reduced gallbladder contraction, there will be gallbladder stasis, right? So that will cause stones in gallbladder, and there will be hypergastrinemia, because of the decrease in insulin. I know somatostatin inhibits gastrin production, but what happens is there will be increased insulin. There will be decreased insulin with somatostatinoma. So it will cause increased production of gastrin, which will cause hypergastrinemia. And then there will be steatoria because of decreased pancreatic secretions. So if there is decreased pancreatic secretion, the amylase and lipase secretion will also be reduced. So that will lead to fat malabsorption, which will cause steatoria. Okay, fourth is secretin. It is secreted by S cells of duodenum. In duodenum, there are 3 cells, I, S, and K. Okay. I is for cholecystokinin, S is for secretin, and K is for glucose-dependent insulinotropic peptide, or GIP. So secretin is secreted by S cells of duodenum. It increases pancreatic bicarbonate secretion, it decreases gastric acid secretion, and it increases bile secretion. So secretin helps secreting pancreatic and bile, but it reduces gastric acid secretion, and it is stimulated by increased fatty acids in lumen of duodenum, so fatty meals. Okay. And if it is increasing the pancreatic bicarbonate secretions, So now bicarbonate neutralizes the gastric acid in duodenum, allowing pancreatic enzymes to function. So what is happening is gastric acid is being secreted from the parietal cells in the stomach antrum, right? Yeah, in the stomach antrum, the parietal cells are secreting H plus or gastric acid. So if when the H plus or that acid is reaching the duodenum, it is stimulating secretin production. So now as secretin stimulation is occurring, it will cause increased bicarbonate secretion. So bicarbonate will now neutralize that acid coming in from gastric. And now as the environment is neutralized, the bicarbonate has neutralized the acid, it is time for pancreatic enzymes to function, because pancreatic enzymes cannot function in the acidic environment, right? Then then there's glucose independent insulinotropic peptide, which is secreted from the K cells of duodenum and jejunum as well. Its exocrine function is to decrease H plus secretion, and endocrine function is to increase insulin release. So if it is increasing the insulin release, we should infer that all type of meals, that is fatty acids, amino acids, oral glucose, will stimulate GIP production. And it is also called gastric inhibitory peptide. That is quite simple in my opinion to remember, GIP. And oral glucose load will increase insulin compared to IV equivalent due to GIP secretion. So when we are giving IV dextrose or IV glucose, there will it will enter the bloodstream directly, right? But if we are giving oral glucose, it is going to enter the duodenum and the jejunum, stimulating GIP release. So if the GIP is stimulated, insulin release is also going to increase, so that glucose will be metabolized faster. And we also use GIP analogs in the treatment of type 2 diabetes. There are two drugs named exenatide and liraglutide. They are GIP analogs. Okay. Now the motilin, it is very important. This motilin is very important, and it is secreted from the small intestine. It produces migratory motor complexes, and it is increased in fasting state. Motilin receptor agonists like erythromycin are used to stimulate intestinal peristalsis. So it produces migratory motor complexes, which means that it is going to increase the intestinal peristalsis, right? So now in the absence of migratory motor complexes, what happens is there is going to be intestinal stasis. And whenever there is stasis anywhere, be it in gallbladder or be it in intestine, there is going to be bacterial proliferation. So if there is absence of migratory motor complex, there is going to be increase in bacterial flora of the intestine, causing enteritis or gastroenteritis or anything like that. And what are the cases where there will be absence or where there will be reduction in the migratory motor complexes in the intestine? You have to keep in mind 2 points which will decrease the migratory motor complex. The first is short bowel syndrome. Okay, so if there is ileal resection or there is intense abdominal trauma causing lacerations of the intestine and causing reduction in the absorptive surface of the intestine, so now if there is a reduced intestinal surface, there will be reduced migratory motor complexes as well, right? So that is the first reason, short bowel syndrome. And second is pregnancy. So in pregnancy there is increased progesterone, right? So the increased progesterone is going to cause reduction in migratory motor complex. Progesterone. So that is going to cause constipation. If the peristalsis are not occurring properly or timely, it is going to cause constipation. Hence it is said that the pregnancy is a state of constipation, right? Many pregnant women will come to the office with the complaints of constipation. Okay, and with being that said, let me just point out few of the changes that occurs with pregnancy. Let me just write it down here. With pregnancy, there is decreased in LES tone, lower esophageal lower esophageal sphincter tone. I forgot that. So that is going to cause GERD. There is going to be decreased gallbladder motility. There will be cholelithiasis. There is smooth muscle relaxation throughout the body in pregnancy. Okay, so the smooth muscles are responsible for the motility, as we saw in the submucosal layer. There are Meissner's plexus, which are responsible. Sorry, not Meissner's, but myenteric plexus, right? In submucosa, which are in muscularis. Yeah, in muscularis externa, there is myenteric plexus, which are responsible for motility of the intestine. Sorry guys, I'm not a pro at this, but there will be colonic smooth muscle activity reduction, which is migratory motor complex, and it will cause constipation. Okay. Now the vasoactive intestinal polypeptide, it is secreted by the parasympathetic ganglia in sphincters, gallbladders, and small intestine. So if it is secreted by parasympathetic ganglia, it is obvious that parasympathetic stimulation is going to increase this VIP hormone, and it increases intestinal water and electrolyte secretion. So there will be diarrhea, there will be increased relaxation of intestinal smooth muscles and sphincters. If there is relaxation of intestinal smooth muscles and there is relaxation of sphincters, it is again going to cause more diarrhea. And if there is increased electrolyte secretion into the lumen, it is going to cause electrolyte wasting, right? That will be shown signified as hypokalemia. There will be deficiency of potassium ion, and it is stimulated. Stimulated by distension and vagal stimulation. Vagal stimulation is parasympathetic stimulation, right? And it is decreased by adrenergic input, which is sympathetic input. Now, what is VIPoma? VIPoma is non-alpha, non-beta islet cell pancreatic tumor that secretes VIP. It is associated with WDHA syndrome, which stands for watery diarrhea, hypokalemia, and achlorhydria. So what is the mechanism of VIP hormone? So whenever VIP is released, it causes increase in pancreatic bicarbonate and chloride ion secretion. Due to increased bicarbonate and chloride ion secretion, it is going to bind to epithelium, which in turn activate adenylate cyclase, which is going to activate CAMP, and stimulation of CAMP in smooth muscles is going to cause relaxation, which we saw here, there is relaxation of intestinal smooth muscles, and there is secretion of sodium chloride and bicarbonate into the lumen, causing watery diarrhea. Nitric oxide causes increased smooth muscle relaxation. It is pretty simple, and including the lower esophageal sphincter. Okay, it relaxes the lower esophageal sphincter, so it can lead to reflux esophagitis as well. So this is the mechanism behind achalasia cardia. So there is loss of nitric oxide secretion. So if there is no nitric oxide secretion in the lower esophageal sphincter, the LES is never going to relax. It is going to be constricted at all the times, causing achalasia. Yeah. So here is the LES. It is constricted all the time. So that will lead to blockage of food in the distal esophagus. Okay, we'll see achalasia later on. And the last is ghrelin. Ghrelin is it is secreted from the stomach. It increases appetite. It causes growling stomach. So whenever you are hungry, your stomach growls, right? So you can remember it by this way, that ghrelin is causing a growling stomach. So it is increasing the appetite. It is making you feel hungry, and it is increased in fasting state. It is decreased by food. It is increased in Prader-Willi syndrome. So if the ghrelin is increasing in Prader-Willi syndrome, one of the key symptoms of Prader-Willi syndrome is hyperphagia. So that is due to increased ghrelin, and it decreases after gastric bypass surgery. Okay. So even after a bariatric surgery, there is going to be decreased ghrelin, because the stomach surface area is reduced, right? Is going to cause decreased ghrelin. And if we are discussing ghrelin, let's also discuss leptin. So leptin is secreted from the adipocytes, and it works opposite to ghrelin. It reduces neuropeptide Y, so it increases the appetite stimulation. Okay. Neuropeptide is used for appetite stimulation. So if it is reducing neuropeptide Y, it is going to decrease the appetite. And you can remember it by this mnemonic, like leptin keeps you thin. Leptin keeps you thin. Okay. And this neuropeptide Y is located in the arcuate nucleus of hypothalamus. The arcuate nucleus of hypothalamus is responsible for hunger stimulation or this leptin stimulation. Okay. Now moving on to the gastric acid. It is secreted from parietal cells. Gastric acid, which is HCl, it is stimulated from parietal cells, secreted from parietal cells. In this action, it reduces stomach pH because it is acid. We'll see the regulation later on. And now the intrinsic factor. Intrinsic factor is also secreted by the parietal cells. Its action is it binds to vitamin B12, and binding of intrinsic factor to vitamin B12 is necessary for its uptake in the terminal ileum. And the parietal cells are regulated by increased histamine from ECL cells, increased vagal stimulation by GRP, increased gastrin, and it is decreased by somatostatin, gastric inhibitory peptide, prostaglandins, and secretin. Right, we saw all of these. Somatostatin is inhibitory hormone. GIP inhibits intrinsic gastric acid release. Prostaglandin also inhibits that, and secretin also has to inhibit that in order to make the pancreatic enzymes work in the duodenum. And the autoimmune destruction of parietal cells causes chronic gastritis or pernicious anemia. Now the pepsin is secreted from the chief cells of the stomach, which are basophilic, and parietal cells are eosinophilic, and it causes protein digestion. It is increased by vagal stimulation like gastric acid and intrinsic factor, and it is also increased by local acid. Okay, so pepsinogen is inactive and it is converted to pepsin, active form, in the presence of acid. And if the gastrin reaches the duodenum and it is not neutralized by the bicarbonate, it is going to damage the intestinal epithelial cells, and it is going to inactivate the pancreatic enzymes if the bicarbonate is absent. This gastric acid has a very low pH, so it can damage any epithelium it comes in contact with, rather it be esophageal mucosa or intestinal mucosa. Bicarbonate has to be there to neutralize it. Okay, and bicarbonate is secreted by mucosal cells of stomach, duodenum, salivary glands, pancreas, and Brunner glands of duodenum. Only duodenum has Brunner gland, and it neutralizes acid. It is increased by pancreatic and biliary secretion with secretin. So secretin stimulates bicarbonate secretion. Okay, it is trapped in mucus that covers the gastric epithelium. Okay, let's see this diagram. So this is the gastric pit. This is the upper glandular layer, deeper glandular layer. Okay, and this is submucosal layer. So these eosinophilic cells you can see are I think parietal cells, and the basophilic cells you can see are the chief cells. You cannot differentiate very easily in this diagram, but the diagram that will be given in the question stems, you will differentiate it quite easily. Let me just see if I have the diagram. No. So yeah, the secretin decreases gastric acid secretion, but in ZES, as we earlier talked, I'm just going to write this down. Secretin administration is going to increase the gastrin levels. So this is the secretin stimulation test used to differentiate between increased gastrin, either it is from gastrinoma or it is due to gastritis or chronic gastritis or atrophic gastritis. That is how you differentiate. Okay, and mostly gastrinoma is in the duodenal, in the second or third portion of the duodenum. The most common site of duodenal ulcers are first portion of the duodenum. right? And the gastric acid secretion has three phases. The first is cephalic phase. It is triggered by the thought, smell, sight, or taste of the food. Right. This acid secretion is triggered by sight, smell, taste of food, or even just a thought of food. The second phase is gastric phase, when the food actually enters the stomach. So that is caused by distension of stomach and presence of gastrin in the stomach. Gastrin from the G cells of the stomach. And the third is intestinal phase, when the food enters intestines. So when the food reaches the intestine, the proteins in that food, the proteins reaching the intestines down regulate gastric acid. Okay, so in both of these phases, acid is increasing, but in the third phase, the acid is going to reduce. In the intestinal phase, the acid is going to reduce. And yeah, and also I want to discuss this is irrelevant to the topic we just studied, but if I'm not going to add it here, I may as well forget it to add it afterwards. So I'm going to discuss the types of diarrhea with you. Just believe me, guys, this is very important for solving the UWorld questions. So the first is osmotic diarrhea. Okay, so it is mostly postprandial, loose stools, and it is associated with bloating as well. Second is secretory diarrhea. It is painless, watery diarrhea. It is due to increased secretion of water and electrolytes into the lumen, and it is increased at night or fasting. Okay. And also we give ORS when there is diarrhea, right? If it is osmotic diarrhea, we give ORS. So what all contents does ORS have? It has sodium, it has dextrose, it has citrate, it has potassium. So what are the uses of having all these in ORS? So sodium, it is going to overcome hypovolemia, right? Because wherever there is sodium, it is going to pull water with it. So if there is increased sodium absorption, there is also going to be increased water absorption. Then there is dextrose. Dextrose helps in increasing sodium absorption. We'll see that later on, that sodium and glucose are absorbed through the SGLT1 co-transporter channel. Okay. So the just mere use of dextrose in ORS is that it increases in increased sodium reabsorption. And what is the use of citrate? It is metabolized to bicarbonate in liver, so it overcomes acidosis. So whenever there is loss of electrolytes, loss of hydrogen ion and loss of water in diarrhea, there is going to be loss of bicarbonate and loss of water in the lumen of intestine, there is going to be acidosis in the body. So this bicarbonate will now overcome that acidosis. What is the use of potassium? It is going to overcome hypokalemia. Okay. I'm going to keep writing extra information, extra irrelevant information to that topic here and there, but just believe me guys, these annotations are important in order to solve view world questions. Okay, or for that matter any question bank, because not everything is given in the first aid book. You have to annotate it guys, and as I have solved the QBank, I know what all annotations are needed in the first aid, so I'm just writing it down so whoever is watching this video can go through the first aid as well as the QBank annotations at the same time. So there is nothing new that will come up in the question bank apart from the first aid and the annotations that I'm doing. Okay. And now the location of gastrointestinal secretory cells. So here's how the stomach is divided. The first part is called cardia, and this is the part called fundus, which herniates in the paraesophageal hernia. So we saw that this is just revision that cardia was herniating in sliding hernia, and fundus was herniating into the thorax in paraesophageal hernia. Okay. Okay, so this is cardia, this is fundus, this is the body, this is the largest area, this is the antrum, and here is the pylorus area. This is the pyloric sphincter, and this is the first portion of the duodenum. So now first we'll see the parietal cells. Parietal cells are here in the body of the stomach. It is secreting HCl, it is secreting intrinsic factor, and it is stimulated by so many things. Firstly, it is stimulated by vagal stimulation. This is the vagus nerve. It is stimulating the parietal cells through acetylcholine. And second, it is being stimulated directly by gastrin. Here is the gastrin directly stimulating the parietal cells to secrete acid. Then there's gastrin stimulating ECL cells, which is secreting histamine, which in turn will stimulate the parietal cells to increase acid production. So this is the major pathway, right? As we talked about, through ECL cells and histamine, that is the major pathway for acid secretion. Okay, now there is chief cells, which is going to secrete pepsinogen, which is further going to activate into pepsin. So chief cells are also stimulated by vagus nerve through acetylcholine. Okay, and also vagus nerve through acetylcholine stimulates gastric releasing peptide in the G cells, so that G cells will secrete gastrin, which causes acid production. Okay, here is the vagus nerve stimulating gastric through gastric releasing peptide is stimulating the G cells, which in turn secretes gastrin, which causes acid production. And then there's also mucus cells in the antrum of the body, antrum of the stomach, which secretes mucus. Then there are D cells in the antrum of the stomach, which secretes somatostatin. So somatostatin can inhibit the acid in the stomach itself. It does not have to go into the duodenum to do that, because there is acid in stomach as well, which needs to be inhibited to protect the gastric epithelium, right? Now the first part of the duodenum contains ISK cells. So this is duodenum. It has ISK cells. So the mnemonic is DISC. I stands for cholecystokinin, S is for secretin, and K is for GIP. You only have to remember the K cells are secreting the GIP. All other stands for their initial letters, right? And you have to also remember cholecystokinin, but you can remember that because cholecystokinin has two eyes, so it is secreted from the eye cells of the first part of the duodenum. And gastrin increases the acid secretion primarily through its effect on enterochromaffin cells, ECL cells, leading to histamine release rather than through its direct effect on parietal cells that we saw. Okay, now the pancreatic secretions. Pancreatic secretion is isotonic fluid. Okay, so what does isotonic fluid means? It has almost similar level of electrolyte as the blood. Okay, but there is only exception in the chloride and bicarbonate levels. So if the pancreatic secretion is low flow, it is secreting in low rates, there is going to be high chloride, and if it is in high flow, it is going to cause high bicarbonate. Okay, if the flow of pancreatic secretion is high, has high bicarbonate. If the flow of pancreatic secretion is low, it is going to cause high chloride. Okay, but sodium and uh, potassium concentration in the pancreatic secretion is always similar to the blood. Okay, it does not depend on the flow rate. So sodium is always going to be in increased levels in pancreatic secretion, and potassium is always going to be in decreased concentration, like that in blood. Alpha amylase. Alpha amylase is helpful in starch digestion, and it is secreted in the active form, and it requires acidic environment. Lipase's function is fat digestion, protease function is protein digestion. Okay, and protease includes trypsin, chymotrypsin, elastase, and carboxypeptidase, and it is secreted as proenzymes like protrypsin, chymotrypsin, proelastase, and they are also called zymogens. They have to be activated into an active form to digest proteins. As I said, alpha amylase requires acidic environment. Lipase requires alkaline environment. So whenever we give proton pump inhibitors, we are inhibiting the acid secretions, right? So there will be alkaline environment. So PPIs are going to cause increased fat absorption because of increased lipase activity. And protease requires acidic environment as well. And last is trypsinogen. It is converted to active enzyme called trypsin, and trypsin in turn activation of other proenzymes and cleaving of additional trypsinogen molecules into active trypsin. So positive feedback loop. So one trypsinogen is converted to trypsin, that is going to activation of other trypsinogen into more trypsin. So that is positive feedback loop. It is converted to trypsin by enterokinase. So this trypsinogen to trypsin conversion is done by enterokinase. kinase or enteropeptidase. It is a brush border enzyme on duodenal and jejunal mucosa. And the dipeptides and tripeptides are the dipeptides and tripeptides are degraded within the intestinal mucosa. So they are absorbed into the mucosa and then they are degraded into monopeptides. So how does the carbohydrate absorption works? So as we talked about, sodium and glucose are both absorbed in the intestine through SGLT1 co-transporters. Okay, so let's read the theory part. Only monosaccharides, glucose, galactose and fructose are absorbed by enterocytes. Glucose and galactose are taken up by SGLT1 along with sodium. So that is sodium dependent absorption, and fructose is taken up via facilitated diffusion by GLUT5. Okay, here is the GLUT5 and fructose is absorbed through the GLUT5 and all are transported to blood by GLUT2. Here is the GLUT2. So glucose and galactose are absorbed through SGLT1 and fructose through GLUT5, and all three of them combinedly are absorbed into the blood by GLUT2. And the D-xylose test, it is a simple sugar that is passively absorbed in proximal small intestine. Blood and urine levels decrease with mucosal damage and normal in pancreatic insufficiency. So it helps us differentiate malabsorption if it is due to if it is due to chronic pancreatitis. There will also be malabsorption, and if there is anything like celiac disease, tropical sprue, Whipple's disease, there will also be malabsorption. But the malabsorption caused by chronic pancreatitis will have normal D-xylose test. Okay, and the xylose levels will be reduced in malabsorption caused by the small intestine pathologies like celiac disease, tropical sprue and Whipple's disease. Okay. So now vitamin and mineral absorption. So you have to remember this mnemonic: iron fist, bro. So iron is absorbed in the proximal duodenum, folate in jejunum, and B12 in terminal ileum. So vitamin and mineral deficiency may develop in patients with small bowel disease, bowel resection, bariatric surgery. The most important thing to remember about bariatric surgery in reference to GIT is that vitamin B12 deficiency is there after terminal ileum resection, because that is where the B12 is being absorbed, right? And iron is absorbed as iron plus 2, that is ferrous iron in duodenum, and folate is absorbed in small bowel, and vitamin B12 absorbed in terminal ileum along with bile salts requires intrinsic factor. And not just intrinsic factor, but B12 has other two proteins attached to it, that is P protein and R protein. So what is the function of pepsin released from chief cells? The pepsin released from chief cells will detach the P protein. Okay. Detached by pepsin of chief cells, and the protein R is detached by pancreatic protease. Detached by pancreatic protease. So imagine if there is ulcers affecting the chief cells, or gastrectomy or a stomach resection affecting affecting the chief cells, causing reduction in the chief cells, or there is pancreatic insufficiency, or there is chronic pancreatitis causing reduction in the pancreatic enzymes, that is protease. So if there is decreased pancreatic protease or decreased pepsin, there will be no detachment of P or R protein. So that will lead to malabsorption of B12. So B12 will not be adequately absorbed. So that will lead to B12 deficiency. And also B12 deficiency occurs after 3 or 4 years of any pathology, because till then there is a storage. The storage lasts for 3 to 4 years. Okay. And after total gastrectomy, we have to give vitamin B12. We have to administer vitamin B12 because if there is total gastrectomy, we have removed all the parietal cells as well, so there will be no intrinsic factor to be attached to B12. So we have to administer vitamin B12 after total gastrectomy. So now let's talk about vitamin B12 a little bit in detail. So what happens if there is a vitamin B12 deficiency? Okay, so there will be buildup of two substances. The first is methyl malonic acid. So that will lead to impaired myelin synthesis. That is going to cause all the neurological symptoms occurring because of B12 deficiency. And the second is homocysteine buildup. Homocysteine buildup is also seen with folate deficiency. Okay. And homocysteine buildup will cause impaired DNA synthesis. So folate can lead to impaired DNA synthesis. So there will be impaired RBC synthesis that will lead to megaloblastic anemia in both folate as well as B12 deficiencies. And yeah, by B12 deficiency causes delayed maturation and reduced cell division of erythrocyte precursors. So there will be more reticulocytes and less erythrocytes in the blood, causing anemia. And whenever we give B12, whenever we replace B12, there is going to be sudden release of reticulocytes from the marrow. So the levels of reticulocytes are going to suddenly increase at 1 week, and then it is going to slowly normalize or slowly decline after 2 or 3 weeks. Okay. Reticulocytes release from marrow. So the level of reticulocytes peak by 1 week. And then it declines, because then maturation of reticulocytes start occurring at normal rate. So reticulocytes level also becomes normal. Now let's quickly talk about the Peyer's patches. They are unencapsulated. Okay, the lymph nodes are encapsulated, but the Peyer's patches are unencapsulated lymphoid tissue found in the lamina propria and submucosa. Lamina propria is a part of mucosa and is also found in the submucosa of just ileum. And it contains specialized microfold cells that sample and present antigens to the immune cells. So, for example, take Shigella. So, microfold cells will take Shigella and it will present the Shigella antigens to the immune cells. And then the B cells stimulated in the germinal center of Peyer's patches differentiate into IgA secreting plasma cells, which ultimately reside in lamina propria. The IgA receives protective secretory components and is then transported across the epithelium to the gut to deal with intraluminal antigen. Okay. So the germinal centers of the B cells. So the B cells have the property of making immunoglobulins. In gut it will form immunoglobulin A. So the plasma cells formed from the B cells will secrete IgA, which will reside in lamina propria. But whenever there is a protective secretory component, whenever there is an infection, it is transported from the lamina propria across the epithelium into the gut lumen to deal with the intraluminal agent. Okay. And what is the pathogenesis of Shigella? Shigella comes in contact with the M cells, which are situated at the base of villi, and then it enters the macrophages. The Shigella enters the macrophages and replicates inside the macrophages. And then from macrophage it enters enterocyte because of its property of actin based motility. It has a shooting like motility because of the actin microfilaments. So there is lateral spread in enterocyte via actin based motility, causing widespread death of enterocyte. And due to the widespread death of the enterocytes, it is going to cause bloody diarrhea. Alright. Now bile is composed of bile salts. What are bile salts? They are bile acids conjugated to glycine or taurine, making them water soluble. And when the bile acids are conjugated with glycine or taurine, it makes bile salts that are water soluble, so it can be absorbed into the intestine. Okay. And bile contains, in addition to bile salts, there are phospholipids, cholesterol, bilirubin, water, and ions. And cholesterol 7 alpha hydroxylase catalyzes the rate limiting step of bile acid synthesis. So as we saw in cardiac pharmacology, the fibrates inhibits this step. Okay. So the cholesterol cannot be converted into bile acid, so the cholesterol increases in gallbladder, causing cholesterol gallstones. So that was the adverse effect of fibrates. Okay. And fibrates drug are clofibrate, gemfibrocil, all of them. What are the functions of bile? It is digestion and absorption of lipids and fat soluble vitamins, that is A, D, E, K. Bilirubin and cholesterol excretion. So body's primary means of elimination of bilirubin and cholesterol is through the bile. So the bilirubin and cholesterol is converted into bile, and it is then secreted into the intestine and then excreted. So that is the means of excretion of bilirubin and cholesterol. And the third is antimicrobial activity via membrane disruption. Okay. And the function of bile is that it digests and absorbs the fat soluble vitamins, that is A, D, E, K. So any pathology that obstructs bile flow from liver, from gallbladder to the intestine, like gallstones obstructing the common bile duct, or pancreatic head adenocarcinoma obstructing the common bile duct. In any case where bile can't reach the intestine, there will be fat malabsorption, there will be fat soluble vitamins malabsorption, so there will be deficiency of vitamin A, D, E, or K. And question stem can provide you with symptoms of any vitamins, any fat soluble vitamin, like they will say the patient has xerophthalmia, which is a symptom of vitamin A deficiency, or ataxia and hemolytic anemia, which is deficiency of vitamin E, or there is bleeding diathesis and coagulation problems, which is deficiency of vitamin K, or rickets, that is deficiency of vitamin D, and all of them are you have to relate it back to decreased bile acid secretion into the intestine. Okay. Decreased absorption of enteric bile salts at distal ileum, as in short bowel syndrome or Crohn's disease, prevents normal fat absorption. Also, if there is any ileal pathology, any intestinal pathology like short bowel syndrome or Crohn's disease, so that will cause reduced absorption of enteric bile salts. So that will again cause malabsorption of fat soluble vitamins, and it will cause bile acid diarrhea. Calcium, which normally binds oxalate, binds fat instead. So free oxalate is absorbed by gut. So that will cause increased frequency of calcium oxalate kidney stones, which we will see this again in Crohn's disease as well, because there is calcium is supposed to bind oxalate normally, but now as there is increased fat, there is fat malabsorption. The fat is not absorbed from the intestine, so there is increased fat in the lumen of intestine. So now the calcium will rather bind to fat instead of oxalate. So now there will be free oxalate, which will be absorbed by gut, which will in turn lead to increased frequency of calcium oxalate kidney stones. Also, ursodeoxycholic acid, it is a kind of bile acid. It reduces cholesterol secretion and it increases bile acid concentration, and it is used in medical management of gallstones, right? Because in gallstones there is increased cholesterol and less bile acid, but ursodeoxycholic acid increases bile acid concentration, so the supersaturation is going to decrease, and the extra cholesterol that was earlier forming gallstones can now bind to the bile acid. Bilirubin. So heme is metabolized by heme oxygenase to biliverdin initially, which is green in color, which is subsequently reduced to bilirubin, which is brown in color. And unconjugated bilirubin is removed from the blood by liver, conjugated with glucuronate and excreted in bile. So direct bilirubin is conjugated with glucuronic acid and it is water soluble. It is dissolved in water. And indirect bilirubin is unconjugated, and that is water insoluble. And if the conjugated bilirubin is water soluble, it can be excreted easily. Okay, and it is conjugated by glucuronic acid. So here is the RBC, and RBC is heme from the RBC is lysed. It gives rise to unconjugated bilirubin, initially biliverdin and then bilirubin, and the unconjugated bilirubin in blood binds to albumin, and then it enters the liver. So unconjugated bilirubin albumin enters the liver, and in liver through the enzyme UDP, glucuronosyl transferase, is very important enzyme. It conjugates bilirubin, so now it is called direct bilirubin, and then it is absorbed into the biliary system, and through biliary system it is secreted into the gut lumen, and the gut bacteria converts the direct bilirubin into urobilinogen. So now most of the urobilinogen is excreted in feces as stercobilin, which gives the brown color of stools. So 80% of urobilinogen is excreted in the feces, but the 20% is absorbed back from the intestine. It is called enterohepatic circulation. So 90% of the absorbed urobilinogen goes to the enterohepatic circulation, that is back to the liver. And 10% of the absorbed urobilinogen goes into the kidney. So this is going into the blood first. Okay, the absorbed urobilinogen goes into the blood first, and 90% of that goes to the liver, and 10% of that is going to the kidney. 10% of it going to the kidney, and it is excreted in urine as urobilin, which gives yellow color of the urine. So now if there is unconjugated hyperbilirubinemia, it can be due to any reason like hemolysis or infection or anything. Okay, so if there is increased unconjugated hyperbilirubin, it is going to cause dark stools, because eventually the unconjugated bilirubin from liver is going to enter the intestines, and in intestine it is going to convert into stercobilin, producing much darker stools. And if there is conjugated hyperbilirubinemia, it is going to cause darker urine. And pale stools, because conjugated hyperbilirubinemia means there is increased conjugated bilirubin in the blood, not in the intestine. So when does the conjugated hyperbilirubinemia occurs? Whenever there is an obstruction somewhere over here. So the bilirubin has been conjugated by the liver, but it is unable to enter the intestines. So what happens is conjugated bilirubin reverts back into the blood, and if it is going back into the blood, eventually it is going to get into the kidneys. And if increased bilirubin is going to the kidneys, increased urobilin will be produced in the kidneys, which will cause more yellowing or darker color of the urine, right? And as there is an obstruction here, that conjugated bilirubin is not able to enter the intestines. So if it is not able to enter the intestine, it will not be converted into the stercobilin, giving pale color to the stools, right? The causes of unconjugated hyperbilirubinemia are infections or hemolysis, or in neonatal period where there is increased production, decreased enterohepatic circulation, and decreased activity of UDP glucuronosyl transferase, that we will see later on. And reasons for conjugated hyperbilirubinemia are like obstruction, mostly obstruction, okay, or membrane transport defect like in Dubin-Johnson syndrome and Rotor syndrome, where there is no obstruction but the conjugated bilirubin cannot be transported from the enterocytes into the bile. Yeah. Now let's move on to the pathology section. So the first is aphthous ulcers. These are just regular ulcers that occurs in our mouth sometimes. They are also called canker sores. They are common oral lesions that appear as painful, shallow, round to oval ulcers covered by yellowish exudate. Okay, so here it is covered by yellowish exudate. And recurrent aphthous stomatitis is associated with either celiac disease, inflammatory bowel disorders, mostly Crohn's disease, SLE, Behcet syndrome, and HIV infections. And Behcet syndrome is signified by aphthous ulcers, genital ulcers, and uveitis. Okay. And there are some physiological changes that occur in salivary glands of old age people. So with old age, there is acinar atrophy and there is fatty infiltration that is going to block salivary secretions from entering oral mucosa. So there will be oral mucosal dryness and reduced salivary secretions. Okay. It will cause reduced saliva. The squamous cell carcinoma. It is the most common malignancy of oral cavity and it usually affects the tongue. And it is associated with tobacco, alcohol, and HPV-16. It presents as non-healing ulcer with irregular margins and raised borders. So leukoplakia, that is white patch as seen here, and erythroplakia, red patch, that is not shown here. They are precursors lesion, and erythroplakia is like 17 times more pre-malignant than leukoplakia. Okay. And cyalolithiasis is the stone formation in ducts of major salivary glands, parotid, submandibular or sublingual glands. It is associated with salivary stasis, which will cause salivary stasis in cases of dehydration and trauma. And it presents as recurrent pre or periprandial pain and swelling in affected gland. So it can be caused, the pain is occurring before the meal or during the meal, and there is also swelling in affected gland. So, one second, guys. Sorry for that, guys. Yeah, so as you can see, there is swelling over here and some erythema too. Okay. Now it is cyaloadenitis. It is inflammation of the salivary gland due to obstruction, that is because of salivary stones, infection because of Staph aureus, mumps virus, or immune-mediated mechanisms in Sjogren's syndrome. And it is always ipsilateral. And as there is inflammation of the salivary gland, if there is suppose inflammation of the pancreatic gland, there is increased lipase and amylase. But if there is infection of salivary gland, there will be increased amylase and the lipase will be normal. And it is also an adverse effects of anticholinergic drugs. Anticholinergic use can also lead to cyaloadenitis. And now we'll see the salivary gland tumors, and they are usually benign and most commonly affect the parotid gland. Submandibular and sublingual and minor salivary glands tumors are more likely to be malignant and typically presents as painless mass and swelling. Facial paralysis or pain suggest malignant involvement. So whenever there is facial paralysis or pain at the presentation, consider it malignant, because of if the benign tumor has turned malignant, it is going to expand, and if it is expanding and involving the facial nerve, then it is causing facial paralysis or pain. So the first is pleomorphic adenoma. It is a benign mixed tumor and it is the most common salivary gland tumor. It is composed of chondromyxoid stroma and epithelium and reoccurs if incompletely excised or ruptured intraoperatively, and it may undergo malignant transformation. So here is the myxoid, chondromyxoid stroma, and here are the epithelial cells. So second is Warthin's tumor. It is a papillary cyst adenoma. Papillary cyst adenoma lymphomatosum, and it is a benign cystic tumor with germinal centers, and it may be bilateral or multifocal. It is typically found in people who smoke. Warriors from Germany love smoking. So there are three things you have to remember in Warthin's tumor. First, it is a benign cystic tumor. Second, it has germinal centers. Third, it is in people who smoke frequently, and it is bilateral. So four things: it is bilateral or multifocal. The third is mucoepidermoid carcinoma. So it is the most common malignant tumor. Both of them, pleomorphic adenoma and Warthin's, are benign tumor, but mucoepidermoid carcinoma is a malignant tumor. And there is mucinous and squamous components. And mucoepidermoid carcinoma is found in the Warthin's tumor is always found in parotid gland, nowhere else. As it is a malignant tumor, mucoepidermoid carcinoma is a malignant tumor, it is going to involve facial nerve. And the pleomorphic adenoma is also a mobile tumor. You can move that tumor. You can palpate that tumor and you can move that, and it is painless. Okay, it does not cause any pain unless it's malignant. Then it is going to cause pain. Now, achalasia. Achalasia is failure of LES to relax due to degeneration of inhibitory neurons containing nitric oxide and VIP. And as we know that nitric oxide causes smooth muscle relaxation, and VIP also causes sphincter relaxation, right? So lower esophagus sphincter is not going to relax because of the lack of nitric oxide and VIP in the mesenteric or Uhrbeck plexus of esophageal wall. So this Uhrbeck plexus is responsible for the motility of the smooth muscle cells. Okay, so this is the main pathology. It is the failure of LES to relax due to degeneration. It's the failure of LES to relax due to degeneration of inhibitory neurons containing NO and VIP. So primary achalasia is idiopathic. Secondary achalasia may arise from Chagas disease, that is Trypanosoma cruzi infection, or extraesophageal malignancies, that is mass effect or paraneoplastic. And Chagas disease can cause achalasia. Okay, there is a mnemonic. And it presents with progressive dysphagia to solids and liquids versus obstruction, which is primarily solids. Okay, so whenever they say about progressive dysphagia, it is always achalasia cardia. Okay, cancer will have initially dysphagia to just solids and then liquids, but if they say about progressive, they use the term progressive, it will mostly be achalasia cardia. Okay, and first initially there will be dysphagia to liquids, right, opposite to esophageal cancer where initially there was obstruction, dysphagia to solids. Here in achalasia there will be dysphagia to liquids initially and then to solids, because if imagine this is the esophagus and this is the achalasia, there is no nitric oxide or VIP. So the LES is not relaxed, it is constricted. But if there is a solid food particle and there is liquid particle, so liquid cannot generate enough pressure to cross LES. But if the achalasia is not very severe enough, the solid particle can exert a pressure effect on the LES to relax it a bit and let the solid particles pass through the LES. So initially the dysphagia is only to the liquids, not to solids. And it is associated with increased risk of esophageal cancer, adenocarcinoma, I think. Yeah, adenocarcinoma. Manometry findings include uncoordinated or absent peristalsis with increased LES resting pressure. Barium swallow shows dilated stomach esophagus with area of distal stenosis. This is the bird beak sign. And the treatment is through surgery or endoscopic surgery, endoscopic procedures, for example, botulinum toxin injection. And you can also give nitrates and calcium channel blockers as well to relax the smooth muscle. So gastroesophageal reflux disease, it occurs due to transient decrease in LES tone. Transient decrease in LES tone, and it is commonly presents as heartburn, regurgitation, dysphagia, and may also present as chronic cough, hoarseness, which is due to laryngopharyngeal reflux. When the reflux reaches the larynx, it causes hoarseness, and it is associated with asthma. And complications include erosive esophagitis, strictures, and Barrett's esophagus. And there is a transient decrease in LES tone, and along with that, there is a decrease in the length of abdominal esophagus. It should be more than 2 centimeter, but in GERD it decreases more than 2 centimeter. And the pressure of the lower esophagus lower esophagus sphincter decreases than 6 mmHg. Length of abdominal esophagus is less than 2 centimeter, and LES pressure is less than 6 mmHg. And now esophagitis, it is a very important topic for questions. So esophagitis occurs due to reflux, infection in immunocompromised because of candida. Candida will show white pseudomembranes. HSV, it will show punched out ulcers, and CMV, it will show linear ulcers. So esophagitis occurs due to reflux, infection in immunocompromised, caustic ingestion, or pill-induced esophagitis, which is drug-induced esophagitis because of bisphosphonates, tetracyclines, NSAIDs, iron, and potassium chloride. And also calcium carbonate. Okay. And eosinophilic esophagitis is infiltration of eosinophils in the esophagus, often in patients with atopy. So atopy is a must to cause eosinophilic esophagitis, and you have to focus on the atopy. Patients with atopy in the question stem. So atopy is just the patient will have history of asthma or an allergy or something like that. And the etiology is multifactorial. So food allergens causes dysphagia, food impaction, and esophageal rings and linear furrows can often seen on endoscopy. And mostly the proximal 1/3 is affected, and these deep ulcers can also cause strictures in esophagus. And on endoscopy you will see like stacked up mucosa. You can see these kind of rings on an esophagus endoscopy. Okay, and the dysphagia and odynophagia, that is pain during swallowing or inability of swallowing, is the most significant symptom of esophagitis. And you have to differentiate between HSV1 and CMV. So grossly you can differentiate it by punched out ulcers in HSV and linear ulcers in CMV, but sometimes they will give you histological slide, and but then you have to differentiate it with histological features, like CMV will have owl-eye inclusion bodies, and HSV will have eosinophilic inclusion bodies, and thing like that. Okay, and yeah, there will be history of immunocompromisation. So there will be history of either HIV or transplant or anything like that, because only HSV and CMV, Candida, all those just affect the immunocompromised patients, right? Okay, so next is esophageal strictures. It is associated with caustic ingestion, acid reflux, and esophagitis. So all two of the above conditions can cause strictures. Now, Plummer-Vinson syndrome, it is triad of dysphagia, iron deficiency anemia, and esophageal webs. Increased risk of esophagus squamous cell carcinoma with it, and it may be associated with glossitis as well. So dysphagia, iron deficiency anemia, and esophageal web. So Plumber dice is the mnemonic. Next is Mallory-Weiss syndrome. It is partial thickness. It is partial thickness. It has longitudinal lacerations, L, because Mallory has 2L. It has longitudinal lacerations of gastroesophageal junction, confined to mucosa and submucosa only. It does not penetrate the muscularis layer, and it is caused due to severe vomiting. Often presents with hematemesis, plus or minus abdominal or back pain, and usually found in patients with alcohol use disorders or bulimia nervosa, where they precipitate vomiting. And you have to differentiate between Mallory-Weiss syndrome and Boerhaave syndrome. In Boerhaave syndrome, there is not partial thickness, there is full thickness tear, and it is not confined to just mucosa and submucosa. It affects all the layers of the esophagus, and it is also due to vomiting. It is also due to alcohol use disorder. And the symptoms are also same, but there can also be hemothorax or hemoperitoneum due to the leakage of food particles or leakage of blood into the peritoneal cavity. So esophageal varices, dilated submucosal veins, red arrows in B. So as you can see, this is the dilated submucosal veins, and that is in lower 1/3 of esophagus, secondary to portal hypertension. It is common in patients with cirrhosis, and it may be source of life-threatening hematemesis. And mostly the esophageal varices are caused due to left gastric vein. If it is in lower esophageal junction and cardiac area, but if it is in fundus area, it can also be due to splenic veins. Next is distal esophageal spasm. It is formally called diffuse esophageal spasm, and it is spontaneous, non-peristaltic, uncoordinated contractions of the esophagus with normal LES pressure. So the LES pressure is normal, unlike achalasia cardia or GERD, or for that instance any other conditions. The LES is normal in distal esophageal spasm. It presents with dysphagia and angina-like chest pain. So patient will present to the emergency with angina-like chest pain, but the ECG would be normal. So that would indicate us to an esophageal pathology. So barium swallow may reveal corkscrew esophagus. It is something like this. It is because of the spontaneous non-peristaltic contractions. It forms a corkscrew esophagus, and the manometry is diagnostic, and treatment includes nitrates and calcium channel blockers. And what is the pathology behind the distal esophageal spasm? There is just impaired neural inhibition. So there is not adequate neural inhibition, so that leads to continuous spasm, continuous contractions of the esophagus, and they are non-peristaltic. Okay, and they are the most powerful contractions. It is more powerful than the peristaltic contractions. So the manometry reading would be the highest in the case of DES. Okay, it is around more than 120 mmHg. Okay, and the contraction lasts for more than 2.5 seconds. Normal peristaltic contraction does not last more than 2.5 seconds. Okay, now scleroderma esophageal involvement. Esophageal smooth muscle atrophy causes decreased LES pressure, okay, and distal esophageal dysmotility, which will cause acid reflux from the stomach, and dysphagia, which will cause stricture, Barrett's esophagus, and aspiration as well. And it is a part of CREST syndrome. So scleroderma affects all of the smooth muscles of the esophagus. Not just esophagus, but it affects smooth muscle all around the body. But when it affects the smooth muscle of the esophagus, it is going to decrease the LES pressure, and it is going to cause dysmotility. So if the LES is now relaxed, the acid from stomach is going to reflux back into the esophagus, causing stricture, Barrett's esophagus, and aspiration. And remind you that the reflux esophagitis due to scleroderma, it is resistant to antacids. And also it is a part of CREST syndrome. So what all symptoms are included in CREST syndrome? So first is calcinosis. Second is Raynaud's phenomenon. Then esophageal dysmotility, we just talked about. Then there's finger ulcers at the tip of the fingers. Then there's telangiectasias too. Now esophageal perforation, that is called Boerhaave syndrome. It may most commonly iatrogenic following esophageal instrumentation while inserting nasogastric tube or endoscopy. Those are the iatrogenic causes. And non-iatrogenic causes include spontaneous rupture, foreign body ingestion, trauma, and malignancy. It may present with pneumomediastinum. So there is the arrow in A. So you can see the air over here too, that has leaked from the esophageal perforation. Okay. May present with pneumomediastinum. Subcutaneous emphysema may be due to dissecting air, and signs include crepitus in the neck region or chest wall. It is called Haman's crunch. The sound of crushing dry leaves, and it is because of the air which has dissected out of esophagus into the subcutaneous layers, causing subcutaneous emphysema. The Boerhaave syndrome is transmural, usually distal esophageal rupture due to violent retching. We talked about this. It is due to violent retching in alcohol use disorder patients or bulimia nervosa patients. It is due to vomiting, and during vomiting the stomach pressure increases against the closed glottis, right? So that causes these kind of perforations. And in Boerhaave syndrome, there is Mackler's triad, which consists of retching, sub subcutaneous emphysema, and chest pain. This is the Mackler's triad, and Haman's crunch is like a sound of dry leaves, or it is also sound occurring like when you are walking on snow, and the sound you get is similar to Haman's crunch. Okay, done. Yeah, what is the most common site of esophageal perforation? The most common site is left posterior lateral wall of lowered 1/3 of the esophagus. So let me just write it down quickly. Most common site is left posterior lateral wall of lower 1/3 esophagus. Now the Barrett's esophagus. It is a specialized intestinal metaplasia. What is the meaning of metaplasia? Okay, so metaplasia means there is an abnormality in the structure which shouldn't be there, like it should be somewhere else. So here there is a stomach should have stratified squamous epithelium, but it is replaced by another epithelium called columnar epithelium, which is a normal structure but at an abnormal site. Okay, I don't remember the exact definition of metaplasia. Okay, so that is replacement of non-keratinized stratified squamous epithelium with intestinal epithelium, that is non-ciliated columnar with goblet cells. Arrow in B in distal esophagus. And it is due to chronic GERD, and it is associated with increased risk of esophageal adenocarcinoma. So during chronic GERD, the lower esophagus comes in contact with the acid produced by the stomach, right? So to protect its own mucosa, the esophagus undergoes metaplasia, and it forms a non-ciliated columnar epithelium with goblet cell in order to try and protect itself from the acidic damage of the stomach. Okay. And it can be seen as a red velvety mucosa, like here. It is a red velvety mucosa. Okay, and if you want to see the Barrett's esophagus clearly, it can be seen with a dye called methylene blue. So that will show us both Barrett's as well as adenocarcinoma in situ. Another. Okay. Yeah. Let's see the diagram. So these are goblet cells. So see, this is the stratified squamous epithelium, but here there is a breach and there is formation of ciliated columnar epithelium with goblet cells. Esophageal cancer, it typically presents with progressive dysphagia, first solids and then liquids, which is opposite to achalasia. In achalasia, earlier there was dysphagia towards liquid and then solids, but in cancer, first there is dysphagia to solids and then liquids. And it is aggressive course due to lack of serosa in esophageal wall, allowing rapid extension. So poor prognosis due to advanced disease at presentation. And it shows us apple core lesion. So here is the tumor narrowing the lumen of the esophagus. So there are two types of esophageal cancer. The first is squamous cell carcinoma and second is adenocarcinoma. So squamous cell carcinoma is found in the upper two-thirds of the esophagus. It is caused by everything that irritates the wall of the esophagus, like alcohol, hot liquids, caustic strictures caused by caustic soda, smoking, and echinacea cardia. Okay, and also nitrosamine foods. These all things irritate the esophagus, causing squamous cell carcinoma. It is the most common cancer worldwide, most common esophageal cancer worldwide. And adenocarcinoma is found in the lower one-third of the esophagus, and it is caused by GOBS. GERD, obesity, Barrett's, and smoking. You have to remember each and every one of the risk factors, because there are tons of questions which will be asked on the basis of differentiating the risk factors. Okay. You have to remember these by heart, and it is more common in America. Squamous cell is more common worldwide, but in America, adenocarcinoma is the most common. And histologically speaking, squamous cell carcinoma will show you keratin pearls and nets of cells. And adenocarcinoma will show you pleomorphic, that is, all the cells will be different, pleomorphic, irregular shaped glands. Squamous cell carcinoma is also caused by esophageal web and lye ingestion. Okay. And accumulated food, because if the food is getting accumulated, it is going to rot and irritate the esophagus, causing squamous cell carcinoma. Okay. So the next topic is gastritis. Acute gastritis. Acute gastritis is an erosion, not an ulcer. Okay. So what did we learn? That erosions are just in the layer of mucosa and submucosa, but ulcer can penetrate even deeper than the submucosal layers. So erosions can be caused by NSAIDs, burns, and brain injury. So how does NSAIDs cause acute gastritis? So as we know, NSAIDs inhibit the prostaglandins E2 synthesis. So if there is prostaglandin decrease, there will be decreased gastric mucosa protection, because one of the function of prostaglandin is to form a protective layer above the gastric mucosa in order to protect it against the acid. So now if prostaglandins are decreased, there is no protection, there is less gastric mucosa protection. Second is burns. So in burns, there will be hypovolemia and shock-like situation, right? In hypovolemia or ICU patients. So hypovolemia is going to cause mucosal ischemia, which is going to weaken the mucosal layer, which is going to make it more susceptible to erosions. and it is called curling ulcer. It is most commonly seen in ICU patients or sepsis patients or intraoperative patients where there have been a case of hypotension. Okay, so if the question stem says that the patient underwent hypotension during a surgery or in sepsis, there is hypotension, right? So whenever they say that there is hypotension, and then 1 or 2 days later the patient started having epigastric pain or even hematemesis, you have to think of curling ulcers. And the third is brain injury, that is Cushing ulcers. It is due to increased vagal stimulation, which will cause increased acetylcholine and increased acid production. We saw that vagal stimulation causes acid production. And these burns ulcer, that is curling ulcers, are most commonly found in proximal duodenum. And the brain injury, the Cushing ulcers, can be found anywhere in esophagus, stomach, or even distal duodenum. It is especially common among patients with alcohol use disorder and those taking daily NSAIDs, like for rheumatoid arthritis or osteoarthritis. Now the chronic gastritis. Chronic gastritis is caused by mucosal inflammation, often leading to atrophy of the mucosa. So if there is atrophy of the mucosa, there is also going to be atrophy of parietal cells. And if there is atrophy of parietal cell, there is going to be decreased acid production. So that is going to increase the pH. So what is increase of pH called? It is called alkalinization. And as we learned that alkalinization increases the gastrin production, so it is going to cause hypergastrinemia and hypochlorhydria. And intestinal metaplasia, so there is always increased risk of gastric cancer with chronic gastritis. Gastrin is secreted from G cells, right? So if there is hypergastrinemia, it is because of G cell hyperplasia. There are two reasons for chronic gastritis. The first is H. pylori and the second is autoimmune etiology. So H. pylori is definitely more common in the developing countries and autoimmune is more common in the developed countries. Almost around 50% of the world population is affected by or infected by H. pylori at some point of their life, and it increases the risk of peptic ulcer disease and malt lymphoma. It affects the antrum first and then spreads to the body of stomach. And the autoimmune affects the body first and then the rest of the stomach, either body or fundus. And autoimmune has autoantibodies, T cell induced, to the H plus, K plus, ATPase pump on parietal cells and to intrinsic factors. So it causes increased risk of pernicious anemia. Because it is all going to affect the parietal cells, there is going to be reduced intrinsic factor, which is going to cause decreased B12 absorption. B12 is required in maturation of erythrocytes, right? So that is going to cause pernicious anemia or megaloblastic anemia. And the parietal cells are going to decrease as well in numbers. And yeah, and how does H. pylori causes malt lymphoma? Because of chronic immune stimulation. So H. pylori is chronically present in so So H. pylori is chronically present in stomach, right? So it is going to recruit more and more T cells over the period of time, and that T cells are going to proliferate and start its own chain of production, and that is eventually going to form T cell lymphoma, that is malt lymphoma. And also H. pylori contains urease and protease that facilitates its penetration into the mucosa, and urease and protease is going to digest mucosa, and that is going to weaken the mucosa. And as there is urease present in H. pylori, one of the lab tests called urease test is helpful in diagnosing H. pylori infection. So what H. pylori produces urease, right? So what is the function of the enzyme urease? It converts urea into ammonia, and if the ammonia is produced, the pH is going to increase, right? It is going to alkalinize the environment, and that is going to turn the litmus paper into, it is going to change the color of litmus paper, indicating that there is urease present. Okay, so if the urea is getting converted into ammonia, the ammonia is going to change the color of the indicator, suggesting us that urease is present, which indicates that H. pylori is present. And it is done in the endoscopic biopsy sample, the biopsy taken from the stomach. And mostly, if you want to differentiate between the epigastric pain and the question stem, that mostly epigastric pain presenting in the office is just functional dyspepsia. Most of the epigastric pain, around 80%, are just functional dyspepsia due to irregular secretion of the acid. And if there is epigastric pain in an IPD patient in the question stem, it is mostly due to acute gastritis. And if it says that there is tenderness present too, not epigastric pain is a symptom and tenderness is a sign. So if they say tenderness is present, it is most likely to be pancreatitis in step 1. Okay, now Menetrier's disease, and it is hyperplasia of gastric mucosa forming hypertrophied rugae, and it is wavy like brain gyri, like these, and it causes excess mucus production with resultant protein loss and parietal cell atrophy with decreased acid production. So there is resultant protein loss causing protein enteropathy and also acid loss. Okay, so it is opposite to Zollinger-Ellison syndrome, where there was parietal cell hypertrophy, right? If you remember. And there was increased acid production. And mind you, it is a precancerous lesions, and as you can see here, these are the rugae, hypertrophied rugae in the stomach, in the body or fundus area of the stomach. It does not involve antrum, it just involves body and fundus, and it presents with weight loss, anorexia, vomiting, and epigastric pain and edema due to protein loss. The edema is due to protein loss. So the mnemonic is weight loss, anorexia, vomiting, epigastric pain, and edema. And it is due to increasing transforming growth factor alpha and endothelial growth factor receptors, increase in TGF alpha and increase in EGFR alpha. Okay, so wherever there is TGF alpha, there is going to be fibrosis and hypertrophy. So in that same instance, Menetrier's disease has TGF alpha increased. It is also associated with CMV virus in children. We'll see gastric cancer. So most commonly it is gastric adenocarcinoma, lymphoma, GI stromal tumor, or carcinoid, which is very rare neuroendocrine tumor, and early aggressive local spread with node and liver metastasis. And it is the most common cause of gastric outlet obstruction in adults. It is often presents late with weight loss, early satiety, abdominal pain, obstruction, and in some cases acanthosis nigricans or lesser prelat sign. And first, let's see the two types of gastric cancer. The first is intestinal type, and the second is diffuse type. So, intestinal, as the name suggests, it resembles an intestinal cancer or a colon cancer. It is associated with H. pylori and dietary nitrosamines like smoked foods common in East Asian countries, right? Tobacco smoking, achlorhydria, and chronic gastritis. All the things that are irritating the stomach, like H. pylori, nitrosamines, tobacco smoking, achlorhydria, or chronic gastritis. And it is common on less curvature, looks like ulcer with raised margin. And the diffuse is diffused cancer, so it spreads diffusely across the wall of the stomach. It is not associated with H. pylori. Most cases are due to E. cadherin mutation causing signate ring cells. It is mucin filled cells with peripheral nuclei. So the mucin gets filled in the cell and pushes the nucleus towards the periphery, causing signate ring cells, like you see here. So the nucleus, as you can see, is pushed to the periphery, and the cytoplasm is filled with mucin. It forms stomach wall grossly thickened and leathery. So the stomach wall is grossly thickened because the tumor spreads in the gastric wall rather than intraluminally. The intestinal tumor is going to spread intraluminally, causing the gastric outlet obstruction earlier than the diffuse one. And the diffuse tumor spreads in the stomach wall, causing stomach wall thickness. Tumor spreads within the wall, and it has a leathery appearance called linitis plastica. Also, intestinal tumor is more common in male than women. Diffuse is more common in women than male. And it looks like ulcers with raised margins. So any ulcer with raised margins is suspicious for malignant ulcer. Okay. And histologically speaking, there is these are the features of intestinal type. Like there are glandular structures with intestinal like columnar or cuboidal cells. So intestine has columnar or cuboidal cells, right? So in the intestinal type there will be glandular structures plus columnar or cuboidal cells. And in diffuse there is going to be plaque-like infiltration of stomach wall causing linitis plastica and signet ring cells. There will be no glands present in diffuse type. There are glandular structures in intestine but not in diffuse type. And also, strangely, blood group A people are more susceptible to intestinal type of stomach adenocarcinoma. Now we'll see the features of metastasis in stomach cancer when it involves distant lymph nodes. So Virchow's node is involvement of left supraclavicular node. Okay, by metastasis from stomach. Krukenberg tumor is metastasis to ovaries, which is typically bilateral, and abundant mucin secreting signet ring cells are found in the ovaries, suggesting a metastasis. Sister Mary Joseph nodule is subcutaneous periumbilical metastasis. Blummer shelf is palpable mass on the digital rectal exam, suggesting metastasis to rectouterine pouch, that is pouch of Douglas. And mostly Krukenberg tumor has signet ring cells, so it is more common with diffuse type. And the sister Mary Joseph nodule is more common with intestinal type. There is also Irish node, which is a metastasis to left axillary lymph nodes. Then there's also Trozo syndrome, which it is called migratory thrombophlebitis, which is a sign of stomach cancer. Not Trozo sign, but Trozo syndrome. Trozo sign is a sign of hypocalcemia. There is also lesser Trelette sign. There is hyperpigmentation on the back, and then there's tripe palms. There's hyperpigmentation on the palms, on the dorsal surface of the palms. Yeah, sorry that I said mild lymphoma is due to T cells. It is not due to T cells, but it is due to accumulation of B cell. It is a B cell lymphoma. Now the peptic ulcer disease. The first is gastric ulcer and duodenal ulcer. So gastric ulcer can be greater with meals. The pain can be greater with meals. So there is associated weight loss. So whenever you have a meal, the pain starts occurring. So you tend to eat less, which is causing the weight loss. And it is due to H. pylori in 70% of the cases. And the mechanism is decreased mucosal protection against gastric acid. Because the H. pylori weakens the mucosa, there is decreased mucosal protection against the gastric acid. So that gastric acid will now erode the gastric mucosa. And other causes are NSAIDs, and risk of carcinoma is increased with gastric ulcer, but not with duodenal ulcer. And you have to biopsy the margins to rule out the malignancy. You don't have to biopsy the surface of the base of the ulcer, but you have to biopsy the margins. Okay. And duodenal ulcers decreases with meal, so you tend to have weight gain. The 90% of it is affected by H. pylori, and it has the similar mechanism, that is decreased mucosal protection and increased gastric acid secretion. And other causes are Zollinger-Ellison syndrome, which is gastrinoma. So that usually affects the distal duodenum, not even proximal duodenum. The proximal duodenum ulcers are very common with H. pylori, even more common with H. pylori than gastric ulcers. Okay. So mostly you have to understand that H. pylori affects the body of the stomach, right? Body and the not body and the fundus. H. pylori affects the antrum of the stomach, right? So from antrum, if the H. pylori is living in the antrum, it is going to cause duodenal ulcers more commonly, right? Either than gastric ulcers. Okay. And yeah, it is generally benign. and they are not routinely biopsied, because it is taken that the 90% of the duodenal ulcers are because of H. pylori. And if the ulcers are in distal duodenum, then it can be suspicious of gastrinoma. But if it is in the proximal duodenum, it is most commonly due to H. pylori, hence they are not biopsied. Now, what are the complications of ulcer? So complications of ulcer include hemorrhage, obstruction, and perforation. Hemorrhage is more common with gastric, and perforation is more common with duodenal ulcers. So hemorrhage is caused by gastric ulcer, duodenum, and duodenum posterior more than anterior ulcers, and is the most common complication. Ruptured gastric ulcer on the lesser curvature of the stomach causes bleeding from the left gastric artery, because left gastric artery supplies the lesser curvature. Okay, and the greater curvature is supplied by the short gastric artery and left gastroepiploic arteries. And ulcer on the posterior wall of duodenum will cause bleeding from the gastroduodenal artery, because gastroduodenal artery lies immediately behind the first part of the duodenum. Okay. And what lies behind the third part of the duodenum? Aorta lies behind the third part of the duodenum, and superior mesenteric artery lies anterior to the third part of the duodenum, that is transverse duodenum. And that is the reason in superior mesenteric artery syndrome there is occlusion of third part of duodenum. Okay, and the obstruction is caused in pyloric channel or in duodenal. And perforation is more common with duodenal ulcers, and it is most commonly anterior, because posterior duodenum is much supported by fat and everything. And so the anterior duodenum perforation is more common than gastric ulcer, and anterior duodenal ulcers can perforate into the anterior abdominal cavity, potentially leading to pneumoperitoneum. You may see free air under the diaphragm. Sorry, just a second, guys. You may see free air under the diaphragm, pneumoperitoneum, as you can see in this X-ray. So this is the free air, right, with referred pain to the shoulder via irritation of the phrenic nerve. So most commonly it is referred pain to the left shoulder. Now let's first differentiate between a benign ulcer and malignant ulcer, then going to the GI bleeding. So what is the difference between, let me use different colors for a change. Benign ulcer and malignant ulcer. So benign ulcers are round and regular, whereas malignant are irregular and larger. Benign ulcers are punched in ulcers, but malignant ulcers have punched out appearance. The margins are normal in benign, but the margins are everted in malignant, and they look like they are piling up on each other. So margin starts piling up. Here in benign there are converging ulcers like this. So here the margin of the ulcers has higher height than here, so it looks like it is converging, and in duodenum ulcer it is diverging ulcer. If this is the ulcer, so here the height of the margins is greater than here, so it looks like it is diverging ulcer. Mostly benign ulcers are on the lesser curvature, malignant ulcer is on greater curvature. There is granulation tissue found in the base of a benign ulcer, and there is necrotic slough on the base of malignant ulcer. Now, acute gastrointestinal bleeding. So upper GI bleed originates proximal to the ligament of Treitz. It is a suspensory ligament of duodenum. Okay. It joins the duodenum jejunal flexure to the right crus of diaphragm. So it holds the duodenum in its position. If the ligament of Treitz is not here, this part of duodenum is going to fall down, but it is held by the ligament of Treitz. Usually presents with hematemesis or melena. It is associated with mostly peptic ulcer disease or variceal hemorrhage or adhesions from past surgery. Lower GI bleed originates distal to the ligaments of Treitz, usually presents with hematochezia. It's associated with inflammatory bowel disease, diverticulosis, angiodysplasia of the colon, hemorrhoids, anal fissure, and colon cancer. It's as simple as that. So now malabsorption syndromes. It can cause diarrhea, steatorrhea. Steatorrhea is fat mixed in the stools, weight loss, weakness, vitamins, and mineral deficiency. And you have to screen for fecal fat, that is Sudan stain, with the help of Sudan stain. You have to screen for fecal fat because fat is the first nutrient that is going to be affected in the malabsorption syndromes. So the first is celiac disease. It is also called gluten sensitive enteropathy, celiac sprue, and autoimmune mediated intolerance of gliadin. It is a gluten protein found in wheat, barley, rye, and oats. It is associated with HLA DQ2 and DQ8 in the northern European descent. This primarily affects distal duodenum or proximal jejunum, but just remember that it affects distal duodenum. It causes malabsorption and steatorrhea. The treatment is gluten-free diet. And there is also abdominal distension present with it, and iron deficiency anemia too. It is associated with dermatitis herpetiformis, decreased bone density, and moderately increased risk of malignancy, that is T-cell lymphoma. Because as it is autoimmune mediated, there is accumulation of T cells within the villi of the duodenum. Okay, so that T cell proliferation gives rise to T cell lymphoma. Just like proliferation of B cells in H. pylori was giving rise to B cell malt lymphoma, and the D-xylose test will be abnormal. So D-xylose test is abnormal in any malabsorption syndrome affecting the small intestine. If there is malabsorption due to like obstruction of common bile duct or any pancreatic pathology, the D-xylose test would be normal. Okay. Because D-xylose is a monosaccharide that is absorbed from the intestinal surface. So if the intestinal surface has any pathology, the D-xylose absorption could be impaired. The serology shows IgA positive, anti-tissue transglutaminase, IgA TTG, and anti-endomysial and anti-deamidated gliadin peptide antibodies. And histology will show villus atrophy and Crep's hyperplasia, and there is intraepithelial lymphocytosis. So this is supposed to be a villi, but as it has atrophied, it has become flattened. And these are the crypts. As you can see, the crypts has hypertrophy, and there is presence of lymphocytes, or all these basophilic cells are lymphocytes. And it affects duodenum more than ileum and jejunum. Therefore, as we saw that iron is absorbed in the duodenum, it is causing iron deficiency anemia. And remind that it does not cause B12 deficiency. B12 deficiency is caused in tropical sprue and Whipple's disease, which affects ileum more than the duodenum. And mostly celiac disease is seen from childhood. As soon as the child converts from breastfeed to any other meals, like of the adults, like wheat or barley or rye, and the symptoms of celiac disease comes as soon as the feed is transformed from breastfeeding to wheat, barley or rye feeding. If you want to see the diagram, there is gluten in barley, rye and oats, and in those gluten there is gliadin protein, and gliadin goes into the intestine, gets absorbed into the intestine, and through tissue transglutaminase it is deamidated, and that deamidated gliadin is presented with the help of APC, antigen presenting cell, to the T cells, and the T cell transforms B cell to form antibodies towards that gliadin protein, and those antibody targets tissue transglutaminase, deamidated gliadin and anti-endomysial antigens. And because there is an inflammation autoimmune reaction, there is also recruitment of T cells and lymphocytes. Initially there is just crypt hyperplasia, and then after villus atrophy occurs. As I said, celiac disease presents as 6 to 24 months as the child is wearing off from the breast milk. It is associated with IgA nephropathy as well, type 1 diabetes and Down syndrome. And why does this dermatitis herpetiformis occurs? Because we saw that there is positive IgA antibodies, right? So IgA separates the dermis and epidermis layer, causing dermatitis herpetiformis. Lactose intolerance. So there is deficiency of lactase enzyme, and there is normal appearing villi except when secondary to injury at the tips of villi, that is viral enteritis that occurs in adults. It causes osmotic diarrhea with decreased stool pH because colonic bacteria ferments lactose. So what happens is lactase is supposed to metabolize lactose. Now if the lactase is not present, there is increased lactose in the intestinal lumen. So the intestinal bacteria is now going to ferment that lactose and going to make an acidic environment, which decreases the pH. And as there is increased lactose in the intestinal lumen, it is also going to form a positive lactose hydrogen breath test. If post lactose breath hydrogen value increases more than 20 parts per million compared with the baseline. And the stool pH also decreases because lactose gets converted into short chain fatty acids, acetate, butyrate and propionate, causing decrease in pH of the stool, and the stools are bad odor stools, and the histology is normal. That is how you differentiate lactose intolerance with all of the other conditions. Like in questions time, it will be given that the histology is normal and there is no villus atrophy, or there is no lymphocytes or macrophage accumulation. Macrophage accumulation is in the Whipple's disease. Okay. And now we'll see the malabsorption caused by pancreatic insufficiency due to chronic pancreatitis, cystic fibrosis, or obstructive cancer. It causes malabsorption of fat and fat-soluble vitamins, that is vitamin A, D, E, K, as well as vitamin B12. Because pancreatic protease detaches the R protein from the B12. R protein or B12 protein. So yeah, detaches the R protein from the B12, so that B12 can now be absorbed in the ileum, terminal ileum. So if the pancreatic insufficiency is there, it is not going to detach the R protein, causing vitamin B12 deficiency as well. And there is decreased duodenal bicarbonate and pH. As the bicarbonate has decreased, pH is going to decrease towards the acidic side. And fecal elastase has also decreased. Fecal elastase is released from the pancreas. Okay, and the D-xylose test is normal, because D-xylose is absorbed from the normal intestinal surface area, and the intestinal surface area is normal in pancreatic insufficiency. Now, tropical sprue. Tropical sprue has similar findings as celiac sprue. It affects the small bowel, but it responds to antibiotics, and the cause is unknown but seen in residents of or recent visitors to tropic, and it is very common, not very common, but it is comparatively more common in the South Indian areas. Okay. Decreased mucosal absorption affecting duodenum and jejunum, but can involve ileum with time. But you just have to remember that it affects jejunum more than duodenum. Okay. It is associated with megaloblastic anemia due to folate deficiency and later B12 deficiency. Because folate is absorbed from the jejunum area, and B12 deficiency is present later on because ileum is involved later on. Okay. Now, with tropical sprue, there is an infection, so it responds to antibiotics. So there should be a history of infectious diarrhea with fever, abdominal pain, all that. Okay. And mostly Caribbean, there is a history of Caribbean travel or travel to tropical regions. The last is Whipple's disease. It is infection with Trophirema whipplei, and it is an intracellular gram-positive organism. So it is going to cause periodic acid shift stain positive foamy macrophages in intestinal lamina propria. So if this is the macrophage, there is organisms inside those macrophages, and in mesenteric nodes. Foamy macrophages are also present in mesenteric nodes. It is going to involve three systems. That first is cardiac, second is arthralgias, and third is neurological symptoms. And diarrhea and steatorrhea occur later in the disease course. First, all these three systems are involved, and then after diarrhea and steatorrhea occur, and it is most common in older males. So there is minimal inflammatory response, right? Because the organism is within the macrophages, and it interferes with the phagolysosome formation. Okay. So Trophirema whipplei is within the macrophage, where it interferes with the phagolysosome formation. and it can affect all the parts of intestine. Celiac disease was involved in just duodenum. Tropical sprue was affecting jejunum and ileum, but Whipple's disease can affect all the parts of intestine. Okay. So there would be B12 deficiency present. There can also, in cardiac symptoms, there is culture negative endocarditis. And there is dementia in neurological symptoms, supranuclear palsy, and opsoclonus myoclonus. And the treatment is antibiotics again, just like tropical sprue. And also, as we discussed malabsorption syndromes, let's also discuss malabsorption with a vegan diet. So vegan diet includes all of the animal products, not just animal meat but also dairy products if it is a vegan diet. So what all nutrient deficiencies can be present? There can be vitamin D deficiency, calcium deficiency due to less milk intake. There can be B12 deficiency, zinc deficiency. Okay. And there can also be iron deficiency. Iron deficiency is very important. However, there is no folate deficiency, okay? Because folate is present in green leafy vegetables as well. Inflammatory bowel disease. Crohn's disease and ulcerative colitis disease. Crohn's disease can affect any portion of the GI tract. From mouth to anal canal, it can cause ulcers in the whole GI tract. Okay. Usually the terminal ileum and colon. And there is skip lesions with rectal sparing. So rectum is never ever involved in Crohn's disease, but rectum is always involved in ulcerative colitis disease. So ulcerative colitis is itis, which stands for inflammation in the colon. There is colitis, there is continuous colonic lesions, and it always starts with rectal involvement. So gross morphology is transmural inflammation is in Crohn's disease, so it affects all the layers of the intestine. And if it is affecting all the layers of the intestine, there can be fistulas. If it is not affecting all the layers, there would just be diverticulosis, right, in colon. But as it is affecting all the layers, it can cause fistulas. If this is one layer and this is the second layer, there will be fistula between both of these layers. Okay. There is cobblestone mucosa, and there is creeping fat, bowel wall thickening. Because it is a transmural inflammation, there is bowel wall thickening, and it will cause a string sign on small bowel. So this is the string sign. This is the lumen of the bowel. Because the wall has thickened on both the sides, the lumen has narrowed. There can be linear serpiginous ulcers. Okay. And there can be also be fissures. And ulcerative colitis just affects mucosal and submucosa. So there is no transmural inflammation, but there is friable mucosa with superficial or deep ulcerations. and compare normal bowel with diseased bowel. So it is an inflammation, right? So there would be erythema, there would be blood vessel dilatation, and there would be because of erythema the mucosa will appear velvety red. And there are loss of rostra which will cause lead pipe appearance on imaging of the colon. One way you can memorize all of these points are through a mnemonic called ulcers. U stands for ulcers, that is ulcerative colitis. L is it affects large intestine. C stands for continuous involvement. It is its ability to cause colorectal cancer in future and having crypt abscess histologically. And E stands for it extends proximally. It starts from rectum always and then it extends proximally. And R stands for red diarrhea. So the symptom of ulcerative colitis is bloody diarrhea with pain on either left lower quadrant or middle lower quadrant, but there is bloody diarrhea involved. And ulcers, so S stands for sclerosing cholangitis. It is also associated with primary sclerosing cholangitis found in male. And Crohn's disease have all the S. S and the C's. So S is for skip areas. The ulcers aren't continuous, but there are skip areas in between. Crohn's disease can also cause small aphthous ulcers in the mouth too and in the intestines too. S stands for serpiginous linear ulcers. C stands for cobblestoning. C stands for creeping fat. So creeping fat is just fat coming over the loops of intestine. If this is the loop of intestine, the creeping fat is going to come above. It creeps around the intestine. And eventually it covers the whole intestine. That is called creeping fat. Now, microscopic morphology, there is non-caseating granulomas. Remember, it is non-caseating, not caseating. Caseating is in tuberculosis of the intestine, but here it is non-caseating granulomas, and there would be lymphoid aggregates. And in ulcerative colitis, there is going to be crypt abscess. If these are the villi, these are the crypts, and there is going to be abscess here. So there is going to be accumulation of lymphocytes, neutrophils in here, causing an abscess. And there would be ulcers, bleeding, and there would be no granulomas. The complications, and also in Crohn's disease there is lymphoid aggregates, and there would also be lymph node enlargement. And complications include malabsorption, malnutrition, and colorectal cancer. That is increased risk with pancolitis. It is more seen with ulcerative colitis. There is going to be fistula in Crohn's disease. Fistula that can also open into the skin. That can be enterovesical fistula, which can cause recurrent UTI. Enterovesical fistula is from intestine to the bladder. It can cause recurrent UTI and pneumaturia, which is air in the bladder wall. Okay. There can be phlegmon, abscess, strictures causing obstruction, and perianal disease. So the fistulas can also open perianally. And in ulcerative colitis, the complications are lesser but more severe. Okay. It can cause fulminant colitis, it can cause toxic megacolon, which is more common than both of them, and the toxic megacolon can cause perforations as well. And there are pseudopolyps found in ulcerative colitis. So you have to differentiate in gross examination between the polyps and the cobblestoning. So cobblestones are very small protuberances, while the pseudopolyps are bigger than the cobblestones. And why does this toxic megacolon occurs? Because there is an inflammation, right? And there is stasis, so the intestinal bacteria secretes nitric oxide, and nitric oxide is going to relax the smooth muscles of the colon and the rectum, causing stasis over there or dilatation of that area, causing toxic megacolon. Intestinal manifestation includes diarrhea that may or may not be bloody, and there is abdominal pain. Mostly it is a right lower quadrant pain, and it is of crampy nature with Crohn's disease, and pain that is relieved with diarrhea. In ulcerative colitis, there is bloody diarrhea, which is usually nocturnal and with pain. Okay, there is always bloody diarrhea with ulcerative colitis because there is an inflammation. Extraintestinal manifestations include rash, that includes pyoderma gangrenosum, erythema nodosum, eye inflammation, that is episcleritis or uveitis, oral ulceration, aphthous stomatitis, arthritis, peripheral, and spondylitis. It can also cause kidney stones, usually calcium oxalate stones. Okay. And I used to remember why it causes calcium oxalate stones. Yeah, so there is malabsorption of free fatty acids in the intestine, right, because of the Crohn's disease. It is an intestinal pathology, so that is going to cause malabsorption of the free fatty acids. So that accumulated free fatty acids combine with the calcium. Okay, so now the oxalate is being free, and that oxalate is absorbed in the blood and goes to the kidney, causing calcium oxalate stones. It may be positive of ASCA, that is anti-Saccharomyces cerevisiae antibody, and Crohn's disease and ulcerative colitis can be associated with primary sclerosing cholangitis, as we talked about, which is found mostly in men. It is associated with MPO, ANCA, and P-ANCA. Here it is ASCA, and here it is P-ANCA. So where else the P-ANCA is positive? In Wagner's and short stress. So that is microscopic polyangiitis and short stress. No, I don't think in Wagner's it is positive. It is positive in microscopic polyangiitis and short stress. They should have kept the name Wagner's and short stress instead of changing their names. Treatment is glucocorticoids, azathioprine, and antibiotics, including ciprofloxacin, metronidazole, and biologics, that is infliximab and adalimumab, that are TNF alpha inhibitors. Okay. And in ulcerative colitis, it is 5 amino salicylic acid preparations, which includes mesalamine. Okay. There's 6 mercaptopurine, infliximab, and colectomy is the last resort. And colectomy is curative for ulcerative colitis. All other these treatments are not curative. They are just helps reducing the disease progression. And Disease activity is measured by fecal calprotectin, which is used to monitor activity and distinguish from non-inflammatory bowel disease, which is inflammatory bowel disease. So fecal calprotectin is increased in inflammatory bowel disease. And what all carcinomas are associated with both of these diseases? With Crohn's disease, cholangiocarcinoma and non-Hodgkin's lymphoma is common, and with ulcerative colitis, colorectal carcinoma is common. And also there will be skin changes in Crohn's disease, okay, because there will be right lower quadrant pain, and there can be abscess formation, as we saw. There can be fistulas, there can be abscess formations, there will be stricture formations, so that can cause abdominal swelling. Okay. This is ulcerative colitis. As you can see, these are the ulcers. As you can see, there is the mucosa is red and velvety, that signifies ulcerations. This is the non-caseating granuloma found in Crohn's disease, as you can see. This is the necrosis. Red part is the necrosis. Okay. And then there's multinucleated giant cells with many multinucleated. So there are many nucleus inside this blue part. Okay. This is a good table that I found from Emboss library. As you can see, there is cobblestoning. I can't use my Apple Pencil here in the gallery app. Otherwise, I will show you the cobblestoning. But the small protuberances that you can see are cobblestoning. There are small ulcers as well. They are aphthous ulcerations. So this is Crohn's disease. This is Crohn's disease as well. You can see serpiginous ulcer, right? This is the serpiginous linear ulcers found uniquely in Crohn's disease. And this is ulcerative colitis. So you can see the mucosa is erythematous, and it has also, because of the edema formation, everything looks like swelling and boggy. Okay. There is loss of superficial vascular markings, see several linear semi-confluent ulcerations. Okay. Yeah, this is a fulminant ulcerative colitis. The mucosa is edematous. The superficial vascular pattern has been lost. And as you can see, there are pseudopolyps. These are the pseudopolyps. Okay, they are larger than the cobblestones that as I said, that pseudopolyps are larger than the cobblestones. Yeah, this is a clearer image. These are the pseudopolyps found in ulcerative colitis. This is the histology of ulcerative colitis. Like, there are neutrophils here. Neutrophil accumulation is here. These, as you can see, these are the crypts that are filled with neutrophils, lymphocyte infiltrates, and it is causing crypt abscess. And then there's continuous inflammation. There is no sparing like there is in Crohn's disease. And here pseudopolyps has started to form. They are formed by an overriding regeneration of the epithelium and can be clearly differentiated endoscopically from the surrounding mucous membrane. Okay, ruling out inflammation associated dysplasia, which can easily degenerate, is important in diagnosing ulcerative colitis. So if there is just dysplasia, they can be easily degenerated, but pseudopolyp formation in ulcerative colitis cannot be degenerated that easily. And one last thing, that ulcerative colitis will have large bowel diarrhea because it is affecting the large intestine, right? Large bowel diarrhea. And Crohn's diseases will cause small bowel diarrhea. So what is the difference between both of them? Large bowel diarrhea have small volume, large frequency or greater frequency of stool, and it will be positive with pus and blood. And tenesmus will be positive. Tenesmus is an urge to pass stools, but instead of stool passing, you just pass pus and blood. And the small bowel diarrhea is large volume, small frequency. So I wrote it this way in order to remember that large bowel, small volume, large frequency, large, small, large, and small diarrhea includes large volume and small frequency, small, large, small. Now, microscopic colitis, inflammatory disease of the colon that causes chronic watery diarrhea, most common in older females. Colonic mucosa appears normal on endoscopy. This is the key distinguishing feature, and it is not a very important topic, this microscopic colitis, because I have not faced any questions on this microscopic colitis. Histology shows lymphocytic infiltrate because it is a chronic inflammation in lamina propria with intraepithelial lymphocytosis or thickened subepithelial collagen band. So there will be lymphocytes, there would be collagen bands, there would be older females, okay, and there will be chronic watery diarrhea. That's it. Now, irritable bowel syndrome. Recurrent abdominal pain associated with more than two of the following related to defecation, change in stool frequency or consistency of the stool. So there is abdominal pain that is recurrent, and there has to be at least two of the three conditions. It is related to defecation, abdominal pain related to the defecation. There is change in stool frequency, like now the stools have been pallet-like or okay. And that is the consistency of the stool. That stool is pellet-like or liquid-like, and there is change in stool frequency. There is increase in stool frequency. Sorry. And there is no structural abnormalities. The histology is also absolutely normal. Is most common in middle-aged females, middle-aged working females, And chronic symptoms may be diarrhea predominant or constipation predominant or mixed. Pathophysiology is multifaceted, may be associated with fibromyalgia and mood disorders, that is anxiety and depression. So first line treatment is lifestyle modification and the dietary changes. And it is in the middle-aged females, so the diagnostic criteria states that the female should not be older than 45 years of age. And now appendicitis. This is the acute inflammation of the appendix, which we can see here. There is fluid accumulation around the abdomen. There is also a little bit of swelling, edematous appendicitis. Okay. And there's fecalith obstructing the lumen of appendicitis. It can be due to obstruction by fecalith, which is red arrow in A in adults, or lymphoid hyperplasia in children. So it leads to proximal obstruction of appendiceal lumen. It forms a closed loop obstruction, increased intraluminal pressure, stimulation of visceral efferent nerve fibers at T8 to T10. So there is initial diffuse periumbilical pain because of visceral efferent nerves, and then there's inflammation which extends to serosal layer and irritates the parietal peritoneum. So now the pain will be localized at right lower quadrant. So the pain starts as periumbilical pain due to visceral peritoneum irritation, but as soon as the parietal peritoneum starts getting irritated, the pain is then localized to the McBurney's point, that is right lower quadrant. So the McBurney's point is 1/3 the distance from right anterior superior iliac spine to umbilicus. Nausea, fever may perforate, and there is nausea and fever, and the appendix can perforate, causing peritonitis. It may elicit psoas, obturator, and Rovsing sign. Rovsing sign is severe right lower quadrant pain with palpation of left lower quadrant pain. Okay. And the signs, these are the signs: psoas, obturator, and Rovsing signs. And there is also guarding and rebound tenderness present. Okay. There's also guarding and rebound tenderness in pancreatitis as well. Okay. Treatment is appendicectomy, and it can, if it is perforating, it can cause intra-abdominal or intra-intestinal abscess, which will be caused by anaerobe called Bacteroides fragilis, E. coli, enterococci, or streptococci. Okay. Now we'll see the diverticula of the GI tract. So, what is diverticulum? It is a blind pouch protruding from the alimentary canal that communicates with the lumen of the gut. So this is the lumen, this is the diverticulum, this is the bowel one. So diverticulum is a false diverticulum, so it is not going to involve all of the layers. So that is why I have kept this outer layer intact. Most diverticula, esophagus, stomach, duodenum, and colon, are acquired and are termed false diverticula. And they are acquired because of the high pressure. Okay. If there is high pressure in left colon, it is going to cause diverticulum, but if there is high pressure in the right colon, it is going to cause angioplasia. Okay. And the true diverticulum contains all of the gut layers, outpouch like Meckel's diverticulum, and also appendix, that is a natural diverticulum. False diverticulum or pseudo-diverticulum is only mucosa and submucosa outpouches. It occurs especially where vasa recta perforates the muscularis externa. Okay. So in sigmoid colon mostly. So wherever the vasa recta is perforating the muscularis externa layer, that is the point of weakness through which diverticulum can occur. This is mucosal layer and submucosal layer. And this is muscularis layer, which is not involved. Now, diverticulosis. So there are many false diverticula in the colon. It is called diverticulosis. It is commonly in sigmoid, common in 50% of the people above 60 years, caused by increased intraluminal pressure and focal weakness in the colonic wall. So the focal weakness is at the area where vasa recta perforates muscularis externa. It is associated with obesity, diets low in fiber and high in total fat and red meat, the same risk factors that also causes colonic adenocarcinoma. It is often asymptomatic. It is incidentally found in the colonoscopy, but it is asymptomatic and is associated with vague discomfort. Its complications include diverticular bleeding, painless hematochezia, or diverticulitis when there is inflammation seeding in the diverticulars. And diverticulosis formation increases with foods that contain seeds or popcorns. These are the previously thought risk factors. This food with seeds and popcorn. And in barium enema, if we do barium enema, we can see sawtooth appearance, because these are the diverticulars. And diverticula of the colon are in the mesenteric border, but the Meckel's diverticulum, which is a true diverticular, comes out from the antimesenteric border. Now, diverticulitis, there is inflammation of the diverticula with wall thickening. This red arrows in C. In B, you can see these diverticulars. In C, you can see the wall of those diverticulums have thickened. Okay. And there can also be perforation that can lead to peritonitis. So this is the perforation. So air is leaking out of the colon into the peritoneal cavity, causing peritonitis. Diverticulitis causes left lower quadrant pain, fever, and leukocytosis because of the infection, and it treat with supportive care, uncomplicated, and if it is complicated, treat with antibiotics. The complication of diverticulitis are abscess formation because of the rupture of the diverticulum. There can be fistula, colovesical from colon to bladder, and if there is a fistula between colon to bladder, air is going to enter the bladder and cause pneumaturia. Can cause obstruction of food particles in the diverticula, and there can be because of the inflammatory stenosis as well, because there is edema, the diverticular wall has thickened. It can cause obstruction. There can be perforation, which is shown by white arrows in C, which will cause peritonitis, and hematochezia is rare in diverticulitis. Okay. And there can also be mass felt in the left lower quadrant due to abscess formation. Here you can see a diverticula. See Zenker's diverticulum. Zenker's diverticulum is also a false diverticulum. It is a pharyngoesophageal false diverticulum, and the esophageal dysmotility causes herniation of mucosal tissue at an area of weakness between the thyropharyngeal and cricopharyngeal parts at the inferior pharyngeal constrictor, that is Killian's triangle. So imagine this is the triangle, these are the thyropharyngeus muscle and these are the cricopharyngeus muscle, and the esophagus protrudes out of this triangle of weakness. Presenting symptoms are dysphagia, obstruction that are common, gurgling, aspiration, that is foul breath, that is called halitosis, and then there's neck mass too. It is most common in older males. And food regurgitates back at the night when lying down. Because if this is the diverticulum, the food during the food intake, there is some food accumulated in this diverticulum too, and when the patient lies down while sleeping, the food comes back into the oral cavity. And the pathology behind the Zenker's diverticulum is the motor dysfunction of cricopharyngeus muscle. So, cricopharyngeal motor dysfunction. And this is a false diverticulum. Then there's also true diverticulum forming in esophagus because of mediastinal lymphadenitis. How does it cause true diverticulum? So, mediastinal lymphadenitis can cause scarring or traction of the esophagus. Cause true diverticulum. So Meckel's diverticulum, it is a true diverticulum. So it involves all of the layers, all of the 4 layers. It is a persistence of the vitelline duct, that is omphalomycentric duct. What does vitelline duct do? It connects ileum to the umbilicus embryologically, but after birth it is sealed off. It loses the connection with the umbilicus, and hence only a Meckel's diverticulum is formed. But also not in all cases, only in few of the cases. It may contain ectopic acid secreting gastric mucosa or pancreatic tissue. Most common congenital anomaly of the GI tract. It can cause hematochezia, melena, which is less common, right lower quadrant pain, intussusception, volvulus, or obstruction near the terminal ileum. And it is diagnosed by technetium pertechnate scan, also called Meckel's scan, for uptake of heterotropic gastric mucosa. So this scan will be positive only and only if it has heterotropic gastric mucosa. Okay. Normally it does not have heterotropic gastric or pancreatic mucosa. So there are the rule of twos. That is, it is 2 times as likely in males. It is 2 inches long. It is 2 feet from the ileocecal valve. 2% of population to have Meckel's diverticulum, and it is commonly present in the first 2 years of the life, and may have 2 types of epithelia, that is gastric and pancreatic. It may present very similar to appendicitis. So during laparotomy, when appendix is searched for appendicitis, you may find completely normal appendicitis. So what surgeons do is they look for 2 feet of ileum from the ileocecal valve for the Meckel's diverticulum. So it can be Meckel's diverticulitis causing symptoms similar to the appendicitis. Okay. This is the antimesenteric border. Okay. Meckel's diverticulum rises from the antimesenteric border, and 20% of the people having Meckel's diverticulum have gastric or pancreatic epithelium. And also if there's ectopic gastric mucosa, there is also chances that that gastric mucosa can get inflamed, so that will cause painless GI bleeding or anemia in kids because of the gastritis of that gastric mucosa present in Meckel's diverticulum. And the stools will be current jelly stools. It can cause intussusception as well as volvulus. It serves as the lead point for intussusception. Now, Hirschsprung disease. It is a congenital megacolon characterized by lack of ganglion cells or enteric nervous plexus, Uhrbeck or Meissner's plexus in distal segment of the colon. So, due to failure of neural crest cell migration. So, this is the main pathology. It's due to the failure of neural crest cell migration. So, congenital megacolon is characterized by the lack of ganglion cells or enteric nervous plexus, that is Uhrbeck and Meissner's plexus in distal segment of the colon. So, the main pathology here is it is due to the failure of neural crest cell migration, and it is associated with loss of functional mutation in RET, in RET genes. So, the neural crest cells are supposed to migrate from cranial end to caudal end and form both of these nerve plexus in the submucosal layer. And the failure of neural crest cells to do so results in lack of Uhrbeck and Meissner's plexus in the submucosa, which will impair secretion of the fluid as well as the motility of the affected part. Right? And it presents with bullous emesis, abdominal distension, and failure to pass meconium within the first 48 hours, and which will result in chronic constipation. And the normal portion of the colon proximal to the aganglionic segment is dilated, resulting in a transition zone. So if there are no nerves here, the food will get impacted in the proximal segment, that is over here, which will on abdominal x-ray will look like a megacolon. And it has increased risk with Down syndrome, and there's explosive expulsion of feces, that is called squirt sign, which causes empty rectum on digital exam. Whenever digital exam is performed in Hirschsprung disease, there is rapid explosive expulsion of feces. Okay, and it is diagnosed by absence of ganglionic cells on rectal suction biopsy. So you have to biopsy this area. This area is normal. Okay, and there is elevated acetylcholinesterase in hypertrophied nerve fibers in lamina propria. Okay, there is increased acetylcholinesterase in hypertrophied nerve fibers in lamina propria. Okay, because if there is increased acetylcholinesterase, the acetylcholine levels are going to decrease. So there will be decreased relaxation of the smooth muscle cells. And this squirt, similar to this squirt sign, there is also a terminology called relaxation reflex, that is absent of internal sphincter after stretching of rectum. So whenever there is stretching of rectum actively, or even if we stretch the rectum of the child with Hirschsprung disease, there should be relaxation of internal sphincter, that is called relaxation reflex. So that reflex is absent in Hirschsprung disease. And on manometry of the sphincters, there is increased pressure. Okay, then it is also associated with glial derived neuropathic factor. It is associated with RET mutations and glial derived neuropathic factors. Malrotation. It is the anomaly of midgut rotation during fetal development, which causes improper positioning of bowel. Small bowel is clumped on the right side, and formation of fibrous band, that is Ladd bands. Okay, and it can lead to volvulus or duodenal obstruction. We discussed in the embryological section, right, that duodenojejunal flexure is on the right side in embryological period, but then it rotates to 70 degree, and the duodenojejunal flexure ends up on the left side of the midline, and the cecum ends up on the right lower quadrant of the abdomen. So if there is malrotation, there will be small bowel here, as you can see. This is the duodenojejunal flexure. Okay. And that can lead to duodenal obstructions as well as volvulus because of the lead bends. These lead bends are fibrous collagenous kinds of band that are attached one end to the colon and the other end to duodenojejunal flexure. Okay. And duodenal obstruction is because of these lead bands. Intussusception. Intussusception is the telescoping of proximal bowel segment into the distal segment. This. No. Shit. Yeah. So this is the distal segment, and this is the proximal segment that has telescoped into the distal segment. And it is most commonly at the ileocecal valve because the lumen of the ileum is narrower and the lumen of cecum is larger, so it becomes easier for the ileum to telescope into the cecal junction. It is typically seen in infants and it is rare in adults, usually idiopathic in children, less frequently due to an identifiable lead point. Idiopathic form is associated with recent viral infection, that is adenovirus or rotavirus vaccine, and there will be Pear patch hypertrophy due to the infection. Pear patches are just lymphoid aggregates, right? So it will hypertrophy in cases of infection, and that may act as a lead point. So common lead points for children is Meckel's diverticulum and small bowel hematoma, and which is found in IgA vasculitis. And in adults, it is intraluminal mass or tumor, although it is rare in adults. It causes small bowel obstruction and vascular compromise. Uh, this is the point of vascular compromise, okay, which will cause intermittent abdominal pain, vomiting, and bloody stools, bloody currant jelly stools. And on physical exam, there will be sausage-shaped mass in the right abdomen. Because the most common point is ileocecal point for intussusception. And patient may draw their legs to chest to ease pain. And imaging will show ultrasound. Ultrasound and CT will show target sign. Because if this is the case, if you see from here or here, it will show as target sign. Like this is the proximal segment that has telescoped into the larger distal segment. Right, and it is also called donut sign or pseudo kidney sign. Right, because from sideways it also looks like this. Okay. And on contrast enema, it is called claw sign. So this is kind of claw or pincer sign. Claw, pincer sign. Okay. Right. So volvulus is the twisting of portion of bowel around its mesentery, and it can lead to obstruction and infarction, and it can occur through the GI tract. So gastric volvulus more common with anatomic abnormalities like paraesophageal hernia, and presents with severe abdominal pain, dry heaving, and inability to pass nasogastric tube. And midgut volvulus more common in infants and children, minors, M for M. And sigmoid volvulus, that is it shows coffee bean sign on X-ray, is more common in seniors, that is older adults. Okay, so sigmoid colon mostly so the midgut volvulus occurs in clockwise direction, and it is because the cecum is a mobile organ. Okay. And the reason behind sigmoid volvulus is the mesentery is long and narrow in sigmoid colon, and the sigmoid is susceptible to volvulus whenever it is loaded. So there should be loaded sigmoid colon with fecal matter. And the third is redundant sigmoid. And sigmoid volvulus rotates anti-clockwise. So here is the coffee bean sign. This is a coffee bean, right? And it has rotated anti-clockwise. It rotates around the mesentery. If this is the mesentery, it rotates around the mesentery in anti-clockwise direction. Okay. Now, acute mesenteric ischemia. It occurs due to critical blockage of intestinal blood flow of an embolic occlusion of superior mesenteric artery, and which causes small bowel necrosis. Here is the necrosis. It causes abdominal pain that is out of proportion to physical findings. So signs are very less, but the abdominal pain, which is a symptom, is in greater proportion than its physical findings. And you may see red current jelly stools like in intussusception. Okay. And the main point to remember is that it is due to embolic occlusion, whereas when we'll see chronic mesenteric ischemia, it will be due to thrombotic occlusion, which develops slowly in the superior mesenteric artery. Emboli can arise from any atrial fibrillation or aneurysm, or in female patients with Virchow's triad that includes hypercoagulability states. Okay. So hypercoagulable states makes them susceptible to embolic occlusion. Okay. And acute mesenteric ischemia is a differential diagnosis of abdominal aorta aneurysm. Okay. So there will be sudden abdominal pain in both of those conditions, but in abdominal aorta aneurysm, there won't be any current jelly stools. Right. Current jelly stools are there because it is affecting the intestines. In aortic aneurysm, abdominal aortic aneurysm, there would be any change affecting the intestines. Right. Okay. And yeah, this is the embolic occlusion of superior mesenteric artery, in which cases occlusion of superior mesenteric vein occurs. It occurs in polycythemia vera. Second is angiodysplasia. It is tortuous dilatation of vessels which cause hematochezia. So these are the tortuous dilatation. It is most often found in the right-sided colon, mostly in the splenic flexure, and it is more common in older patients. It is confirmed by angiography, associated with end-stage renal disease, von Willebrand disease, and aortic stenosis. Whenever it is associated with aortic stenosis, it is called Hayes syndrome. Third is, I think, leave it. Chronic mesenteric ischemia is intestinal angina. So there will be recurrent pain, recurrent abdominal pain, and it is caused by atherosclerosis of celiac artery, superior mesenteric artery, or inferior mesenteric artery, which will lead to intestinal hypoperfusion, which will lead to postprandial epigastric pain. Okay. and that will cause food aversion. So the appetite is going to decrease. The patients refuse to eat more as there is a postprandial pain, and there will be weight loss because of the loss of appetite. So why does the pain occur postprandially? Because postprandially there is energy needed in the intestines, right? So ATP comes in the form of the blood flow, right? So whenever the blood flow is going to increase in the atherosclerosis celiac artery, superior mesenteric artery, or inferior mesenteric artery, there is going to be ischemia, and there will be angina-like pain. Sorry, not ischemia. Okay, so food, energy needed, angina-like pain, and it is due to thrombosis, right? Atherosclerosis is incomplete thrombosis of the vessel. Acute ischemia was due to embolic occlusion. And now colonic ischemia, it is a crampy abdominal pain followed by hematochezia, commonly occurs at watershed areas, that is splenic flexure and rectosigmoid junction. Typically occurs older adults, and there is thumbprint sign on the imaging due to mucosal edema or hemorrhage, and that thumbprint sign is due to submucosal air. Okay. Usually occurs in the splenic flexure and the rectosigmoid junction. Now ileus is the intestinal hypomotility without any obstruction. So constipation, it causes constipation and flatus, decreased flatus, and distended tympanic abdomen with decreased bowel sounds. It is associated with abdominal surgeries, opiates, hypokalemia, and sepsis, and there is no transition zone on imaging. Treatment includes bowel rest, electrolyte correction, cholinergic drugs, which stimulates intestinal motility. Okay, so the patient will have history of recent abdominal surgery within 1 or 2 days. Opiates, hypokalemia. Hypokalemia is the reason it causes ileus after abdominal surgeries, because there is tissue damage during the surgery which causes the potassium to leak out of the cell, causing hypokalemia. And sepsis or burns. Okay. And there is just intestinal hypomotility without any obstruction, that causes constipation and flatus, but there is no pain. Okay. Now necrotizing enterocolitis is seen in premature babies, formula fed infants with immature immune system. And necrosis of intestinal mucosa, most commonly terminal ileum and proximal colon, which can lead to pneumatosis intestinalis. Okay, so pneumatosis intestinalis means air within the bowel wall. Not air within the bowel, but air within the bowel wall. Okay, which will be seen something like this. These are not clearer images, but the UL image is pretty clear. So the question stem would say that there are thin curvilinear lines parallel to the bowel wall. So if this is the bowel wall, so there will be curvilinear line parallel to it. So that signifies that there is air within the wall of the bowel. Okay, and if that ruptures, it will cause pneumoperitoneum as well and portal venous gas. And there will be necrosis of intestinal mucosa. There will also be abdominal distension plus bloody stools because there is necrosis of the bowel wall. and as there is everything is just because of immature immune system in preterm infants. So if there is immature immune system, bacteria can proliferate rapidly. And the bacteria are introduced in the body with the formula fed uh, formulas, okay, breast milk formulas and all. Small bowel obstruction, it is the normal flow of intraluminal contents is interrupted. It causes fluid accumulation and intestinal dilation proximal to the blockage, and intestinal decompression distal to the blockage. So if this is the obstruction, it's going to cause dilatation proximally and decompression distally. It presents with abrupt onset of abdominal pain, nausea, vomiting, abdominal distension. Compromised blood flow due to excessive dilatation or strangulation may lead to ischemia, necrosis, or perforation. It is a surgical emergency. Okay. And most commonly caused by intraperitoneal adhesions. Adhesions can be due to past surgery, past tuberculosis. Okay. That is fibrous band of scar tissue that encircles the bowel, causing obstruction. So it is caused by intraperitoneal adhesions, tumors, hernia as well. In rare cases, meconium plugs in newborn causes meconium ileus. Okay. And in upright abdominal X-ray, it shows air fluid levels. Remember, it is only in upright abdominal X-ray, not in supine abdominal X-ray. Upright abdominal X-ray will show air fluid levels. And management includes gastrointestinal decompression with a flatus tube or anything like that, volume resuscitation, and bowel rest. And if still nothing, no improvement occurs, then laparotomy is done to identify the cause and do surgical treatment. Okay, and there should be more than 3 air fluid levels in upright abdominal X-ray to diagnose small bowel obstruction. And in abdominal X-ray, how do we differentiate jejunum and ileum? Jejunum will have step ladder pattern, like it is like this, and ileum will have featureless loops. Of Wittgenstein. So there will just be smooth loops. So hence they are called featureless loops. Okay. Also, let's talk about pseudo obstruction. Okay. So colonic pseudo obstruction, also called Ogilvy syndrome. If this is primary cause, if it is secondary to any other causes, like in ICU patients, neurological diseases, spinal injury, hypothyroidism, and retroperitoneal hematoma. And let's also talk about Clostridium difficile diarrhea. It is very commonly asked in GIT system. Okay. So how does Clostridium difficile occur? Okay. It occurs due to the use of antibiotic in hospital admitted patients, inpatients in old age, and patients on proton pump inhibitors. So the C. diff has two toxins, tox A and tox B. So tox A is enterotoxin and toxin B is cytotoxin, and it disrupts the cellular cytoskeleton and intercellular tight junctions. So that leads to colonocyte, the cells in the colon, that are colonocytes, apoptosis. And colonic mucosa responds by forming yellow-white exudates as an inflammatory response. It recruits neutrophils and fibrin and bacteria. So you can see all these things in the colonic mucosa if you perform endoscopy. So what you will find is, first let's write down the pathology. Disrupts cytoskeleton and intercellular tight junctions, leading to colonocyte apoptosis. So one of the step of apoptosis is this, right? That cytoskeleton gets disrupted, tight junctions gets damaged, and all that. So C. diff does that for the cell. It disrupts cytoskeleton and intercellular tight junction. So eventually the colonocyte has to undergo apoptosis. And colonic mucosa responds to this organism and to the apoptosis by forming yellow exudates, that are pseudomembranes. The yellow exudates that are pseudomembranes, which is very characteristic of C. diff. And it also recruits neutrophils because it's an infection, right? There will be fibrin, and also there will be bacteria, right? Let's just highlight pseudomembranes. And why does C. diff occurs? Because of antibiotic and in hospital patients and in old age. Because see, there is always microbioflora in colon, right? There are organisms that live in colon at all times, but when we administer antibiotics or proton pump inhibitor, so that gut microbiota gets altered. Okay, so that allows the growth of other bacteria, that is Clostridium difficile. So there is altered gut microbiota, that is antibiotics, because of antibiotics or PPIs. So that allows the growth of C. diff. The complications of C. diff are toxic megacolon and colonic perforation. Done. So colonic polyps. So this is the growths of tissue within the colon. It is grossly characterized as flat, sessile or pedunculated on the basis of protrusion into the colonic lumen. So flat and sessile does not protrude into the colonic lumen, but the pedunculated does. Generally classified by histological type. Either it is generally non-neoplastic or potentially malignant. Okay, there are just two types, generally non-neoplastic and potentially malignant. So non-neoplastic includes hamartoma. All these terms are non-neoplastic, right? Hamartoma, hyperplasia, inflammation, mucosal and submucosal. you can infer by their names that they are all non-neoplastic, whereas the potentially malignant ones are adenomatous. Like, right, we know that adenoma has malignant potential, right? Any adenoma, either be it hepatic adenoma or colonic adenoma, anything like that, gastric esophageal adenoma. Okay, and there is serrated polyps, which we'll see later. So hematomatous polyps are, it is the solitary lesions that do not have significant risk of transformation, and it is just the growth of normal colonic tissue with distorted architecture. So that is the definition of hematoma, right? It is the normal growth, but in a distorted architecture. Okay, it is associated with, however, Peutz-Jeghers syndrome and juvenile polyposis, which are malignant. Okay, and on histology there will be hyperplastic smooth muscle cells. Okay, and there will be tree branch appearance of it. We'll see in Peutz-Jeghers or wait a second. It will have hyperplastic smooth muscle cells on histology that are spindle shaped, like these. Okay, and now hyperplastic polyps, they are the most common non-neoplastic polyps, that is hyperplastic polyp. They are generally smaller and predominantly located in the rectosigmoid region. Occasionally evolves into serrated polyps and more advanced lesion. Okay, and why is there the serrated appearance? It is because of the hypertrophy of the glands. And as it resembles serrated type, it will also have sawtooth pattern like serrated does. Okay, so there will be sawtooth appearance as well. Inflammatory pseudopolyps due to mucosal erosion in inflammatory bowel disease. Okay, mostly in ulcerative colitis, because pseudopolyps develop in ulcerative colitis. There's mucosal polyps. It is small, usually less than 5 millimeters, and look similar to normal mucosa. They are clinically insignificant, so you don't have to remember this. And submucosal polyps may include lipoma, leiomyoma, fibroma, and other lesions. Okay, you just have to remember these lipoma, leiomyoma, and fibroma in questions differentiating between malignant and non-malignant polyps. Okay. Now adenomatous polyps, they are neoplastic. They occur via chromosomal instability pathway with mutations in APC and KRAS. Tubular histology has less malignant potential than villus histology. Okay, so B is tubulous. So you can see there is no elevation here. It's just a flat surface. But in villus there are villi like this. Okay, and tubulovillus has intermediate malignant potential, usually asymptomatic, may present with occult bleeding. There may be occult bleeding, and it is incidental finding on endoscopy. And villus is more villainous, so villus has more malignant potential than tubular. Okay, and serrated, no. Okay, and yeah, one more thing, that if it is tubular adenomatous polyp, the higher chances are it can be anywhere in the colon. Whereas if it is a villus adenomatous polyp, chances are it will be in rectum mostly. And also these adenomatous polyps secrete prostaglandin E2, which is going to increase mucin, So increase in mucin in lumen will cause mucinous secretory diarrhea. Mucinous secretory diarrhea. And in that mucin's contents are bicarbonate and sodium. There will be increased bicarbonate and increased sodium in those, and so therefore it is going to cause metabolic acidosis plus hyponatremia. Okay. And also it has increased increased potassium, that is going to cause hypokalemia. Okay. Now serrated polyps. So serrated polyps are neoplastic. They are characterized by CpG island methylation. CpG island methylator phenotype, that is CIMP. Cytosine base followed by guanine linked by a phosphodiester bond. And the defect in this CpG island methylator phenotype may silence the mismatch repair gene, that is MLH1. So MLH1 gene would be silenced, so there will be reduced repair of the damaged DNA, right? These mutations lead to microsatellite instability and mutations in the BRAF. Okay. So mutation in the MLH1 gene will cause microsatellite instability and further mutation in the BRAF. It will cause sawtooth pattern of crypts on biopsy in up to 20% of cases of sporadic colorectal carcinoma. And there are two types of serrated polyps. So first is sessile and the second is traditional. So sessile are more than 5 cm, larger than 5 cm, but they are in ascending colon, and they are similar to hyperplastic polyps. In hyperplastic polyps we did discuss, right, that it can develop into serrated polyps. And the second is traditional serrated polyp, which is found in rectosigmoid, and it is caused by dysplasia, and it will have sawtooth crypts. And the potential to turn malignant depends on 3 factors. Okay, so the first main factor is polyp size. So if someone asks you that what is the which of the following polyps have highest chance of being malignant, 3 millimeter polyp in ascending colon or 5 millimeter polyp in descending colon. So you don't have to focus on the ascending colon and the descending colon. You just have to focus on the size of the polyps. So that is the most important factor in diagnosing if it has a malignancy risk or not. So obviously 5 millimeter polyp will have higher chances of turning into a malignant lesion. The second is degree of or grade of dysplasia. Okay, if it is high grade or low grade. And the third is architecture. Okay, architecture means if it is adenomatous type, or it is tubulous, or if it is villous type, or is it sedated type? Okay, so if someone asks you that which of the following is the most malignant, most potentially malignant polyp, either it is either if it is a tubulous adenoma, a 3 millimeter tubulous adenoma, or 5 millimeter villus adenoma. So obviously it is 5 millimeter villus adenoma, right? Because villus adenoma are more malignant, has more malignant potential than the tubulous adenoma. Now, polyposis syndromes. First is familial adenomatous polyposis. It is autosomal dominant mutation of APC tumor suppressor gene on chromosome 5q21 and q22. It follows the two-hit hypothesis, and thousands of polyps arise starting after puberty. It is pancolonic and always involves rectum. Prophylactic colectomy or else 100% progress to colorectal carcinoma. So in general population, the colonoscopy starts at 40 to 45 years of age, right? But in known cases of familial adenomatous polyposis, so known cases of FAP in family members, so in them the colonoscopy starts at puberty. Okay. And yeah, aspirin has proven to protect against progress to colorectal carcinoma in FAP patients. And second is Gardner syndrome. It is FAP plus osseous and soft tissue tumors like osteomas of skull or mandible. That is congenital hypertrophy of retinal pigment epithelium and supernumerary teeth. The third is Turcot syndrome. It is FAP or Lynch syndrome plus malignant CNS tumor. That is medulloblastoma or glioma. So Turcot sounds similar to turban, and turban is wear on the head. So you can remember it by that way. That it is FAP or Lynch plus malignant CNS tumors. Fourth is Peutz-Jeghers syndrome. It is very important, and it is also autosomal dominant syndrome featuring numerous hamartomatous polyps. So here we saw hamartomatous polyps, and we saw it is associated with Peutz-Jeghers syndrome. Okay, throughout the GI tract, not just in colon. So FAP was pancolonic, but Peutz-Jeghers syndrome is throughout the GI tract, along with hyperpigmented macules on mouth, lips, head, and genitalia. It is associated with increased risk of breast and GI cancers like colorectal cancer, stomach cancer, small bowel cancer, and pancreatic cancer. And it has a tree branch like appearance on histology, like leaves coming out of it. Okay, not histologically, but grossly it looks like the leaves coming out of the colon. Okay, it is called arborizing pattern. And also you have to remember some mutations that are STK11 and LKB1 on chromosome 19. And it starts at an early age like FAP. It starts as at puberty, that is 10 to 15 years it starts. Okay, and there's 39% chances of converting to colorectal carcinoma. FAP had 100% chance of converting to colorectal carcinoma. And juvenile polyposis syndrome, it is autosomal dominant syndrome in children typically less than 5 years old, featuring numerous hamartomatous polyps in the colon, stomach, and small bowel. It is associated also with increased risk of colorectal carcinoma. And the gene involved here is SMAD4. This is the gene also associated with hereditary hemorrhagic telangiectasias. Okay. Let's also discuss Cowden syndrome. Okay, that is caused by P10 mutations on chromosome 10, and there are multiple GI polyps plus lipomas plus ganglioneuromas. Okay, and it can also cause varieties of cancer like endocrine cancers like breast, thyroid, endometrial cancers, and it can also cause skin papules. So it may sound similar to Peutz-Jeghers syndrome. Plus there is hyperkeratosis. So there is diffused skin involvement, not like Peutz-Jeghers where only mouth and lips were involved. So there is mouth, lips and hands were involved. In Cowden syndrome there will be variety of cancers as well, and there will be skin papules and hyperkeratosis too. Lynch syndrome. It is formerly called hereditary non-polyposis colorectal carcinoma. It is also autosomal dominant mutation of mismatch repair genes MLH1 and MSH2. Like in serrated polyps, there was also mutations of mismatch repair genes, that was MLH1. Here there is MLH1 as well as MSH2. It will lead to microsatellite instability, and then it will cause DNA damage, causing cancer. And with subsequent microsatellite instability, yes, and 80% progress to colorectal carcinoma. Proximal colon is always involved. Okay. Like in FAP, whole of the colon was involved, but the rectum was always involved. In Lynch syndrome, the proximal colon is always involved, associated with endometrial, ovarian and skin cancers. Okay, and there are very few adenomatous polyps compared to FAP, where there were thousands of polyps arising. Here the adenomatous polyps are very few in number. And there is a 3-to-1 rule which you have to keep in mind to diagnose Lynch syndrome. There should be 3 affected family members. Two generations should be involved at least, and one relative who is less than 50 years of age. One relative who is diagnosed with Lynch syndrome at less than 50 years of age. Okay. Now, the colorectal cancer. It presents as mostly iron deficiency anemia in males more than 50 years of old, and postmenopausal females. Okay. So iron deficiency anemia in males more than 50 years of age or postmenopausal females raises suspicion, and the screening should start at 45 years of age. So average risk in local population, it screen at age 45 with colonoscopy. So polyp is seen like this. This is the polyp. Alternative includes flexible sigmoidoscopy, fecal occult blood testing, fecal immunological testing, fecal DNA and CT colonography. In patients with first degree relative who has colon cancer, screen at age 40 with colonoscopy or 10 years prior to the relative's presentation. So in first degree patients with first degree relative who has colon cancer, start screening at age 40 or 10 years prior to the relative's presentation. So if the relative had colorectal carcinoma and presented at 30 years of age, and he's the primary relative, so you should be screened at 10 years prior to that. So it is should screen at 20 years of age. In patients with inflammatory bowel disease, screen 8 years after onset. Okay, on barium enema, it shows apple core appearance like this. Here is the tumor obstructing the lumen. Okay. And CEA tumor marker, it is good for monitoring the recurrences but should not be used for screening. Okay, and it is used for monitoring recurrence as well as treatment response. And CEA also increase in pancreatic, gastric and breast cancer. And if the pre-op CEA is increased, we all know that it is a bad prognosis, but if the post-op CEA is still high, it means that there is residual disease. Okay. Increased post-op CEA means there is still residual disease left or residual tumor left to resect. And the tumor stage is the greatest prognostic indicator in colorectal carcinoma. Okay, so tumor stage, and how do we determine the stage of a tumor? By its extent of expansion. Like if it is just in mucosa, or it has invaded submucosa, or even the serosa or adjacent structures. So if it has extended to adjacent structures, it has the worst prognosis. Epidemiology, most patients are more than 50 years of age and 25% have family history. And the presentation is mostly rectosigmoid, then ascending and then descending. Most are asymptomatic. If it is right-sided colorectal cancer, is it cecal or ascending, it is associated with occult bleeding, and the left-sided rectosigmoid associated with hematochezia and obstruction. So narrow lumen will cause decreased stool caliber. So stool caliber means the diameter of the stools. So if this is the lumen, same diameter of stools are going to come out, but now as the lumen is narrow, the stool caliber is going to decrease. Okay, so it is called pencil thin stools. And if it is an ascending colon, there is going to be exophytic mass, there will be iron deficiency anemia, and because of the occult bleeding. Okay, and because of that there will be weight loss. In descending, it will be infiltrating mass, there will be partial obstruction and colicky pain and hematochezia, and colicky pain and pencil thin stools. Because it is infiltrating mass, it will grow in the lumen of the intestine, causing obstruction. Okay. It can present with S. bovis, galeolyticus, bacteremia or endocarditis, or as an episode of diverticulitis. And mostly tumors found in ascending pathway are due to MSH1 gene related, and if it is in descending colon, it has went through that process of adenoma carcinoma sequence, right? So first adenoma must have formed, that has converted into carcinoma if it is in descending colon. So the risk factors are adenomatous and serrated polyps, right? In adenomatous, mostly villous polyps are more malignant. Familial cancer syndromes, FAP and Lynch syndrome and Peutz-Jeghers syndrome, all that, and juvenile polyposis syndrome. And inflammatory bowel disease, tobacco use, diet of processed meat with low fiber, Okay, also utero, not utero, ureterosigmoid anastomosis. Like in some of congenital urological surgical problems, there is anastomosis formed between ureter to sigmoid colon, so that causes increased potential of malignancy. Also selenium deficiency. Okay, and NSAIDs are protective against colorectal carcinoma. As we saw in familial adenomatous polyposis, aspirin was protecting against FAP. Right? And the most common metastasis is to liver. Cell growth. Also, now as we have discussed colorectal cancer, now let's also discuss carcinoid syndrome. It is very important too. Now let's discuss carcinoid tumor, not syndrome. Okay, it is a, yeah, this color is better. Submucosal polyp like nodule. It is a low grade neuroendocrine tumor. Okay. And as it is neuroendocrine tumor, there will be positive synaptophysin and chromogranin. And there will be 5-HIAA positive in urine. Okay. And what does carcinoid tumor do? Carcinoid tumor leads to secretion of serotonin in body. Okay, but if it is a localized carcinoid tumor, if it is a carcinoid tumor in just intestine, it can't reach systemic circulation, right? Because as the serotonin is released from the carcinoid tumor, it is going to go into the intestinal blood circulation, right? And eventually it is going to end up in the portal vein, and the portal vein ends up in liver, and liver is going to metabolize serotonin, because liver has MAO, right, the monoamine oxidase. So serotonin gets metabolized, and so the localized carcinoid tumor in intestine does not affect liver, lung, or left heart, like flushing of skin, bronchospasm, and all that will not be seen with carcinoid tumor. If all of those symptoms are written in the question, like flushing of skin, bronchospasm, and all that, just remember that it is a carcinoid tumor that has metastasized out of intestine, right? Okay, so it will cause flushing, bronchospasm, diarrhea. Okay. And it can affect heart. It can cause valvular fibrosis. And very specific, tricuspid regurgitation. Only this condition causes tricuspid regurgitation and also pulmonary stenosis. It is the only condition that causes either tricuspid regurgitation tricuspid regurgitation can also be caused by endocarditis affecting the tricuspid valves, right? The people who have history of IV drug abuse, mostly they have tricuspid regurgitation, but pulmonary stenosis is the condition very specific to carcinoid syndrome only. Okay. And these symptoms if it is metastasized carcinoid. But remember that if the carcinoid tumor has originally arisen from a bronchi or in lung, uh, these symptoms are going to be there, right? Because lungs does not have monoamine oxidase we talked about like liver, so it is not going to metabolize serotonin, hence the flushing and bronchospasm are going to be there even in the localized bronchial carcinoid tumor. Okay. Now we'll see the molecular pathogenesis of colorectal cancer. Chromosomal instability. Sorry. Yeah. Molecular pathogenesis of colorectal cancer. So chromosomal instability pathway causes mutations in the APC antigen APC that causes familial adenomatous polyposis and most sporadic cases of colorectal carcinoma. So the colorectal carcinoma that is found in descending colon. In ascending colon, colorectal carcinoma is mostly caused by MSH1 pathway mutation. Okay. So in a descending colon, it is adenocarcinoma sequence. Right. And the microsatellite instability pathway, it is mutation or methylation. Methylation is just it makes the genes mute. Okay, methylation makes the genes mute. So mutations or methylation of mismatch repair genes, that is MLH1, causes Lynch syndrome and some sporadic colorectal carcinoma via serrated polyp pathway, that is in ascending colon. Usually leads to right-sided colorectal carcinoma. Yeah, and there is overexpression of COX2 has been linked to colorectal cancer. Hence, NSAIDs may be chemopreventive, as we saw in in FAP syndrome or colorectal carcinoma. The NSAIDs are protective because there is overexpression of COX, and NSAIDs are COX inhibitors. Right. And so there is normal colon. First, there is loss of APC gene that is going to make the colon at risk for adenoma. Then there will be KRAS mutation that is going to form adenoma finally. And KRAS mutation causes unregulated intracellular signaling. Okay. And loss of APC genes cause decreased intracellular radiations, right? Increased proliferation, decreased intracellular radiations. So cells are apart from each other. They are going to grow apart from each other, causing like this overgrowth. And then there is unregulated intracellular signaling that is going to cause adenoma. And then there's loss of tumor suppressor genes, that is TP53 and DCC, and also COX2 overexpression is going to cause carcinoma. So if they ask you what is the reason for the formation of the adenoma, it is KRAS mutation. Okay, because KRAS is going to make colon at risk to adenoma. Right. I'm sorry, the COX2 is here. COX2 is here. So there is going to be methylation and COX2 overexpression. So that is going to cause epithelial proliferation. Right. Now, cirrhosis and portal hypertension. Cirrhosis, it is a diffuse bridging fibrosis that is caused by stellate cells. We talked about it in hepatocyte globular structure architecture, that stellate cells are present which cause in the space of DC, which causes fibrosis and cirrhosis. And regenerative nodules that disrupts normal architecture of liver. There is increased risk of hepatocellular carcinoma and can lead to various systemic changes causing okay, so the etiologies include alcohol, NASH, chronic viral hepatitis, autoimmune hepatitis, biliary diseases, genetic and metabolic disorders. So the nodules, the regenerative nodules, these compresses the hepatic sinusoids, causing increased pressure in portal veins, increased backflow in portal veins, causing hypertension in portal veins. So that is increased pressure in portal venous system. Etiologies include cirrhosis, most common cause in developed countries, vascular obstruction, that is portal vein thrombosis, or Budd-Chiari syndrome, which is obstruction in IVC. Then there's schistosomiasis in African countries, in our history of African travel. Okay, so the symptoms are pretty easy, and you must have seen all of these symptoms in your wards. Like first is jaundice. We'll talk about these two symptoms later on. Jaundice, purpura, potassiae. Then there's effect of portal hypertension, esophageal and gastric varices, which causes hematemesis and melena. If it is lesser amount, it will cause hematemesis. If it is 5 to 10 ml, it is going to cause hematemesis. And if it is more amount, it causes melena as well. Then there's vascular, that is caput medusae, it is portovenous, portosystemic shunts. Anorectal varices is portosystemic shunts. Ascites, bacterial peritonitis. Reproductive, we are going to talk about it later as well. Then there's amenorrhea. Neurologically is hepatic encephalopathy due to reduced ammonium metabolism by liver. There is asterexis, that is flapping tremors like penguins. There's gastrointestinal symptoms cause anorexia, nausea, vomiting, dull abdominal pain, and fetor hepaticus, that is the smell of ammonia. Hematologically, there's thrombocytopenia due to reduced platelets and increased platelet sequestration by splenomegaly. There's anemia due to increased RBC sequestration by spleen. There's coagulation disorders because of reduced coagulation factors in liver. There's splenomegaly because the splenic vein joins the inferior mesenteric vein to form portal vein, right? So if there is increased backflow in portal vein, there is going to be increased backflow in splenic vein as well. And to accommodate increased blood flow, there is red pulp expansion in spleen, causing splenomegaly, right? So there is red pulp expansion in spleen. In infections, there is expansion of white pulp. In renal, there is hepatorenal syndrome. Hepatorenal syndrome has to diagnose hepatorenal syndrome, the RFTs should be normal, right? And there should not be any etiology or pathology found in the renal system, right? The serum creatinine should be normal and the LFTs should be abnormal. Okay. And metabolically, there's hyperbilirubinemia causing jaundice. There's hyponatremia as well. Cardiovascular, cardiomyopathy, and peripheral edema. Okay. So now these other spider angiomas, palmar erythemas, testicular atrophy, and gynecomastia. And they are due to increased estrogen, right? So why does estrogen increase in cirrhosis? Because the estrogen metabolism used to occur in liver, but now as liver is cirrhosed, estrogen metabolism is not occurring, which will cause elevated estrogens. And also there is increased synthesis of adrenal precursors of estrogen in liver cirrhosis, right? So increased estrogen causes testicular atrophy and gynecomastia. But how does spider angiomas and palmar erythema occurs? It is because of the estrogen-induced vascular dilatation. Vasodilatation. Now let's understand the pathology of portal hypertension. I want to say that when there is portal hypertension, there is going to be splanchnic vasodilation, right? Because whenever there is hypertension, there is going to be splanchnic vasodilation. Splanchnic vasodilation means there is the arteries supplying the abdominal organs, peritoneal organs, are going to vasodilate, okay, because of release of nitric oxide. Okay, so as splanchnic vasodilation occurs, there is reduced BP. The renal perfusion, because kidneys don't come in splanchnic circulation, so renal perfusion is going to reduce. Okay, that is going to activate RAS system. RAS will stimulate aldosterone, reabsorb sodium and water. So if water is reabsorbed, it is going to increase intravascular volume, right? So that is going to increase the hydrostatic pressure. Okay, and also there is low oncotic pressure because of liver cirrhosis, right? There is hypoalbuminuria, hypoproteinuria, because they are not being secreted by the liver, so that is going to decrease the oncotic pressure. So together, reduced oncotic pressure in circulation, together decreased oncotic pressure and increased hydrostatic pressure is going to push the fluid out of the capillaries into the interstitium. So that is going to cause ascites. Okay, that's it. To treat ascites, we give spironolactone and furosemide. Why just spironolactone? It is an aldosterone receptor blocker. It is aldosterone antagonist. Okay, so because of as there is reduced renal perfusion in portal hypertension, okay, so the and there is reduced blood pressure as well. So both of these things, the kidney and the circulation, are dependent on the RAS system. Okay, kidneys are dependent on the RAS system to increase its own perfusion and increase the blood pressure, right? So if we give ACE inhibitors or ARBs, angiotensin receptor blockers, so if we give ACE inhibitors or ARBs, they are going to inhibit this RAS system, right? So that is going to worsen the renal perfusion and worsen the hypotension for us. So generally ARBs and ACE inhibitors are not given in liver cirrhosis. So we just inhibit the end point of intravascular volume increase, that is because of sodium reabsorption and H2O reabsorption by aldosterone. So we just block this step. Okay, we directly block this step. So everything above this is not going to be affected at all. Okay. And this was portal hypertension. But now let's just also discuss splenic vein thrombosis. So if you remember, in anatomy we discussed that the pancreatic tail is in contact with the spleen. So any etiology, pathology, Any pathology affecting the pancreas is going to affect splenic vein or spleen as well. So chronic pancreatitis or pancreatic cancer or any abdominal cancer that is metastasized to splenic vein can cause splenic vein thrombosis. It will cause varices, but not in lower esophagus, which is the site for varices caused by liver cirrhosis because of the esophageal branches and left gastric vein. But in splenic vein thrombosis, the varices are formed in gastric fundus, because that is the area on the greater curvature that is being supplied by the splenic vein. Okay, because splenic vein and branches of splenic vein, that is short gastric veins. Okay, well done. Spontaneous bacterial peritonitis is also called primary bacterial peritonitis, and common and potentially fatal bacterial infection in patients with cirrhosis and ascites. So often asymptomatic, but it can cause is often asymptomatic, but it can cause fevers, chills, abdominal pain, ileus, or worsening encephalopathy. So commonly caused by gram-negative organisms, that is E. coli and Klebsiella, or less commonly gram-positive, that is Streptococcus. And diagnosis is by pericentesis with ascitic fluid. Absolute neutrophil count is more than 250 cells per mm3, and also the ascitic fluid will be darker or reddish brown in color if there is bacterial peritonitis. And the empiric first line treatment is third generation cephalosporin, that is cefotaxime. Okay. Now the serum markers, it is AST and ALT first. They are increased in most liver disease. ALT is increased more than AST always, except in alcoholic liver disease, in which AST increases more than ALT. So the ratio usually is 2:1. Okay. AST does not typically exceed more than 500. So it is somewhere in the range of 400 to 450. AST is in range of 400 to 450, and the ALT is in ratio of 200 to 250. So that is significant for alcoholic liver disease. Okay. And AST is more than ALT in non-alcoholic liver disease, suggests progression to advanced fibrosis or cirrhosis, because there is no more hepatocytes that can now secrete ALT, right? And ALT is specific to liver. Okay, so now as hepatocytes are decreasing in fibrosis or cirrhosis, there will be reduced ALT synthesis, but AST can be synthesized somewhere else in the body too. So AST is not much decreased as compared to ALT. And increased aminotransferase more than 1000. Differential includes drug-induced liver injury, all the acute conditions, okay, like drug-induced liver injury, acetaminophen, ischemic hepatitis, acute viral hepatitis, or autoimmune hepatitis. These all are acute conditions, and in acute conditions, ALT, AST are more than thousands, and the normal levels are less than 30. Okay, and they are not considered significant till they rise 5 times their normal value. So after like 150, they are considered clinically significant in wards, right? Remember, in wards. But in step 1, they can even give you 120 level of AST ALT, and you have to consider it significant. Okay. Alkaline phosphatase is increased in cholestasis, infiltrative disorders, and bone disorders. Okay, wherever there is obstruction, there is increased alkaline phosphatase, infiltrative disorders, and bone disorders. And last is GGT, Okay, it increases in various liver and biliary disease, just as ALP can, but not in bone disease. Okay, because it is located in the canalicular membrane of hepatocytes, like ALP. As I said, ALP is unique to hepatocytes. GGT is also unique to hepatocytes, but ALP isn't. So ALP can be increased in cholestasis, infiltrative disorder, and bone disorder. So we cannot know whether it is whether the increase in ALP is due to a bone disease, infiltrative disease, or cholestasis. But if there is increased GGT, we can surely say that it is due to increase in it is due to cholestasis. That is, it is considered as liver pathology. It is related to liver pathology. Okay, and it is also associated with alcohol use. Now, why is AST increased in alcoholic liver disease more than ALT? So there are two reasons. Okay, so first is ALT needs pyridoxine, that is vitamin B6. ALT needs pyridoxine to synthesize. So, but there is pyridoxine deficiency in alcoholics. So that is the first reason that ALT is low. And second is the mitochondrial damage occurring in alcoholics. In alcoholic liver disease, releases AST more than ALT. So AST is in mitochondria of hepatocytes, and in alcoholics there is mitochondria. In alcoholic hepatitis and alcoholic steatosis, there is mitochondrial damage. So mitochondrial damage releases AST faster than ALT. Okay, but the first reason is the main reason, that ALT needs pyridoxine. Okay. Now this bilirubin, it increases in various liver disease, biliary obstruction, alcoholics, viral hepatitis, cirrhosis. In all of these, there is increased in unconjugated bilirubin. In biliary obstruction, there is increase in conjugated bilirubin, and in cirrhosis, there is increase in both of them. Okay, in hemolysis, there is increase in unconjugated bilirubin. Albumin decrease in advanced liver disease, causing decreased oncotic pressure. Prothrombin time is increased in advanced liver disease, decreased production of clotting factors, thereby measuring the liver's biosynthetic function. And prothrombin time, remember, increases in acute liver conditions as well, acute liver failure to be more specific. In acute liver failure, there will not be deficiency of albumin or deficiency of platelets, anything, but acute liver failure's most significant marker is increased prothrombin time. So prothrombin time tells us the biosynthetic function of the liver. And platelets, it decreases in advanced liver disease, increased because of reduced thrombopoietin and liver sequestration, and portal hypertension that causes splenic sequestration due to the backflow from portal vein into the splenic vein. Okay. Ray's syndrome, it is a rare, often fatal childhood hepatic encephalopathy. It is associated with viral infections, especially varicella zoster virus and influenza, that has been treated with aspirin. Okay, viral infection plus aspirin causes Ray. And aspirin metabolites reduces the beta oxidation by reversible inhibition of mitochondrial enzymes. So aspirin reduces beta oxidation of free fatty acids. So there is reduced free fatty acids metabolism. And if there is reduced free fatty acid metabolism, what is going to occur? The free fatty acids are going to accumulate in the hepatocytes, or more specifically in the mitochondria. So accumulation of free fatty acids into the mitochondria is going to cause fatty changes, that is microvesicular fatty changes. Okay, let's see mitochondrial abnormalities. Fatty liver because of microvesicular fatty changes. Hypoglycemia is there, vomiting, hepatomegaly, and coma is there. So aspirin is given in children only one disease, that is Kawasaki disease. And this is a nice mnemonic of remembering Ray's syndrome, that is SHINE. It is steatosis of liver hepatocytes. There is hypoglycemia or hepatomegaly. There is I infection, zoster virus or influenza. And not awake, that is coma. And E, that is encephalopathy. Okay, so there is microvesicular fatty changes, also called steatosis. And encephalopathy is also due to cell swelling, but it is due to astrocyte swelling in brain. Okay, now as we've talked about all of the biomarkers, let's quickly talk about pathological changes grossly and histologically change in hepatitis B. So in hepatitis B, there is going to be lobular mononuclear infiltrates. There is going to be hepatocyte ballooning. There is going to be ground glass hepatocytes. Okay, and Hep C, it is mostly chronic hepatitis, right? Hep C mostly causes chronic hepatitis. So there is lymphoid aggregates, steatosis, but no ground glass opacification of hepatocytes. In autoimmune, there is lymphoplasmacytic infiltration. In alcoholic hepatitis, there is steatosis plus neutrophilic infiltration. Okay. And in acetaminophen toxicity, acute liver failure, there is hepatic infiltrates of neutrophils. And the last one, in halothane hepatitis. Halothane is an anesthetic agent, okay, inhaled anesthetic agent, which is now not used much. It is replaced by desflurane, ceflurane, isoflurane, all that. And in earlier days, halothane used to cause halothane hepatitis. So it is just hypersensitivity immune reaction that is caused in 2 days to 3 weeks. It is going to cause increased LFT, like increased ALP, increased AST, increased prothrombin time, increased bilirubin, all that. and it can cause fulminant liver failure as well. So the liver would look very shrunken and atrophied on gross examination, and on histological examination there will be centrilobular necrosis and inflammation of portal tracts and parenchyma. And if it is chronic, one more thing, if it is chronic hepatitis B, there is also going to be macrophages and lymphocytes present. Lymphocytes are always present in chronic conditions, right? So in chronic hep B, there will be lymphocytes and macrophages. Let's also quickly talk about liver abscess. So if you know all these topics, you can just skip ahead. Okay, you don't need to stick around for all of these extra information. So liver abscess can be caused by Staph aureus through hematogenous route. First is Staph aureus. Second, it can be caused by E. coli or Klebsiella. Okay. By ascending cholangitis. It can also be caused by direct invasion of enterococci. That is direct invasion of enterococci. And direct invasion can be from appendicitis or diverticulitis. And there is portal and periportal lymphoplasmacytic infiltrates around the portal tracts. Okay, and that being said about the liver abscess, so normal flora of colon, there is bacteria present in the colon normally, right? So normal flora of colon includes bacteroids, fragilis, that is anaerobe. Then there's E. coli, enterococci, and streptococci as well. There is no Staph aureus normal flora. Okay, now we'll discuss alcoholic liver disease. So alcoholic liver disease includes 3 stages. The first is steatosis, the second is hepatitis, and third is cirrhosis. In steatosis, there is just fatty changes, accumulation of fat into the mitochondria. In hepatitis, there is inflammation too. So there is swollen necrotic hepatocytes with neutrophilic infiltration as well. And in cirrhosis, it is final irreversible form where there is nodular regeneration and fibrosis also. So in hepatic steatosis, there is macrovesicular fatty change that may be reversible with alcohol cessation. Alcoholic hepatitis includes and it requires sustained long-term consumption of alcohol. There is swollen and necrotic hepatocytes with neutrophilic, because as I said, hepatitis is inflammatory changes with neutrophilic infiltration, and there are maillary bodies present. It is intracytoplasmic eosinophilic inclusions of damaged keratin filaments. So maillary bodies are eosinophilic inclusions, like here we can see. So this is the maillary body. It is eosinophilic inclusion bodies found in the cytoplasm of hepatocytes, and it is formed due to the damaged keratin filaments. Alcoholic cirrhosis includes final and usually irreversible form. So both of these are reversible, but this is irreversible. And there is sclerosis around the central vein. Okay, and arrows in C. So this is the sclerosis or the fibrosis, which are seen around the regenerative nodules. Regenerative nodules surrounded by fibrous band in response to chronic liver injury, which causes portal hypertension, because as I said earlier that these regenerating nodules are going to compress the hepatic sinusoids, causing increased backflow pressure into the portal veins. Okay. So why does alcohol causes all this? So alcohol is acetaldehyde, right? So acetaldehyde is going to damage the hepatocytes. And grossly, if you want to see the fatty changes in liver, it will be seen as greasy, shiny liver. And also, let me write this down. Alcohol increases NADH, so that inhibits free fatty acid. Alcohol increases the NADH to NADP ratio, right? So it is going to inhibit free fatty acids oxidation and also increase triglyceride synthesis. So increased free fatty acids accumulation is going to cause steatosis. And normally these fibrosis, here we can see this structure is eosinophilic normally, okay, but in cirrhosis it turns a little basophilic. And in alcoholic liver disease, AST is more increased than ALT, because AST is mitochondrial. So when alcohol damages the mitochondria, AST is released faster than ALT. Okay. Now non-alcoholic fatty liver we have to go through the histology, right? So this is the steatosis. So there is just fatty changes. These all are fatty changes. There is nothing else. Okay. It is called fatty liver. And in B there is steatosis. So there is also fatty changes like ballooning of hepatocytes, but along with that there is neutrophilic infiltration too, right? The third stage is, and the third is liver cirrhosis. Okay. Okay, so there is ballooning of hepatocytes. As you can see, there is fat accumulation and there is maillary body seen as well, that is eosinophilic inclusion bodies made up of keratin filaments, right? Now non-alcoholic fatty liver disease, that is NAFLD or NASH. It is caused by metabolic syndrome, that is insulin resistance and obesity, and it is caused by fatty infiltration of hepatocytes that will cause cellular ballooning and eventual necrosis. So what happens if this is hepatocyte? There is going to be cellular ballooning of hepatocytes due to fat accumulation. So the hepatocytes initially will swell up due to fat accumulation, and then it will burst. So that is cellular necrosis. It may cause cirrhosis and hepatocellular carcinoma, and it is independent of alcohol use. So in question stem there will be negative history of alcohol given, and in the as it is not related to alcohol use, ALT is going to be in more than AST, but they will still be in the chronic state. So in chronic liver disease, the ALT AST are not rise that much. It is in the range of 150 to 200, and plus there will be fatty liver. That forms NASH diagnostic criteria. Okay. But also if AST starts rising more than ALT, but they are still lower than 150, and you have diagnosed NASH earlier, but now this change is going to occur that AST is rising than ALT, then you should infer that the NASH has progressed to cirrhosis. Okay. There are various drugs that can cause NAFLD2, like bleomycin, tetracyclines, nitrofurantoin, amiodarone is an important drug. Then there's barium and mercury. And the treatment of NASH is weight loss and vitamin E, like 1000 international unit per day, and another drug called pioglitazone. Now, autoimmune hepatitis, it is a chronic inflammatory liver disease. Alright, we know that, and it is more common in females. Because it is autoimmune, it is more common in females. It may be asymptomatic or present with fatigue, nausea, and generalized pruritus. It is often positive with anti-smooth muscle or anti-liver kidney microsomal 1 antibodies. Anti-LKM, this is called anti-LKM1 antibody. And labs include increased ALT and AST, and histology shows portal and periportal lymphoplasmacytic infiltrates. Okay, and there is also called interface hepatitis. So if this is the portal tract, there would be lymphoplasmacytic infiltrates around the portal tract. And autoimmune hepatitis will cause waxing and waning jaundice. Whenever there's a patient of jaundice, the first disease thought is hepatitis, right? After hepatitis and after tox, and the second one thought to be is drug related hepatitis. Either the patient is on some drugs that causes hepatitis, and when both of them are turned out to be negative, then we think of autoimmune hepatitis, especially when it's female. And then there's plasmacytic infiltrates. We know that it is a chronic, so there will be lymphocytic infiltrates, but there are plasma cells as well. Why? Because it is autoimmune disease, right? So plasma cells is going to synthesize antibodies, right? That is going to cause the autoimmune reaction. Now, hepatic encephalopathy, cirrhosis will form portosystemic shunts, right? So that is going to decrease NH3 metabolism, decreased ammonium metabolism, and then because of portosystemic shunts, the ammonia is going to enter the systemic circulation and eventually reach brain, causing neuropsychiatric dysfunction, which is reversible. This encephalopathy is reversible, may range from disorientation, hysterexis mild, to difficult arousal or coma. That is in severe stages. There is modified West Heavens criteria that you will study in medicine. Okay, so what are the triggers? Anything that increases the ammonium production in the body or its absorption from the intestine. will precipitate hepatic encephalopathy. So due to GI bleed, there is going to be increased bacterial proliferation, which is going to produce more ammonia. Then there's constipation, okay, and then infection. All of these three are going to increase ammonium production or absorption of ammonia from the intestinal wall. And the second is, if the ammonia removal from the body is reduced. So which are the cases where ammonia removal will be decreased? First is renal failure, then second is diuretics. So in diuretics, the NH3 is saved and water is excreted, and bypassed hepatic blood flow tips, that is the shunt, man-made shunt, that is portal vein to hepatic vein. Okay. What is the treatment of hepatic encephalopathy? First we give lactulose. Okay, so that increases conversion of NH3 to NH4 plus ammonia to ammonium ion, and ammonium ion is water soluble, so it will be excreted easily. Okay, and rifaximin, it is an antibiotic which will decrease the ammonium producing gut bacteria, right? And other supportive treatments like to decrease the ammonia production and absorption. By treating constipation, we give anti-constipation drugs. Okay. And yeah, lactulose. Why does lactulose convert NH3 into NH4 ammonium ion? Because it provides acidic environment. Okay. Acidic environment or H plus ion. So that H plus is going to bind to ammonia, forming ammonium ion. Okay. And yeah, earlier I was confused why diuretics decrease ammonia removal. Now I remember that diuretics causes hypokalemia and alkalosis in the body, right? Because of secretion of H plus and K plus ions into urine. And so as there is alkalosis, there is alkaline environment, there is reduced H plus ions in the body. NH4 ammonium ion is going to convert into ammonia. So that way ammonia is going to increase in the body. Okay, and how does it actually cause encephalopathy once it reaches the brain? So let's suppose the NH3 has reached the brain. It reaches astrocytes. Okay, there ammonia binds to glutamate, that forms glutamine, and that glutamine enters the neurons. Okay, and then it acts on NMDA receptors, causing neurotoxicity. So there is a reduction of glutamine because it is entered the neurons, right? It is not in circulation. So there will be reduction of glutamine in circulation and increase in GABA, that is inhibitory hormone, right? Next is liver tumors. Liver tumors, the first is hepatic hemangioma. It is also called cavernous hemangioma, and most common benign liver tumor is just a venous malformation. It typically occurs at the age 30 to 50 years, and biopsy contraindicated because of risk of hemorrhage. Yeah. So there is a cavernous blood-filled space on histology. Blood-filled space lined by just a single epithelial layer. Which can be broken down easily if we perform biopsy. So that is why biopsy is contraindicated. So here you can see cavernous hemangioma, that is red blood cells all over here. This is the blood vessels. Okay. And if you can see, this is the epithelial layer. There is just lining of single epithelial layer. So you can see there is just one cell. Okay. So if you want to see another image, so this is the blood, and as you can see the arrow points towards single epithelial layer. Right. Second is focal nodular hyperplasia. It is the second most common benign liver tumor. Okay, so first common benign tumor is hemangioma. Second is focal nodular hyperplasia. It occurs predominantly in reproductive females of reproductive age, that is 35 to 50 years. It is hyperplastic reaction of hepatocytes to an aberrant dystrophic artery marked by the central stellate scar, that is the dystrophic artery, and it is usually asymptomatic and detected incidentally. Okay, so on histology there will be bile ducts present. Why am I saying that there will be bile ducts present? It is always present in liver histology, but we'll see hepatic adenoma later on, which does not have bile ducts present on histology. There is going to be Kupffer cells, which are modified macrophages, and there's going to be hepatocytes seen in histology. And you can see a central stellate scar and then radiations coming out of it on gross examination. So there are fibrous septa that divides nodules. And this FNH is uncapsulated tumor. Okay. Now hepatic adenoma, it is a rare benign tumor. It is benign tumor. It is often related to oral contraceptive or anabolic steroid use, and it may regress spontaneously or even rupture. And it is the second most common cause of peritonitis during pregnancy. Okay, it may cause rupture during pregnancy. And histologically there will be no bile ducts, no Kupffer cells. Okay, there will just be plates of glands, which is called adenoma. Okay, and now it's time for hepatocellular carcinoma, okay, also called hepatoma, most common primary malignant liver tumor in adults. It is associated with HBV, which may or may not have turned into cirrhosis. So Hep B can form can cause hepatocellular carcinoma directly without cirrhosis, right? And all other causes of cirrhosis includes HCV, alcoholic, non-alcoholic, autoimmune hemochromatosis, Wilson's, alpha-1 antitrypsin, specific carcinogens like aflatoxins from Aspergillus that is found in stored grains or corn farms. Okay, and also P53 mutation can cause liver cancer. Findings are anorexia, jaundice, tender hepatomegaly, and may lead to decompensation of previously stable cirrhosis, ascites, and portal vein thrombosis, and it spreads hematogenously. And diagnosis is screening is done by ultrasound or contrast CT, MRI, and okay, so screening is done by ultrasound and confirmation is done by contrast CT or MRI, and biopsy is also done in cases where diagnosis is not uncertain, is uncertain. Okay, and his biopsy will show us polygonal cells with increased eosinophilic cytoplasm plus prominent nuclei. Right, typical features of cancer, and it is also going to cause hypoglycemia, hypercholesterolemia, gynecomastia, and hypercalcemia. And there will be increased in alpha fetoproteins as well. Now, hepatic angiosarcoma, it is a rare malignant tumor of endothelial origin. Okay, and it is associated with exposure to arsenic or polyvinyl chloride industries. Okay, and also thorotrest, and also due to mutation of CD31 plus, that is PCAM1. Okay, so there will be history of a worker working in polyvinyl chloride industry for X number of years. Okay, and also liver cancer seen like this in CT MRI. This is the liver cancer, and grossly it is seen like this. You're going to figure that out easily in question. And the metastasis, most common malignant liver tumors overall. Okay, so if there is a malignant liver tumor, it is going to be metastasis more likely than hepatocellular cancer. Okay, but if it is primarily a malignant liver tumor and there is no malignancy found anywhere else in the body, then it is going to be hepatocellular carcinoma most commonly. But if there is malignant liver tumor in liver, most commonly it is from the metastasis. And what are the sources? The sources include GI, breast, lung cancers. Okay, and metastases are rarely solitary. This is the liver. There are going to be multiple metastases, not a single focal metastasis. And why does liver metastases are so common? Because the hepatic sinusoids are fenestrated, so tumor cells can easily enter the liver parenchyma, and also liver has dual blood supply, that is portal and systemic, so that favors the entry of tumor cells into the liver more easily. There are fenestrated hepatic sinusoidal epithelium, So tumor cells can easily enter the liver parenchyma. The second reason is it has dual blood supply, portal plus systemic, right? Now, Budd-Chiari syndrome. Okay, it is a hepatic venous outflow tract obstruction. Okay, it is due to thrombosis or compression with centrilobular congestion and necrosis. There is going to be congestion because there is hepatic venous outflow obstruction. If there is an obstruction over here, the blood is going to congest the liver parenchyma, and it is going to cause congestive liver disease that includes hepatomegaly, ascites, varices, abdominal pain, liver failure, and there is absence of jugular venous distension. Obviously, because jugular vein is somewhere over here. If the obstruction is over here, the backflow is going to go into the liver. Okay, there is nothing related to jugular venous pressure here. It is just written here that there is absence of jugular venous distension because this condition is very common to cardiac cirrhosis, like liver cirrhosis occurring because of cardiac problem, right? Imagine this is the heart, here is the liver, here is the heart, this is the tricuspid valve, there's jugular vein. So if there is tricuspid regurgitation, blood is going to go into the jugular vein as well as go into the superior vena cava as well as inferior vena cava, right? Blood is going to regurgitate back into superior as well as inferior vena cava. In any diastolic heart failure, right? And like in tricuspid regurgitation or hypertrophic cardiomyopathy, right? The blood is going to regurgitate back. So in those cases, there will be congestive hepatomegaly too. That is called cardiac cirrhosis. There is going to be hepatomegaly. There is going to be ascites. There is going to be liver failure and all that. So to differentiate both of these conditions, we have to check the jugular venous pressure. So if jugular venous pressure is elevated, the initial cause of this disease is heart. And if the jugular venous pressure is normal, the pathology is somewhere in IVC or the liver itself. Okay. It is associated with hypercoagulable states. Polycythemia vera is hypercoagulable state. The postpartum state is hypercoagulable, and hepatocellular carcinoma. Okay. Hepatocellular carcinoma, suppose it is over here, is going to obstruct IVC, and it may cause nutmeg liver, mottled appearance. So yeah, I was trying to remember this term, nutmeg liver. It is in cardiac cirrhosis. So we read about it in cardiovascular system that and this congestive heart failure causes nutmeg liver or mottled appearance. It is like this. This is the mottled appearance. It is due to the congestion of hepatic sinusoids, right? And is compared to portal vein thrombosis as well. So portal vein thrombosis is somewhere over here. So it is going to cause backflow into the portal veins and splenic veins. It is going to cause varices in left gastric vein and splenic vein, right? So, but there is no hepatomegaly unless there is pre-existing liver disease. Okay, so there is no hepatomegaly in portal vein thrombosis because blood is going to go this way, not this way. Okay. And other causes of Budd-Chiari syndrome are factor V Leiden mutation, protein C and protein S deficiency. Protein C and protein S are anticoagulant protein. Antithrombin 3 deficiency, APLA syndrome, pregnancy we talked about, patients on OCP, and PNH, paroxysmal nocturnal hemoglobinuria. Okay, and there is going to be caudate lobe hypertrophy, because the last lobe IVC drains from is caudate lobe. Okay, so there will be caudate lobe hypertrophy first. And also I want to talk about acetaminophen toxicity. Like, it is metabolized by sulfation and glucuronidation. 90%, and 10% is metabolized by CYP 450. Okay, so the point behind discussing this is that alcohol is also metabolized by CVP in some part. The major part of alcohol is metabolized by alcoholic dehydrogenase, but a little part is also metabolized by CYP 450. So alcohol can reduce the acetaminophen toxicity due to competitive inhibition of cytochrome P450. So in alcoholic patients, if they have tried ingesting a lot of acetaminophen tablets at once, so we have to counsel the relatives that because the patient was alcoholic, there is lesser chance of acetaminophen being metabolized by the liver, hence there is lesser chance of liver failure causing due to acetaminophen. Okay, so it can reduce acetaminophen toxicity due to competitive inhibition of CYP 450. Right. Also in portal vein thrombosis, there is going to be splenomegaly, no hepatomegaly. Now, alpha-1 antitrypsin deficiency, it is accumulation of misfolded gene product in hepatocellular endoplasmic reticulum. So that is going to cause cirrhosis with PAS positive globules in liver at an early age. It is a co-dominant trait, often presents in young patients with liver damage and dyspnea. So there is going to be lung emphysema as well, without a history of tobacco smoking. So young, plus there would be no smoking given in the question, plus COPD symptoms as well. And they may also give a history of brother or father or even cousin for that matter, that they died of some pulmonary conditions or they died of some liver conditions. So if any question says that the family member died of liver condition, you have to keep these conditions in mind. First is alpha-1 antitrypsin deficiency, second is hemochromatosis, third is Wilson's disease. Okay, so because these three are fatal disease which can cause liver cirrhosis and eventually death of the patient. Okay, so in lungs there is decreased alpha-1 antitrypsin. So alpha-1 antitrypsin is elastase inhibitor. So if alpha-1 antitrypsin is going to decrease, the elastase is going to increase. And if elastase is going to increase, elastase, right? So it breaks down elastic tissue. So if elastase is increasing, it is going to break down the elastic tissue, which is going to cause collapse of the alveoli. it is called pan-acinar emphysema. If this is the acina, this is alveoli. Okay, so it causes emphysema of everything, not just alveolar emphysema. Okay, smoking may cause just alveolar emphysema or this emphysema, but I don't know the exact word for this. Don't remember that. And but alpha-1 antitrypsin will cause pan-acinar emphysema, so everything will be dilated. Jaundice is going to cause abnormal yellowing of the skin or sclera due to bilirubin deposition. So hyperbilirubinemia secondary to increased production like in hemolysis or infection, or decreased clearance like in obstruction, impaired hepatic uptake, conjugation or excretion. This is pretty basic, I don't need to explain this. So these are the common causes of increased bilirubin level: hemolysis, obstruction, tumor, liver disease. Conjugated hyperbilirubinemia, that is direct, it is due to biliary tract obstruction, that is gallstones, cholangiocarcinoma, pancreatic or liver cancer, or even liver fluke. Okay, liver fluke infects the biliary tree. That is why it causes conjugated bilirubinemia. Biliary tract disease that are primary sclerosing cholangitis and primary biliary cholangitis or cirrhosis. Excretion defect due to Dubin-Johnson syndrome and Rotor syndrome, where conjugated bile cannot be transported from hepatocyte into the bile. Okay. Unconjugated hyperbilirubinemia, the causes are hemolytic and in benign and neonates, and Crigler-Najjar and Gilbert syndrome, where there is UDP, glucuronosyl transferase activity is low. Okay. The beta-glucuronidase, it is a lysosomal enzyme that deconjugates direct bilirubin. Okay, it is also found in the intestinal brush border and in breast milk, sometimes leading to neonatal unconjugated hyperbilirubinemia and may lead to pigment stone formation. Okay, this is one of the reasons of pigment stone formation. Pigment is black or brown color of gallstone, that is called pigment stone. So one of the causes of pigment stone is increased beta glucuronidase due to infection. Okay. Mixed hyperbilirubinemia in hepatitis and cirrhosis. So UDP, glucuronosyl transferase, converts deconjugated bilirubin into conjugated bilirubin, but beta glucuronidase converts conjugated bilirubin into deconjugated bilirubin. Unconjugated bilirubin. So benign neonatal hyperbilirubinemia, it is formerly called physiological neonatal jaundice. Mild unconjugated hyperbilirubinemia caused by three reasons. The first is the fetal RBC turnover is increased because the fetal RBC lifespan is less than adult RBC lifespan, and there is increased hepatocytes. You know that the infants have higher level of hemoglobins, right? Like 15 to 18 is the even more than that is the normal range of hemoglobin in infants. And because as there is increased hemoglobin and also there is decreased fetal RBC lifespan, so that is going to cause increased unconjugated bilirubin in circulation. And second is immature newborn liver, so that has decreased activity of UDP, glucuronosyl transferase enzyme. so that is not going to convert unconjugated into conjugated bilirubin. The third is sterile newborn gut. So there are no bacteria in the newborn gut, so there is decreased conversion to urobilinogen. So normally what happens is the conjugated bilirubin enters the intestine, and the intestinal bacteria converts that conjugated bilirubin into urobilinogen, which enters the stools. Okay, so that conversion is reduced due to sterile newborn gut and increased deconjugation by intestinal beta glucuronidase. So beta glucuronidase is always present in the gut, but there is just the lack of bacteria that is causing this increased deconjugation. Okay, so beta glucuronidase is going to convert conjugated bilirubin into unconjugated bilirubin that will be reuptaken by enterohepatic circulation. Okay, yeah, here it is. It is going to be from intestine to circulation by enterohepatic circulation. It occurs in nearly all newborns after first 24 hours of life and usually resolves without treatment in 1 to 2 weeks. And exaggerated forms are breastfeeding failure jaundice, where there is insufficient breast milk intake. So that is going to cause decreased bilirubin elimination in stool, and that bilirubin which stayed in the intestinal lumen for long, it is going to be reuptaken by the enterohepatic circulation. So if there is insufficient breast milk intake, there is going to be less stool or bowel movements for the child, right? So that is why the bilirubin accumulation increases in the intestine, because the stool movements are reduced. And now the breast milk jaundice. So the breast milk has increased amount of beta glucuronidase. So beta glucuronidase is going to convert conjugated bilirubin into unconjugated bilirubin. Okay, and that will be reuptaken by the enterohepatic circulation from intestine into the circulation. Severe cases may lead to kernicterus, that is deposition of unconjugated lipid soluble bilirubin in the brain, particularly basal ganglia. So that is going if it is accumulating in the basal ganglia, it is going to cause atonia or even dystonia and chorea and up gaze palsy, or also sensory neural hearing loss. The treatment is phototherapy. It isomerizes unconjugated bilirubin to water soluble form, right? It conjugates bilirubin. And as the bilirubin is increasing in the circulation in neonatal hyperbilirubinemia, there is going to be increased color of the urine, that is increased darker color of urine. And also in hepatitis, we discussed that there is increase in both direct and indirect hyperbilirubinemia. So in hepatitis, due to destruction of bile ducts, there is going to be increase in conjugated bilirubin due to bile ducts damage, and due to hepatocyte damage, there is going to be increased unconjugated bilirubin. So biliary atresia, it is the most common reason for pediatric liver transplantation, and it is fibro-obliterative destruction of bile ducts that is causes cholestasis and conjugated bilirubinemia. Often presents as newborn with persistent jaundice after 2 weeks of life, darkening urine and acholic stools. Acholic stools is pale stools, okay? So there is rise in conjugated bilirubin which is going to enter kidneys, so it is going to produce darker urine color, but the conjugated bilirubin is not able to enter the intestines because there is destruction of bile ducts. So that conjugated bilirubin is not able to reach the stools to give its yellow color. That is why the stools are going to be pale, and increase in direct bilirubin and GGT because there is an obstruction. Also, it can be presenting as there would be resolving of the neonatal hyperbilirubinemia, but within the first 2 months there is return of jaundice, and this time there will be conjugated bilirubinemia. In neonatal hyperbilirubinemia there was just rise in unconjugated bilirubin, right? So there will be jaundice within the first 2 months. And on liver biopsy, this liver biopsy is important as it is going to show intrahepatic bile duct proliferation plus portal tract edema and fibrosis. As the bile ducts are getting destroyed by fibrosis, there is going to be proliferation of newer bile ducts, and smaller bile ducts. Okay. Now, hereditary hyperbilirubinemia, all are autosomal recessive. First is Gilbert syndrome. There is mildly decreased UDP-GT conjugation activity, and it is asymptomatic or mild jaundice, usually with stress, that is during exams, illness or fasting. So increase in unconjugated bilirubin without overt hemolysis. Okay, so there is not going to be any hemolysis. If you perform Coombs test and all, they are going to be negative, but there is just going to be in rise in unconjugated bilirubin, and it is also some very modest rise in bilirubin, like less than 3 microgram per deciliter bilirubin. This is a relatively common and benign condition. Many of us may have Gilbert syndrome, and we might even know it. Okay. And the second is Crigler-Najjar syndrome type 1. Okay. There is just absent UDP-GT. So in Gilbert's there was reduced activity, but in Crigler-Najjar there is just absent. So it must be severe, right? It presents early in life, but some patients may not have neurological signs until later in life. So bilirubin increases so much that it enters brain and causes kernicterus. So it may show neurological signs. Findings is jaundice, kernicterus, unconjugated bilirubin deposition in brain, conjugated bilirubin elevated. The treatment is plasmapheresis to remove the bilirubin and phototherapy. It does not conjugate unconjugated bilirubin, but it increases the polarity and water solubility, so it can be excreted easily, and only liver transplant can save the child. Okay. And type 2 is less severe, and it responds to phenobarbital, which increases the liver enzyme synthesis. And mostly the bilirubin is in range of more than 20 mg per dl. Okay. Only very few of the disease may have such high number of bilirubin. Okay, the first is Crigler-Najjar, and then there's Wilson's disease too, where there is severe hyperbilirubinemia. Okay. And thus death in 1 to 2 years of life if liver transplant is not done. Third is Dubin-Johnson syndrome. So the conjugated hyperbilirubinemia due to defective liver excretion. So here is that there is no problem with UDP-GT. The conjugated bilirubin has formed in the hepatocyte, but the intracellular transport from hepatocyte into the bile flow into the bile canaliculi is impaired. So conjugated bilirubin starts accumulating into the hepatocytes and in circulation. Okay, and due to accumulation of conjugated bilirubin in liver itself, it is going to cause dark liver. Okay, and sorry, that is not due to accumulation of conjugated bilirubin, but it is due to accumulation of epinephrine metabolites. This is very important. I made a mistake here, but it is very important to remember that it is due to accumulation of epinephrine metabolites, not due to accumulation of conjugated bilirubin. Okay. And Rotor syndrome, it is phenotypically similar to Dubin-Johnson but milder in presentation without the black liver. Okay, and due to impaired hepatic storage of conjugated bilirubin. Okay, now let's differentiate between the prehepatic, hepatic and post-hepatic jaundice on the basis of color of urine and stools. Okay. The urine and stool colors are very helpful to differentiate the post-hepatic post-hepatic hepatitis or post-hepatic jaundice, because if there's post-hepatic, there is going to be obstruction, which is going to cause increase in conjugated bilirubin, which is going to give a very dark urine color. Okay, when it is going to give pale stools. Okay, so that is very clear-cut situation where you can diagnose a post-hepatic jaundice. Anyways, is pre-hepatic, hepatic and post-hepatic. So in pre-hepatic, the urine is going to be of normal color, or it may be dark in hemoglobinuria. Okay, if there is hemolysis, the urine is going to be dark, but otherwise the urine is going to be of normal color. The stool is going to be dark. In hepatic, urine is going to be dark and the stools may be pale and dark. That is why I said that in post-hepatic jaundice, you have clear-cut situation where urine is very dark and stools are very pale. So urine is very dark, stools are pale. So in hepatic, the stools may be pale if there is cholestasis, that is obstruction of the bile ducts, and it can be dark if there is hepatocyte damage somehow. Wilson's disease, it is also called hepatolenticular degeneration. It is the autosomal recessive mutations in hepatocyte copper transporting ATPase. In hepatocyte copper transporting ATPase, which is due to the ATP7B gene on chromosome 13 mutation. So that leads to decreased copper incorporation into apoceruloplasmin and excretion into bile. So copper has to bind to ceruloplasmin in order to go into the circulation, and it is being excreted from hepatocyte into the bile to do so. So in Wilson's disease, there is decreased copper excretion from hepatocytes into the bile, and there is decreased so that causes decreased incorporation of copper into the ceruloplasmin, into apoceruloplasmin. So that leads to decreased ceruloplasmin. So when copper binds to apoceruloplasmin, it gets converted into ceruloplasmin. So now if copper is not binding to apoceruloplasmin, there will be decreased level of serum ceruloplasmin, and hence copper accumulates especially in the liver, right, because it is not being excreted from liver into the bile, in brain, that is in basal ganglia, in cornea, kidneys, and in urine. So there will be increased urine excretion of copper. It presents before the age 40 before age 40, and generally it is even younger than that, like before even 20 years of age, with liver disease, that is hepatitis, acute liver failure, or directly cirrhosis. And neurological diseases, if it is a neuro-Wilson, it is called neuro-Wilson, and all of the cases of Wilson's disease may not have neurological involvement. Only a little percent of that has neurological involvement. So that will cause dysarthria, dystonia, tremors, and Parkinsonism. Psychiatric disease, Kayser-Fleischer rings, that is deposit in descent membrane of cornea. These are the right. So this is the Kayser-Fleischer ring. Okay. Hemolytic anemia and renal disease, that is Fanconi syndrome. Okay, so the treatment is with chelation with penicillamine or trientine or oral zinc. So what does penicillamine do? It increases urine copper excretion, so that the increased free copper in circulation gets excreted through urine. So it normalizes the copper levels. And what does oral zinc do? It reduces copper absorption from intestines. Okay, and there is a unique feature of Wilson's disease, that alkaline phosphatase will be reduced. Okay. And it will most commonly affect males of less age. There will be also reduced cholinesterase. And serum ceruloplasmin is reduced, and the diagnostic value is less than 5 mg per dl when the diagnosis is confirmed of Wilson's disease, and urine copper should be more than 100 milligram. And free copper increases in blood because the ceruloplasmin in serum is decreasing. The free copper is going to increase because now copper is not able to bind apoceruloplasmin, hence there is increase in free copper. So if you want to measure the total serum copper, that is free copper plus bound copper bound to ceruloplasmin. So we know that ceruloplasmin bound copper is going to decrease very much, and the free copper is going to increase, but the free copper is not going to increase as much as the bound copper is decreasing. So the total effect will be total serum copper is going to reduce. Okay. Total serum copper has been reduced because it has been accumulated into liver, brain, eyes, cornea, kidneys, everywhere else, but not just in the blood. Now, hemochromatosis. It is an autosomal recessive again. It is mutation in HFE gene located on chromosome 6. The Wilson's disease was ATP7B on chromosome 13. Okay, yeah, and you have to you don't have to get confused between the ATP7B and ATP7A. So ATP7A is involved in Mankey-Kenkie hair syndrome, which we will study in biochemistry, and ATP7B is in Wilson. In hemochromatosis, it is HFE gene on chromosome 6 that leads to abnormal hepcidin production, that is low hepcidin production. So hepcidin's normal function is to inhibit the iron absorption, but now as the hepcidin is low, there is going to be increased intestinal iron absorption, which will cause iron overload. Can also be secondary to chronic transfusion therapy, that is in beta thalassemia major, and iron accumulates especially in liver, pancreas, skin, heart, pituitary, and joints. Hemosiderin, that is the form of iron in which it accumulates, can be identified on liver MRI or biopsy with Persian blue stain, and it will be seen as these blue colors in Persian blue stain. Okay, that blue pigment is hemosiderin. It presents after the age of 40 when total body iron is more than 20 gram. So iron loss through menstruation may slow progressions in a female. Okay, it after age 40, total body iron is more than 20 grams, and in females it may present even late after 60 years or so, because the menstruation may have slowed down the progression of hemochromatosis, because with menstruation there is loss of blood, there is loss of iron, right? So it manages the progression of the disease. The classical triad of cirrhosis, diabetes, and skin pigmentation, that is bronze diabetes, is brown discoloration of the skin, also cause restrictive cardiomyopathy. When the hemosiderin gets accumulated in the myocardium, it is not going to let the myocardium or the heart dilate, so that is going to cause restrictive cardiomyopathy or dilated cardiomyopathy, that is reversible. Okay. And also hypogonadism, arthropathy, because of calcium pyrophosphate deposition, especially metacarpophalangeal joints. And hepatocellular cancer is the common cause of death. Okay. And the treatment is repeated phlebotomy. We have to chelate iron with desferasirox, deferoxamine, and deferripone. And also in older age there will be pigment called lipofuscin, which is a normal aging pigment that is found in the heart, in liver, etc. So how do we differentiate hemosiderin and lipofuscin? So the Persian blue stain colors only the iron, but not lipofuscin. Okay, and if we talk about the labs, the ferritin is going to be increased, obviously, because ferritin is the source of iron storage. So if there is excess iron in circulation, it is eventually going to cause increased in its storage also. So ferritin is increased in the range of even more than 300, and if it is more than 1000, it is it is the confirmed diagnosis of hemochromatosis with poor prognosis. Okay, mostly in question stem the ferritin values will be given more than 1000, so that you don't have to get confused, it is hemochromatosis. And the TIBC, total iron binding capacity, will decrease because the iron is increasing, its capacity is going to decrease. Iron is going to increase. Okay, and percentage saturation is formulated by iron by TIBC. So iron is going to increase, TIBC is going to decrease, so PSAT value is going to increase, right? Yeah, and other the main mutation is in HFE gene, and the other genes are HJV gene, that is hemojuveline gene, and TFR gene, TFR2 gene. Now, biliary tract disease. It may present with pruritus, jaundice, dark urine, light colored stool, hepatosplenomegaly, and typically with cholestatic pattern of LFTs, that is increase in conjugated bilirubin, increase in cholesterol, increase in ALP, and increase in GGT. And the LFTs are pretty much normal. Sorry, not LFTs, but ALT and AST. ALT, AST are pretty much normal. Okay, because this is a biliary tract disease, this is not a hepatic disease. Okay, so primary sclerosing cholangitis is the unknown cause of concentric onion skin bile duct fibrosis. So there is going to be concentric and there is going to be fibrosis of the bile duct, alternating strictures and dilatation with beading of intra and extra hepatic bile ducts on ERCP. So here you can see the beading, right? This is swollen, this is then again constricted like this. Here you can see too on ERCP and magnetic resonance cholangiopancreaticography, ERCP or MRCP. And it is classically presented in middle-aged males with ulcerative colitis, associated with ulcerative colitis. And if it is associated with ulcerative colitis, the P ANCA is going to be positive, right? There is also going to be IgM, and it can lead to secondary biliary cirrhosis, directly secondary biliary cirrhosis. Both of these conditions can lead to secondary biliary cirrhosis. Increased risk of cholangiocarcinoma because it is in biliary tree. It is going to cause cholangiocarcinoma and gallbladder cancer. Okay, not hepatocellular carcinoma. There is going to be HLA DRW 52 positive, okay, and normal ALT AST. Now, primary biliary cholangitis, or also previously called primary biliary cirrhosis, it is an autoimmune reaction. So if it is autoimmune, there is going to be lymphocytic infiltrates plus or minus granulomas, which will cause destruction of lobular bile ducts. Okay, it is going to be present in middle-aged females. Sclerosing cholangitis is more in males, and biliary cholangitis is more in females. There is going to be positive anti-mitochondrial antibody, IgM, as in PSC. It is associated with other autoimmune conditions like Hashimoto's thyroiditis, rheumatoid arthritis, and celiac disease. Treatment is ursodiol. Okay, and this anti-mitochondrial antibody is positive against pyruvate dehydrogenase. E2. Okay, and there is no risk of malignancy here. Of course, the ALP and GGT is going to increase, and also cholesterol is going to increase. And there would be destruction of lobular bile ducts. So on histology, you will not be able to see any bile ducts. That is called ductopenia. And in both of these conditions, in primary sclerosing cholangitis and PBC, the bile is not able to reach the intestines. So if bile is not able to reach the intestine, there will be malabsorption of fat soluble vitamins, that is vitamin A, D, E, K are going to be malabsorbed because it needs bile to get absorbed. Now, secondary biliary cirrhosis, it is because of extrahepatic biliary obstruction. This is going to cause increased pressure in intrahepatic ducts, which will cause injury, fibrosis, and bile stasis. So any obstruction that is going to obstruct the biliary system, it is going to have increased pressure on intrahepatic ducts as well. So any obstructive lesions known, that is gallstones, biliary strictures, pancreatic carcinoma, is going to cause secondary biliary cirrhosis. So it is secondary because of the primary pathology involved in biliary tree, that is going to cause liver cirrhosis, right? May be complicated by acute cholangitis. Okay, and the pruritus in biliary tract disease is due to lipophosphatidic acid. Leakage of lipophosphatidic acid from liver into the circulation. And this primary biliary cholangitis, we see lymphocytic infiltrates and destruction of bile duct. So it is very similar to graft versus host disease after liver transplant. In graft versus host disease, we also see lymphocytic infiltrate and destruction of bile ducts. Right. Now, cholelithiasis and related pathologies. So, gallstones are caused by increased cholesterol and or bilirubin or decreased bile salts, and gallbladder stasis all cause sludge or stones. So there are three reasons. First is increased cholesterol, second is decreased bile salts, and the third is gallbladder stasis, which will cause biliary sludge or stones. So there are two types of stones. First is cholesterol stones and second is pigment stones. So cholesterol stones are the most common stones. They consist 80% of the stones, and they are radiolucent with 10 to 20% opaque due to calcification. Only 10 to 20% of the cholesterol stones have calcium in them, so that makes them radio opaque and can be seen in X-ray. And it is associated with obesity, Crohn's disease, advanced age, estrogen therapy, multiparity, rapid weight loss, medications that includes fibrates. The adverse effect of fibrates is gallstone formation because of the we'll talk about that later. And race, increased incidence in white and Native American populations. Okay, so in obesity, obviously there is increased cholesterol in the circulation, so that will cause cholesterol stones. In Crohn's disease, there is going to be decreased intestinal surface area, right? So the bile is not going to get reabsorbed back into the liver. Okay, so that is going to decrease the bile in gallbladder, and if the bile is going to decrease in gallbladder, the cholesterol is going to supersaturate. Okay, there is supersaturation of bile with cholesterol, so cholesterol is going to be increased unbound to bile, so that is going to cause cholesterol stones. And third is advanced stage. Fourth is estrogen therapy, and estrogen therapy, multiparity, or even oral contraceptive use if there is rapid weight loss. Okay, and total parenteral nutrition also causes cholesterol stones, because in total parenteral nutrition everything is given intravascularly, right? It is IV, so no food reaches duodenum, no fatty acids, no amino acids are reaching duodenum to stimulate the cholecystokinin release from duodenum. So if there's no cholecystokinin release, there is no contraction of gallbladder that can secrete bile into the intestine. So that causes bile stasis in gallbladder, which eventually leads to cholesterol stones. Okay, and also ileal resection can do the same by inhibiting the bile reuptake from intestine into the liver, causing bile concentration decrease in the liver and in gallbladder, and therefore the cholesterol is supersaturated and it will cause cholesterol stones. So the pigment stones can be either black or either brown. So black pigment stones are radio opaque and they have calcium bilirubinate. So therefore they are radio opaque and can be seen in X-ray, and they are mostly caused by hemolysis, because whenever there is hemolysis there is going to be increase in unconjugated bilirubin, right? So if the unconjugated bilirubin increases more than the gallbladder can handle, it is going to cause gallbladder stasis, okay, and that will lead to supersaturation of bile with calcium bilirubinate. There is going to be increased calcium bilirubinate in which will cause stone, okay. And the brown color is due to infections, okay. So whenever there is a infection, let me just write it down. So if it's a black stone, it is due to calcium bilirubinate. And if it is a brown stone, it is due to infection. So how does infection causes stone formation? Okay. So whenever there is infection of bile ducts, like with E. coli or liver fluke, those bacteria are going to release beta glucuronidase, and that beta glucuronidase is going to convert conjugated bilirubin into unconjugated bilirubin, so it is going to increase, okay. So if there is unconjugated bilirubin, that is going to cause supersaturation of bile, and that is going to cause pigment stones, okay. It is associated with Crohn's disease, chronic hemolysis, alcoholic cirrhosis, advanced stage biliary infections, and total parenteral nutritions. The most common causes you just have to remember are hemolysis and infections. So Crohn's disease can cause both cholesterol stones as well as pigment stones, okay. Yeah, here there's the table: sex, female, age, obesity, genetics, decreased cholesterol 7 alpha hydroxylase, that is the effect of fibrates, which will cause increased cholesterol, and decreased bile. So gallbladder stasis occurs, supersaturation of bile with cholesterol, and it's going to form cholesterol stones. And here it is chronic hemolysis and biliary tract infection that is going to cause increased unconjugated bilirubin, okay, and gallbladder stasis, and it will cause supersaturation of bile with calcium bilirubinate. It is going to cause pigment stones. And the most common complication of cholelithiasis is cholecystitis. It can also cause acute pancreatitis and acute cholangitis. It is diagnosed with ultrasound, treated with elective cholecystectomy if symptomatic, and if the patient refuses surgery, you can also give ursodeoxycholic acid as medical treatment, but it is not curative, okay. It is just going to relieve the symptoms. And the 5 F's are female, fat, fertile, faulty, and fair, okay. So fair means it is going to affect the white populations more. And also in cholesterol stones there is decrease of phosphatidylcholine, okay. So what is the function of phosphatidylcholine? Phosphatidylcholine used to make cholesterol soluble into the bile, so it can get excreted from the gallbladder. But as now phosphatidylcholine decreases, the cholesterol is not going to get soluble into the bile. And how does estrogen affects the cholesterol stone formation? So estrogen upregulates the lipoprotein lipase receptors. Okay, so that is going to cause increased cholesterol formation. Also, we talked about fibrates, that it decreases cholesterol 7 alpha hydroxylase enzyme, so that is going to cause decreased cholesterol metabolism and increase in cholesterol concentration. There is another drug from the class bile acid resins, which is lipid lowering agent, cholestyramine. So cholestyramine is a bile acid resin, so that reduces the reabsorption of bile from the intestine by binding the bile, so that it reduces its uptake into blood. Hence, the cholesterol already present in the gallbladder is going to form cholesterol stones. So the cholesterol in the gallbladder was waiting for the bile to come back from the intestine through the enterohepatic circulation and into the gallbladder. But due to cholestyramine, the bile is not able to come back from intestine to the gallbladder, and so the cholesterol that was waiting for the bile now precipitates and into the cholesterol stones. So in both of these cases, there is not enough bile. Okay, in first case there is not enough bile for cholesterol, and in the other case, in chronic hemolysis and infection case, there is not enough bile for unconjugated bilirubin to get solubilized. Okay. Bile increase in both of these cases. Now, biliary colic, it is associated with nausea, vomiting, and dull right upper quadrant pain, and neurohormonal activation, example by CCK after a fatty meal. It is due to cholecystokinin after a fatty meal. This which triggers contraction of the gallbladder, forcing the stone into cystic duct. Labs are normal, and ultrasound may show cholelithiasis. Okay, so the most important point is that the biliary colic is due to cholecystokinin hormone, right? And cholelithiasis is presence of gallstones in common bile duct, often leading to elevated ALP, GGT, direct bilirubin, and or AST or ALT because of backflow pressure into hepatocytes. Now, cholecystitis, it is the acute or chronic inflammation of the gallbladder. So there are two types of cholecystitis. The first is calculous and second is acalculous. So on calculous cholecystitis, the most common type, it is due to the gallstone infection in the cystic duct, resulting in inflammation and gallbladder wall thickening. It can produce secondary infection. So here you can see there is thickened wall. Okay, the wall has thickened. There is gallstone with its acoustic shadow. Gallstone on USG is diagnosed by its acoustic shadow, presence of acoustic shadow. And then there's acalculous cholecystitis due to gallbladder stasis. There is no stones involved here, or hypoperfusion or infection, CMV, seen in critically ill patients, mostly in ICU, burns patient, sepsis patient, all of them. Okay. Because of hypoperfusion or infection, there is gallbladder stasis, is going to cause cholecystitis, and there is no stones found in ultrasound. So Murphy sign is very specific for cholecystitis. Inspiratory arrest on right upper quadrant, palpation due to pain. Pain may radiate to right shoulder due to irritation of the phrenic nerve. Increased ALP if bile duct becomes involved. Acute cholangitis. So when cholecystitis gets converted into cholangitis, there is going to be increased ALP. And it is diagnosed with ultrasound or cholecystography. There is more specific. Failure to visualize gallbladder on HIDA scan suggests obstruction because there is gallbladder stasis. So the movement within the gallbladder of the contrast fluid is not much. So there is failure to visualize gallbladder. Okay. It can suggest obstruction because the contrast cannot go inside the gallbladder because of the obstruction. Okay. Gallstone ileus is fistula between the gallbladder and the GI tract. Stones enter the GI lumen, obstructs at ileocecal valve, narrowest point, and can see air in the biliary tree, that is pneumobilia. It consists of regular striate, radiographic findings of pneumobilia, small bowel obstruction, and gallstones. That is found in the iliac fossa. So remember that the gallstone ileus is not caused by gallstone traveling from gallbladder cystic duct, then common bile duct, and then into intestine, but it is due to a fistula formation between the gallbladder and GI tract directly. So it bypasses the common bile duct and cystic duct and all that. Okay, it directly lines up in the ileocecal junction. And whenever there is cholestasis or obstruction or anything like that, wherever there is stasis, you can see bile pigments, that is sludge, and green brown plugs. In dilated bile canaliculi. So that indicates cholestasis. Now porcelain gallbladder, it is calcified gallbladder due to chronic cholecystitis, usually found incidentally on imaging, and treatment is prophylactic cholecystectomy, generally recommended due to increased risk of gallbladder cancer. Okay, it may be due to chronic cholecystitis. Okay. So this is the calcified wall seen on X-ray, and we have to do prophylactic cholecystectomy because it can cause gallbladder cancer. Acute cholangitis, and why is there calcification of the gallbladder wall? Because of chronic inflammation. Okay. Dystrophic calcification, it is called dystrophic calcification. And last is acute cholangitis. It is also called ascending cholangitis, infection of biliary tree, usually due to obstruction that leads to stasis and bacterial overgrowth. Okay. And where is that obstruction? That obstruction is in the common bile duct. So if this is the cystic duct, this is the common hepatic duct, and together they form common bile duct. And here is the pancreas, and this is the intestine, right? So if there is an obstruction somewhere over here, there is going to be stasis all over here, and that is going to cause cholangitis, and the bacteria travels upwards. So that is why it is called ascending cholangitis. So Charcot's triad is jaundice, fever, and right upper quadrant pain. Okay, so all three of them are intermittent. It depends on the movement of the stone. If the stone moves in a certain kind of way that it causes complete obstruction of common bile duct, then the right upper quadrant pain, jaundice, and fever, all of them will rise together. Okay. And Reynolds pentad is Charcot's triad plus altered mental status and shock, it is hypotension. And the most common bacteria involved are E. coli, Klebsiella, and Enterococci, because they form the normal flora of the intestine, right? Now, cholangiocarcinoma. It is the malignant tumor of the bile duct epithelium. Okay, bile duct epithelium. Most common location is convergence of right and left hepatic ducts. Okay, so the convergence is the most common site. Risk factors include primary sclerosing cholangitis. We saw that primary sclerosing cholangitis can cause cholangiocarcinoma, but primary biliary cholangitis is that does not have any malignant potential. It can also be caused by liver fluke infections. Like usually presents late with fatigue. Uh, Usually presents late with fatigue, weight loss, abdominal pain, and jaundice. So, weight loss, abdominal pain, and jaundice. Imaging may show biliary tract obstruction. Okay. If there is biliary tract obstruction, there is going to be increased in ALP and GGT and all that. Okay. There is going to be cholestasis. And histology may show infiltrating neoplastic glands associated with desmoplastic stroma. So it is a adenocarcinoma. So there is going to be hyperchromatic nuclei. In glandular structure, because it is adenocarcinoma. And you have to remember this keyword, that is desmoplastic stroma. Okay, and there is going to be positive CA19-9 as well. Okay, and it looks like tree-like mass rising from the bile ducts, biliary system, and it has Courvoisier's law positive. Where there is palpable gallbladder, and it is non-tender, and there is obstructive jaundice. So it is due to cholangiocarcinoma and any obstruction in the common bile duct. It does not have any gallbladder pathology. Right. And as it is associated with primary sclerosing cholangitis, we also might see beading, as seen in PSC. We might see beading in bile ducts. And the smooth muscle antibody and P-ANCA, not smooth muscle antibody, but P-ANCA are going to be positive. Okay. Right. Now, acute pancreatitis. Acute pancreatitis is the autodigestion of pancreas by the pancreatic enzymes itself. So, pancreas show yellow arrows surrounded by edema, that is red arrows. So, this is the pancreas, and this is the surrounding edema that has formed. Okay, this is spleen. This is the spleen. This is liver. Okay, these are the kidneys. Right. Okay, and the causes are I get shamed. So it stands for idiopathic gallstones, ethanol, trauma, steroids, mumps, autoimmune disease, scorpion sting, hypercalcemia or hypertriglyceridemia, then ERCP procedure, post-ERCP pancreatitis, and drugs. Drugs include sulfur drugs, NRTIs, and protease inhibitors. So diagnosis by two of the three criteria, that is acute epigastric pain, often radiating to the back. Second is increased serum amylase or lipase, and third is characteristic imaging findings. Two of these three criteria should be present to diagnose it as acute pancreatitis. And serum amylase and lipase should be 3 times the upper limit of normal, and lipase is always more specific because amylase is also secreted from the salivary glands, right? And the complications include pseudocyst. That is this pseudocyst is formed with repetitive attacks of acute pancreatitis. It is not caused by chronic pancreatitis, right? And pseudocyst is lined by granulation tissue, not epithelium. And abscess, necrosis, hemorrhage, infection, organ failure, that is acute lung injury, ARDS, shock, renal failure, hypocalcemia, and hypocalcemia. It is due to the precipitation of calcium soaps. There is saponification occurring that uses up all of the calcium. Okay, so what is the reason that alcohol causes acute pancreatitis? So alcohol, first of all, constricts the sphincter of ODI. Second, it causes stasis of pancreatic enzymes. Right. Okay, so there is leakage of pancreatic enzymes in acute pancreatitis, right? There is autodigestion of pancreas by pancreatic enzymes, mainly trypsin. So it will cause autodigestion and destruction wherever it goes. Trypsin, wherever it comes in contact with any of the structures, it is going to digest it or destroy it. So if it is coming in contact with the pancreas itself, as a form of complication, it may form liquefactive necrosis, okay, of pancreatic tissue, but of the peripancreatic fat, it will cause fat necrosis of peripancreatic fat, and it is called saponification. And that uses up all of the calcium, which causes hypocalcemia. And if these enzymes are secreted into the circulation, right, and if it reaches the lungs, it is going to cause ARDS, because enzymes destroy the alveolar capillary network. And if it is in circulation and it destroys the coagulation factor, it is going to cause DIC, because of destruction of coagulation factors. Right. And whenever there is hypocalcemia associated with acute pancreatitis, that suggests poor prognosis. Okay. Now, chronic pancreatitis. It is chronic inflammation, atrophy, and calcification of the pancreas. So the major risk factors include alcohol use disorder and genetic predisposition, that is due to cystic fibrosis. And and also there is something called some mutations involving trypsin. So that in that mutation, the trypsin is not degraded. Okay, so it stays activated, right? So if the trypsin stays activated for much longer time, it is going to cause recurrent episodes of pancreatitis. Okay, these are the two causes. The first is cystic fibrosis, and the second is including the trypsin mutation. I think it is a SPINK1 mutation or TRSS1 or something like that gene mutation. Okay, that causes pancreatitis. Not TRSS1 but PRSS1, SPINK1 and PRSS1 mutation. They may cause hereditary pancreatitis. Okay, and cystic fibrosis also causes recurrent pancreatitis. Complications include pancreatic insufficiency. So pancreatic insufficiency means that there is decreased production of all the enzymes from the pancreas. For example, insulin insufficiency, that is going to cause diabetes mellitus. Then there's trypsin deficiency. So its deficiency is going to cause deficiency of other digestive enzymes from pancreas. So that is eventually going to lead in malabsorption, fat malabsorption mostly. Yeah, so pancreatic insufficiency, typically when less than 10% of pancreatic function, may manifest with steatorrhea, that is due to fat malabsorption, and fat soluble vitamin deficiency, that is EDEK, and diabetes mellitus. So amylase and lipase may or may not be elevated, because almost always elevated in acute pancreatitis, because just like chronic hepatitis, where there is reduced ALT AST because of death of hepatocytes, in chronic pancreatitis also there is death of pancreatic cells, right? So eventually in chronic cases, the amylase and lipase may not be elevated as much as in the acute pancreatitis. And as you can see in this picture, these white structures are the calcification that has occurred in the chronic pancreatitis. Okay, and it's dystrophic calcification. Now there was this pathology given in the UWorld section. I am going to just write it down here. So the initial stages of pathogenesis of acute pancreatitis starts with one of the two reasons. The first reason is either there is ductal obstruction, that is because of stones, tumors, and contraction of sphincter of ODI by alcohol. And the second is it can be direct parenchymal injury, like again in alcohol, in drugs, after ERCP, or increased triglycerides. So ductal obstruction will cause reduced blood flow to the pancreas, that is going to cause ischemia, right? And direct parenchymal injury is going to directly cause acinar cell dysfunction, and ischemia also leads to acinar cell dysfunction. So now there is intraacinar trypsin activation, because the activated trypsin is not able to leave the pancreas, right, because of the acinar cell dysfunction. Okay, so now trypsin activates other pancreatic enzymes. So those enzymes are going to cause pancreatic cell inflammation or destruction. It is also going to cause fat necrosis around it, that is satonification, and it is also going to cause vascular damage around pancreas, that is going to cause hemorrhage. And there are some signs associated with acute pancreatitis. The first is, it is all due to the hemorrhage, intraperitoneal or retroperitoneal hemorrhage. So the first sign is Cullen's sign. It is discolor around umbilicus. Second is Gray-Turner sign. It is discoloration around the flanks. Third is Fox sign, that is around inguinal region. And the last is Bryant sign, that is around scrotal area. Also there is a string of beads or chain of lakes appearance in chronic pancreatitis. Now, pancreatic duct adenocarcinoma, it occurs due to KRAS mutation, because first adenoma is formed and then carcinoma is formed. So that AK53 pathway, if you remember, there is APC mutation, then there is KRAS mutation, then there's P53 mutation. So there is KRAS activation mutation. There is loss of APC mutation, activation of KRAS mutation, and loss of TP53 mutation in adenocarcinoma sequence. And it is a very aggressive tumor arising from the pancreatic ducts, not pancreatic parenchyma or acinar cells. It is from the ducts. So disorganized glandular structure with cellular infiltration. Okay. So here you can see glandular structures. These are glandular structures. Okay, that is with cellular infiltration, often metastatic at presentation with average survival of 1 year after diagnosis. Tumors more common in pancreatic head, so that it leads to obstructive jaundice because of obstruction of common bile duct. It is associated with CA19-9 tumor marker, and also CEA, that is less specific. CEA is more specific for colorectal carcinoma, and CA19-9 is also found there. And the biggest risk factor is tobacco smoking, and only tobacco smoking, not alcohol. You may think that alcohol causes acute pancreatitis so easily and chronic pancreatitis so easily, so it may also cause pancreatic adenocarcinoma, but that's not the case. Pancreatic carcinoma is due to tobacco smoking only. So alcohol may cause chronic pancreatitis, and that chronic pancreatitis may lead to pancreatic cancer over the period of time, but alcohol and pancreatic cancers are not related directly. So risk factors are tobacco smoking, chronic pancreatitis, especially after more than 20 years of chronic pancreatitis, diabetes, and age more than 50. So it often presents with abdominal pain radiating to the back. That is the characteristic of pancreatic pain. It radiates to the back. There is weight loss due to malabsorption and anorexia. There is migratory thrombophlebitis, that is redness and tenderness on palpation of extremities, that is Trozo syndrome. And there would be thin erythematous lines wherever the veins are affected in the extremities. So the question stem may say there is erythematous line on the right forearm one day, and few days later in the same kind of lines develop in the legs. So that is migratory thrombophlebitis. Okay. And migratory thrombophlebitis always has some kind of abdominal malignancy associated with it. Either it may be pancreatic adenocarcinoma, or it may also be gastric adenocarcinoma. Okay, so skin is called the mirror of internal disease, right? Whichever internal disease may there be, it mirrors as skin manifestation. Okay, and there's obstructive jaundice with palpable and non-tender gallbladder, that is Courvoisier's sign. Here you can see this is the pancreas, this is the head, and there's adenocarcinoma in the head. Which are these other organs? Like this is liver, this is spleen, this I think is the stomach with gas bubble and food. This is intestine, lumen. Okay, and this is aorta, abdominal aorta. This is IVC, I think. Okay, and in pancreatic insufficiency, there will if we perform xylose test, it's going to be absolutely normal. right? Because D-xylose is a monosaccharide absorbed from the intestinal wall, so there is no effect on intestinal wall of pancreatic insufficiency. And the curative is surgery called Whipple's procedure, where the jejunum is taken and it is joined to hepatic duct, to pancreatic duct, and to duodenum. So that is hepatojejunostomy, pancreatic jejunostomy, and duodenojejunostomy. Okay, so that will also lead to iron deficiency, because the duodenal part is resected and then it is joined with jejunum, so it is going to cause iron deficiency. So now gastrointestinal pharmacology. So how does the acid secretion occurs, and how does all of the antacid drugs inhibit that acid secretion? So let's see the physiology first. So the vagus nerve, everything starts from the vagus nerve. Vagus nerve stimulates the acetylcholine and it activates GRP, gastrin releasing peptide. So acetylcholine directly acts on the M3 receptors of the parietal cell. Okay. And gastrin releasing peptide, it is a gastrin releasing peptide, so it is going to release gastrins from the G cells. It is going to stimulate G cells to secrete gastrin, and that gastrin that gastrin is going to stimulate CCK-B receptor, that is cholecystokinin B receptor. Okay, and both of them together is going to act through GQ receptors. Okay, and if you remember the in cardiac pharmacology too, we discussed that GQ acts through IP3 and calcium channels. It stimulates IP3 and calcium channels, and that is going to stimulate the hydrogen potassium ATPase pump. Right. But now gastrin also stimulates the ECL cells. Okay, so this is the direct pathway through which gastrin stimulates acid secretion, right? Through CCK-B receptors, through GQ, through IP3 calcium channels, right? Sorry, not channels, but secondary messenger, that is IP3 and calcium. But this is the minor pathway. As we discussed earlier, that gastrin stimulates ECL pathway, and ECL secretes histamine, which acts on the H2 receptors in the stomach wall. Okay, and that H2 receptor through GS stimulates CAMP. In cardiac pharmacology, we also discussed that GS acts through CAMP. Okay, and that CAMP is going to stimulate H plus K plus ATPase pump, and this happens in parietal cell. This all happens in parietal cell. Okay, now we also discussed that GI is always inhibitory, I for inhibitory. So what are the two things you can think of that are inhibitory towards acid secretion? So the first is somatostatin, right? So somatostatin has its own receptor. Okay, so that activates GI, that is going to inhibit the CAMP. And also there's prostaglandins, which acts through GI the same way as somatostatin does, and is going to inhibit CAMP, right? And once this pump is activated, the H plus K plus pump is activated, what happens is H plus is secreted from parietal cell, right? So H plus is the acid, it is secreted into the lumen. So here is the H plus being secreted into the lumen, and in turn the potassium comes inside the parietal cells. Okay, this is the parietal cell going inside, and it will use an ATP. So where is this H plus coming from in parietal cells that is being secreted into the lumen? It is coming from carbonic anhydrase. Okay, so there is carbon dioxide and H2O. It is going to form H2CO3, that is carbonic acid, through enzyme carbonic anhydrase. And on dissociation of carbonic acid, we have bicarbonate ion and hydrogen ion. So bicarbonate ion goes into the blood. Okay, so that is called alkaline tide. So there is increased blood pH because bicarbonate is going into the blood after gastric acid secretion. So there is decreased pH in stomach, but because bicarbonate is secreted in the blood, there is alkaline tide in blood circulation. That is called alkaline tide, right? And there's also chloride channels present here. So now let's discuss the drugs that affects this physiology. So the first drug is proton pump inhibitors and antacids. Okay. And first let's discuss proton pump inhibitors and H2 blockers, because the proton pump inhibitor is the most powerful antacid drug, most powerful drug to inhibit acid secretion. Okay, so the name itself suggests that it is a proton pump inhibitor. So it inhibits the final pathway, that is this pump, hydrogen potassium pump. It inhibits that. And H2 blockers inhibit this histamine acting on the H2 receptors. Okay, because the major pathway is through this histamine pathway, ECL cells and histamine pathway, right? So H2 blockers inhibits the histamine acting on H2 blockers. So there will be no GS stimulation, there will be no CAMP, and there will be no activation of H plus K plus ATPase pump. Okay, so those are the two drugs. The third is antacids. Okay, antacids just directly neutralize the effect of hydrogen ion. So it directly neutralizes the acid in the stomach. Then there's atropine, which inhibits acetylcholine binding on M3 receptors. That is also going to inhibit potassium pump, hydrogen potassium pump. Yeah. Now then there's sucralfate and bismuth and misoprostol, which forms a coating on gastric mucosa. Okay, a protective coating on gastric mucosa so that acid cannot act on it and erode it. Okay. But misoprostol is now obsolete. It was used before the coming of proton pump inhibitors, but as soon as proton pump inhibitors came, the misoprostol was not used, and it will mostly be the wrong answer in all of the questions. Okay. And this GRP is secreted from the nerve endings of the vagus nerve. Okay. Now H2 blockers, that is cimetidine, famotidine and nizatidine. It directly blocks the histamine acting on the H2 blockers. Okay, so this is a reversible block of histamine H2 receptors. There is going to be decreased acid production. Used in peptic ulcer, gastritis and mild esophageal reflux. This is the second line of drugs for all of these conditions. The first line is proton pump inhibitors always. The adverse effect, I've used sketchy for these pharmacology section. Okay, so I recommend you guys to watch sketchy videos. They are very short, and there are just 3 or 4 videos regarding gastrointestinal pharmacology. And there's cimetidine. Cimetidine has the most number of adverse effect. It is a potent inhibitor of cytochrome P450. That is, so it has multiple drug interactions. It also has anti-androgenic effects like prolactin release, gynecomastia and impotence. And then there's decreased libido in males. It can cross blood-brain barrier, causing confusion, dizziness and headaches. Okay, and it can also cross placenta and affect the fetus. Cimetidine decreases renal excretion of creatinine. Okay, so can cause acute renal failure, and other H2 blockers are relatively free of these side effects. Okay. And why is H2 blockers not used before proton pump inhibitors? Because it has a slower onset of action, and the tachyphylaxis is very common. And cimetidine blocks conversion of dihydrotestosterone into testosterone. Okay. So therefore dihydrotestosterone gets converted into estrogen, causing all of these effects like prolactin release, gynecomastia, impotence, decreased libido, all of that. Okay, and now proton pump inhibitors, they are omeprazole, lansoprazole, esomeprazole, antiprazole, dexlansoprazole. The mechanism is it irreversibly inhibits hydrogen potassium pump, okay, in the stomach parietal cells. The clinical use is same as H2 blockers like peptic ulcer, gastritis, esophageal reflux. Zollinger-Ellison syndrome is added here, and it is component of therapy for H. pylori. So the other drugs in H. pylori are mostly antibiotics, okay, and stress ulcer prophylaxis. So adverse effects include increased risk of C. difficile infection. Okay, why C. difficile? We already discussed this because proton pump inhibitors provide alkaline environment, right? So both so all of the other normal gut flora is going to decrease, okay, and that will allow the Clostridium difficile bacteria to proliferate inside the gut. Okay. There's pneumonia, there's acute interstitial nephritis, there's vitamin B12 malabsorption. Okay. Vitamin B12 malabsorption, because as it is affecting the parietal cells, it may also, I guess it may also lead to decreased production of intrinsic factor that will lead to vitamin B12 malabsorption. There is decreased serum magnesium, calcium and iron as well absorption, which potentially leading to increased fracture risk in older adults. Okay. Because all of these iron, magnesium, calcium and iron, they require acidic environment for their absorption. And there's this important adverse effect which is not given here, that is rebound acid hyper secretion. That occurs when PPIs are withdrawn suddenly after taking them for a chronic period of time. So whenever the PPIs are administered, there is going to be increase in pH, right? And we all know that alkalinization or increased pH leads to gastrin secretion. And if gastrin is secreted, on what cells gastrin do act? Gastrin acts on ECL cells, right? Gastrin is acting on the ECL cells, so that is going to cause ECL hypertrophy or increased in activity of ECL cells, and also parietal cells, because gastrin also directly stimulates parietal cells, although it is a minor pathway, but both of these cells are going to be hypertrophied. So now as both of these cells are hypertrophied, now if the PPIs are withdrawn very suddenly, there is no inhibition over these hypertrophied cells now, right? Because as we are giving proton pump inhibitors, they were inhibiting these hypertrophied ECL and hypertrophied parietal cells. But as we have withdrawn the proton pump inhibitors, there is not going to be any inhibition over these hypertrophied cells. So that is going to cause increased amount of acid secretion compared to normal or pre-treatment acid secretion. Right. So proton pump inhibitors should always be withdrawn slowly. Okay, now antacids, it can affect absorption, bioavailability, or urinary excretion of other drugs by altering gastric and urinary pH or by delaying gastric emptying. All can cause hypokalemia. So as we talked about, it directly inhibits the acid in gut. It can affect absorption, bioavailability, or urinary excretion of other drugs by altering gastric and urinary pH, because all of the drugs, all electrolytes require different environments. Some may require iron, some may require acidic environment, some may require alkaline environment. So antacids affects them all, and it causes hypokalemia. And aluminium hydroxide is the first one. So these are the adverse effect, that is CHOPS, constipation, hypophosphatemia, osteodystrophy, proximal muscle weakness, and seizures. And second is calcium carbonate. So that causes hypercalcemia because it has calcium in it. There is milk alkali syndrome, there is rebound acid hypersecretion with calcium carbonate, and it can chelate and decrease the effectiveness of other drugs like tetracycline. The third is magnesium hydroxide. It causes diarrhea opposite to aluminum hydroxide. It causes hyporeflexia, hypotension, and cardiac arrest. Okay. There's this mnemonic that magnesium must go to the bathroom because it causes diarrhea. Okay. And calcium carbonate also can cause erosive esophagitis. And aluminum hydroxide and magnesium hydroxide are frequently administered together, okay, because they cross each other's side effects out. Like aluminum hydroxide causes constipation, so magnesium hydroxide will cause diarrhea. So they cross each other's effects. Okay, so side effects of aluminum hydroxide is CHOPS, constipation, hypophosphatemia, osteodystrophy, proximal muscle weakness, and seizures. And calcium carbonate has hypercalcemia, that is milk alkali syndrome, because they are alkali salts, and rebound acid hypersecretion. And magnesium hydroxide, the important adverse effect is diarrhea. Now, bismuth and sucralfate, they bind to the ulcer base, providing physical protection and allowing the bicarbonate secretion to re-establish pH gradient in the mucosal layer. Okay. So they don't let the acid come in contact with the ulcer base, but at the same time they allow the bicarbonate secretion into the gut, so it can neutralize the pH of the gut. And sucralfate requires acidic environment, not given with PPIs and H2 blockers, because PPI and H2 blockers both are going to form an alkaline environment, so it will render the sucralfate inactivate. And the clinical use of both of these drugs are in increased ulcer to increase the ulcer healing in traveler's diarrhea. Okay, we are going to talk about traveler's diarrhea in some time. And bismuth also used in quadruple therapy for H. pylori. And misoprostol is a PGE1 analog. It increases the production and secretion of gastric mucus barrier and decrease acid production. So it increases the gastric mucus barrier and decrease the acid. Then prevention of NSAID induced peptic ulcer, because NSAIDs block PGE1 production. Okay, so we have to give PGE1 analog so the mucus barrier stays on. And also used off label for induction of labor. Misoprostol cream is used in labor rooms. Okay, an adverse effect is diarrhea, because there's increased mucus production. and contraindicated in patient in childbearing potential because it is abortifacient. It can cause abortion. Okay. Now octreotide, it is a long-acting somatostatin analog. It inhibits secretion of various splanchnic vasodilatory hormones, okay, like nitric oxide, and clinical use in acute variceal bleeds, acromegaly, VIPoma, and carcinoid tumors. The most important one is in acute variceal bleeding, okay, due to portal hypertension. Its adverse effect is nausea, cramps, steatorrhea, increased risk of cholelithiasis due to CCK inhibition. Okay, it inhibits the cholecystokinin, so there can be stone formation in gallbladder. Now, sulfasalazine is a combination of sulfapyridine, that is antibacterial drug, and 5-amino salicylic acid, that is anti-inflammatory drug. Okay, that is activated by colonic bacteria and used in ulcerative colitis and Crohn's disease. In Crohn's disease, wherever there is colitis, okay, because it can reduce infection as well as inflammation. And the adverse effect is malaise, nausea, sulfonamide toxicity, and reversible oligospermia. Loperamide is an important drug to remember, that it is an agonist at mu-opioid receptors, okay, and it slows gut motility, and it has poor CNS penetration, so it has low addictive potential. It is used in diarrhea, and adverse effects are constipation and nausea. So it reduces the colonic transit time. So food stays in a particular segment of the intestine for a longer period of time, so that enables increased water absorption from it. Okay, and if it is an agonist at opioid receptors, it is going to inhibit the release of acetylcholine from the wall. Okay, and it acts on mesenteric plexus, because mesenteric plexus is responsible for the motility of the intestinal wall, right? So it inhibits the acetylcholine release from the mesenteric plexus. Right. And also there's other antidiarrheal drug called bismuth subsalicylate that stimulates intestinal absorption of fluid. Okay, and then so Pepto-Bismol, more commonly Pepto-Bismol is the brand name for bismuth subsalicylate. That is the most popular drug for diarrhea, and loperamide is sold under the brand name of Imodium, right? And loperamide has poor CNS penetration, but the other drug that is diphenoxylate, that has CNS penetration, so it can cross blood-brain barrier, and it can cause addiction. Okay. Now the antiemetics, they all act centrally in chemoreceptor trigger zone of area postrema. So the first is ondansetron and granisetron. So they are 5-HT3 receptor antagonist. Also act peripherally by decreasing vagal stimulation, and they are used in nausea and vomiting after chemotherapy, radiotherapy, or surgery, and also in traveler's diarrhea. Adverse effects include headache, constipation, QT interval prolongation, and serotonin syndrome. Serotonin syndrome is the symptoms of serotonin syndrome are rigidness, tremors, hyperthermia, and confusion. Okay, and what is traveler's diarrhea? Traveler's diarrhea is not the same as motion sickness. Okay. Traveler's diarrhea is nausea, vomiting, and watery diarrhea, and caused by E. coli, rotavirus, and cryptosporidium. That cryptosporidium needs immunosuppressed patients like of HIV. And the treatment is 5-HT3 antagonists. I recommend you watching sketchy videos to get to memorize all of these uses and adverse effects. Otherwise, you are going to forget the adverse effects in a few time. So, yeah, do watch sketchy videos. And the second is prochlorperazine and metoclopramide. They are dopamine 2 receptors, agonists, antagonists, and metoclopramide also causes increased gastric emptying and increased lower esophageal sphincter tone, and used in nausea, vomiting, and metoclopramide is also used in gastroparesis, that is in diabetic patients, and in persistent GERD. It has a wide range of adverse effects, starting from extrapyramidal symptoms, that is there are dystonia and akathisia and all that, to hyperprolactinemia, anxiety, drowsiness, restlessness, depression, GI distress, also neuromalignant syndrome, okay, also tardive dyskinesia, neuroleptic malignant syndrome. I have to look it up. Okay, so in neuroleptic malignant syndrome, there is mental status change, there is rigidity, there is fever, and there's dysautonomia. Right. And it is very similar to the serotonin syndrome, but serotonin syndrome symptoms are seen within the 24 hours of starting treatment, and neuroleptic malignant syndrome is a slower onset, that is 1 to 2 weeks after starting therapy. Okay, and the rigidity is very severe in neuroleptic malignant syndrome, and there is also fever and increased creatinine kinase and all that in neuroleptic malignant syndrome. Okay, serotonin syndrome is a little milder than neuroleptic malignant syndrome. And there's aprepitant and fosaprepitant, it is NK1 receptor antagonist, okay, the neurokinin 1 receptor antagonist, okay, and NK1 receptor is a substance P receptor, so substance P activates NK1 receptors on area prostrema. And we didn't discuss the physiology of the 5-HT3 receptors acting on vagal stimulation and all that, right? So whenever there is distension due to overeating, or there is any inflammation, or there is chemotherapy, all of these three things are going to release serotonin. So serotonin acts on 5-HT3 receptors that are present on the vagal afferents. vagal afferents nerve endings, okay, of the vagus nerve, and that leads to nucleus tractus solitarius in brain, and that activates the vomiting center, which is adjacent to the nucleus tractus solitarius. That is the physiology behind this. Okay, and then there's another two drugs that are antiemetics. Okay, there's M1 and there's H1 antagonist. So M1 antagonist is scopolamine and H1 is diphenhydramine. They both are used in motion sickness. They are the best drugs for motion sickness, and also hyperemesis gravidarum in pregnancy. Hyperemesis gravidarum is prolonged vomiting in the second trimester of the pregnancy. The vomiting is normal in the first trimester of the pregnancy. So this includes vestibular nausea. These both are caused by activation of the vestibular system through cranial nerve 8, that is vestibular cochlear nerve. And you have to just remember the first line of drugs for all of them, mostly chemotherapy. It is 5-HT3 antagonist. For gastroparesis, it is prochlorperazine and metoclopramide that are dopamine and receptor antagonist. Okay. And for motion sickness in hyperemesis gravidarum, it is M1 and H1 antagonist. Now, orlistat, it inhibits gastric and pancreatic lipase, so it causes decreased breakdown and absorption of dietary fats, right? Taken with fat containing meals, and it is solely used for weight loss. The adverse effects are abdominal pain, flatulence, bowel urgency and frequent bowel movements, steatorrhea because of fat malabsorption, and decreased absorption of fat soluble vitamins A, D, E, K. Now the last topic, that is anti-constipation drugs. So the first are bulk forming laxatives. Now let's start from osmotic laxatives. Okay, that includes lactulose, magnesium citrate, magnesium hydroxide, and PEG, that is polyethylene glycol. They all act by providing the osmotic load that can draw water into the GI lumen. And lactulose also treats hepatic encephalopathy because gut microbiota degrades lactulose into metabolites, that is lactic acid and acetic acid, which will provide hydrogen ion to bind to ammonia to convert itself into ammonium ion, that is water soluble and can be easily excreted with the stool. Okay. That promote nitrogen, lactic acid, acetic acid, that promote nitrogen excretion as ammonium ion by trapping it in colon. Okay, and its side effects, so it is anti-constipation drugs, so its adverse effects will be diarrhea and dehydration, right? Dehydration because of diarrhea, and it may be used by patients with bulimia nervosa. Okay, in order to they think that they want to excrete all the food that they have eat in order to reduce the weight. Okay, so it is used in bulimia patients, and this is the same pathology behind lactose intolerance diarrhea. So lactose intolerance, lactose is not being digested, not being absorbed, so lactose draws water into the gut lumen. Okay. Now the bulk forming laxatives. So osmotic laxative is the most important. The bulk forming laxatives, it is methyl cellulose and psyllium. There are soluble fibers that draw water into the gut lumen. forming viscous liquid that promotes peristalsis, and it binds the luminal water. Adverse effect is bloating. It forms the bulk of the stool by binding to the luminal water. Okay. Now there's stimulant laxatives, that is bisacodyl and senna. They activate the enteric nervous system, so that leads to colonic contraction. Okay, so loperamide used to antagonize the mu opioid receptors, right? Not antagonize but agonize. That was a mu opioid receptor agonize, so that was slowing down the gut motility, right? But the stimulant laxatives bisacodyl and senna are quite the opposite of it. So it is going to stimulate the enteric nerve to contract more, so colonic contraction is going to increase, resolving the constipation. And the side effect of senna is melanosis coli, that is hyper pigmentation, that is brown pigmentation in the back, not in the back but in colon. Okay. Then there's docusate, which is it is a surfactant that decreases stool surface tension, so it allows water entry into the stool. And there's lubiprostone, that is chloride channel activator, so it is going to increase intestinal fluid secretions as well, because along with chloride there is going to be water secretion also. Another two drugs I want you to know is naloxone and methyl naltrexone. They are opposite of the loperamide. They are mu opioid antagonist. Okay, so they are used in constipation. And what is the key difference between both of these drugs is naloxone crosses blood-brain barrier, so that can cause withdrawal symptoms whenever it is withdrawn. And methyl naltrexone is a safer drug. It does not cross blood-brain barrier, so no withdrawal symptoms. Right. So we are done with the gastrointestinal symptoms. Okay. Thank you.